Глубоко уважаемые коллеги, мы начинаем сессию BRICS. Dear colleagues, we started BRICS Spine Meeting. Это уже третье у нас получается такое мероприятие. Первое было в Бразилии, два было в России. К нам приехал вот единственный, так скажем, представитель из Бразилии, Рената Трешейра. И скажет нам несколько слов. Can you say some words for opening BRICS meeting?
I'd like to thank for the invitation to be here in this meeting, and say that I'm very honored. The first BRIC meeting took place in Rio in 2017. With a great interest of Sergey, who helped in that moment. He was a person that in the early moment when we talked the first time, he got very interested, and we also had imagined a good future for sharing experience. The second one, BRICS happened in Moscow in 2019, and therefore this is the third edition. I expect that going to happen another ones, maybe next could be in India, or anyway, I would say that they're going to have in Brazil in 2024, and you are all invited to come. I expect that can be a great event, and we would happen together with Brazilian Spine Meeting, probably a very Latin American meeting together at this moment. Thank you.
Несколько слов скажет наш президент Ассоциации спинальных хирургов России, член-корреспондент Академии наук Николай Александрович Коновалов.
Я очень рад всех вас видеть. Я думаю, что по мере этой секции присоединится больше и больше людей. Тем более мы имеем онлайн-трансляцию, причем эта онлайн-трансляция, она идет на все страны БРИКС. Это действительно международное мероприятие. Сейчас это очень важно в том, что мы видим, что наши международные связи, они не закрылись, они продолжаются быть стабильными, развиваются. Несмотря на некоторые проблемы с перемещением, тем не менее, сегодня большое количество выдающихся ученых, спинальных хирургов из стран БРИКС примут участие в этой сессии. Она пройдет весь день. Я думаю, сегодня вы услышите много нового, интересного, будут актуальные дискуссии. Хочется пожелать всем терпения в этот субботний день. Все равно самые выдержанные, кто пришли уже в зал, я думаю, будет больше людей. И хотелось пожелать, чтобы все это прошло легко, позитивно и информативно. Хорошего всем работы. Дмитрий Александрович Пташников.
Уже сказано немало слов позитивных в адрес нашего сегодняшнего конгресса. Хочется присоединиться ко всем этим словам. И на самом деле поблагодарить организаторов за то, что этот конгресс состоялся. И состоялся не просто как какая-то очередная вещь для заполнения программы. То есть и очень интересные темы подняты, очень хороший состав участников, и подкупает то, что сегодня суббота, в общем-то, в зале присутствуют ведущие специалисты, эксперты нашей страны для того, чтобы поделиться своими знаниями, опытом. И я надеюсь, что сегодня будет подключаться значительное количество наших молодых специалистов для того, чтобы этот опыт перенять. И я хочу всем пожелать хорошего, полезного времяпровождения в этот субботний день.
Мы тогда начинаем. Первый будет выступать Игорь Басанкин. Поскольку мы на англоязычную аудиторию рассчитаны без отчества. First, we are starting, and first presentation will be transpedicular decompression during A1 compression fractures.
Добрый день, глубоко уважаемый президиум, дорогие коллеги. Ну, во-первых, слова признательности за предоставленную возможность выступить здесь, на этом мероприятии. И мой доклад, как вы видите, он будет посвящен лечению повреждений позвонка типа А1. Это компрессионные переломы, и все мы прекрасно знаем, как листать. Вот. Все мы прекрасно знаем, что это повреждения, которые проявляются компрессией одной замыкательной пластинки, чаще всего верхней, при сохранности задней стенки позвонка. И встречаются они порядка 7% от всех повреждений позвоночника, при этом сопровождаются они достаточно серьезными болевыми синдромами и в некоторых случаях могут вызывать локальную деформацию, локальную сегментарную деформацию. И если говорить о механизме формирования боли при компрессионном переломе, то это в первую очередь компрессия и окклюзия после повреждения позвонка. Это компрессия и окклюзия мелких вен в системе базовертебральной вены. И, как следствие, это повышение внутрикостного давления, которое, в свою очередь, ведет к появлению внутрикостного отека, ощелачиванию крови и повышению уровня цитокинов, что, в свою очередь, стимулирует ноцицептивные рецепторы и воздействует на базовертебральный нерв, вызывая эту боль. Невозможно понять этот механизм без отсылки к некоторым анатомическим аспектам. И все мы прекрасно знаем, что мелкие вены, они сгруппированы в такие многослойные венозные сплетения, которые разделены между собой костными трабекулами. Вот эти мелкие вены сливаются в более крупные сосуды, у которых есть два пути оттока. Один – это на периферию через кортикальный слой, и второй – это сливание в горизонтально идущую базовертебральную вену, которая дренирует венозную кровь непосредственно в переднее эпидуральное пространство. Если посмотреть на артериальную сеть, а ее нельзя не брать во внимание, то здесь структура распространения, направление распространения сосудов совсем другая. Здесь нет какого-то центрального магистрального сосуда. Это такое радиальное вхождение артериол в тело позвонка. И даже в случае повреждения компрессионного мы видим, что питание этого позвонка, артериальное питание, оно никак не нарушается. При этом мы должны понимать, что стенка артериола, она гораздо толще, чем стенка венул. И, соответственно, даже костные повреждения не полностью блокируют артериальный приток крови. Еще один важный компонент анатомии – это базовертебральный нерв, который входит в базовертебральное отверстие и, соответственно, находится в задней, и передней и в средней части позвонка. Итак, что касаемо повреждений типа А1. Все мы знаем, что это не осложненные, что это абсолютно стабильные повреждения, но при всем при этом они достаточно сложны и весьма неоднозначны в выборе хирургической тактики, которая основана как на объективных данных, так, ну и, соответственно, на институциональных особенностях. И методы хирургического лечения, они здесь разноплановые. Это могут использоваться и консервативная терапия, и различные методы цементного укрепления позвонка. В некоторых случаях применяют даже транспедикулярную фиксацию. Но наша идея – это проведение операции так называемой транспедикулярной декомпрессии, которая выполняется на основе перфорации тела позвонка через его ножку, которая приводит к снижению внутрикостного давления или внутрипозвонкового давления, которая меняет кровоснабжение в лучшую сторону этого позвонка, которая достаточно быстро, в течение нескольких часов после процедуры, снижает интенсивность болевого синдрома. При этом, учитывая, что мы не используем цементное укрепление, мы минуем значительное количество осложнений, связанных с введением костного цемента. Вот единственная публикация, которую нам удалось найти на эту тему, это статья наших японских коллег, которые провели лечение 108 пациентов с переломами типа А1, и они разделили их на две группы. Это остеоперфорация или транспедикулярная декомпрессия, 58 человек, и 50 человек с цементным укреплением. При этом авторы показали, что это достаточно эффективное мероприятие, и мы видим на графике, что снижение интенсивности болевого синдрома сопоставимо, хоть ты делаешь вертебропластику, хоть ты делаешь эту декомпрессию в течение 28 дней. Но если мы посмотрим к 90 дням, к 3 месяцам, да, состояние пациентов после остеоперфорации значительно лучше. И важно обратить внимание на таблицу здесь внизу. Из всех представленных осложнений, этих двух методов лечения, они остановились только на двух. Первый из них – это возникновение нового перелома после проведения повреждений. Посмотрите здесь, в группе остеоперфорации их всего 3,7%, а в группе вертебропластики почти 24%. И второе осложнение, которое указали авторы, это прогрессирование потери высоты, ну, так скажем, увеличенный коллапс того позвонка, который возник после остеоперфорации в 22% случаев, но после вертебропластики в 16% случаев, при этом статистически это было недостоверно. Мы представляем результаты лечения 24 пациентов, которые пролечились в нашей клинике с изолированными повреждениями, высоко- и низкоэнергетичными повреждениями типа А1 в грудном поясничном отделе, у которых исходная интенсивность болевого синдрома была более 6 по ВАШ, локальная кифотическая деформация меньше 10 градусов, потеря высоты не более 30%. Для визуализации КТ, МРТ и рентген в разные сроки, клиническая оценка ВАШ, УДИ и клинические наблюдения больше 1 года. Итак, у нас 14 пациентов были с низкоэнергетическими повреждениями, 10 человек с травмой высокой энергии. Возраст 35-70 лет, основная локализация – это грудопоясничный переход. 30% пострадавших госпитализировано у нас в течение первой недели, и остальные 71% в промежуток от 7 до 14 дней. Соотношение мужчин с женщинами 1 к 4. В течение первого года вы видите, что снижение интенсивности болевого синдрома с 7,9 до 2,25, при этом максимальное снижение боли первые 2 суток после процедуры. Изменения по индексу острости от 60 до 13%, ни одного случая кюмелевского спондилита. И вот клинический пример, 52-летний мужчина, повреждение 12-го позвонка, который упал с высоты 2 метров. Достаточно сильно болит спина на 8 баллов, по Т-критерию -2, локальный угол Коба 5,2 градуса. Сама процедура, да, то есть это транспедикулярно по стандартной траектории введение 2 игл Джамшиди, активная декомпрессия крови, вся процедура 30 минут, анализ удаленной крови показывает снижение pH, снижение уровня кальция. Вот КТ-данные через 2 дня, вот на аксиальном срезе видно каналы после проведения игл. Болевой синдром в спине 3 балла, угол Коба 6,4. Месяц после процедуры мы видим изменение сигнала по Т2, мы видим болевой синдром 2 балла, 6 месяцев, спина не болит, при этом хочу отметить, что пациент ходит, двигается активно, гипоинтенсивный сигнал на МРТ, угол Коба 9 градусов, но если обратить внимание вот на место повреждения и контакт со смежным позвонком, то мы видим, что уже у нас формируется здесь такой спонтанный периферический костный блок, спонтанный фьюжн, то есть ускорение регенеративных процессов приводит к более быстрому блокированию. И вот квинтэссенция этих сроков наблюдения, то есть смотрите, после повреждения спина на 8 баллов, 2 дня 3 балла, 1 месяц 2 балла, через 6 месяцев ничего не болит. Если говорить об угле Коба, то есть исходно 5,2 и к 6 месяцев 9,1. Я для сравнения здесь поставил стандартно используемые методики лечения, да, то есть слева это транспедикулярная декомпрессия или остеоперфорация, которую мы разобрали, в центре это консервативное лечение, и последний слайд – это пациент после вертебропластики. Исходно повреждения позвонков сопоставимы, болевой синдром вы сами можете видеть, насколько эффективно снижается в первом случае и сохраняется остаточный болевой синдром при обоих, а нарастание деформации, которая здесь есть, ну, во-первых, она не критична, во-вторых, она в любом случае меньше, чем при этих случаях. Таким образом, транспедикулярная декомпрессия – это простой, эффективный, безопасный метод лечения, при этом который стоит очень мало и является эффективным для лечения этого повреждения. Спасибо.
Да, дискуссия у нас будет через 2 доклада. Следующий доклад Dynamic Correction of the Scoliosis in Adults. Динамическая коррекция сколиоза у взрослых. Сергей Колесов, пожалуйста.
Dear colleagues, dynamic correction scoliosis in adult, it's new technology. And usual clinical scenario for spinal surgeon who operated on idiopathic scoliosis is the treatment of patients with complete growth, moderate curvature, who has radiological indication for surgery, but the disease is asymptomatic. Surgical correction in a patient with complete growth often raises concern about possibility of complication, especially paralysis. Patients who underwent surgical treatment of idiopathic scoliosis at a younger age, as a rule, have fewer fixation levels, less blood loss, shorter surgery time, and fewer complications. Compared with adults who went through the natural history of scoliosis, its progression, and sought treatment later. Also, X-rays correction data are similar, and improvement in the quality of life after surgery is observed in both cohorts. Now we can see evolution of different instrumentation, begin with distractors, Harrington, rods, Catrelli-Basset systems, Zilke, transpedicular correction scoliosis, and anterior correction scoliosis with rigid construction. In Russia, in Russian Federation, at about 2,500 surgeries in scoliosis in adolescents, and about 1,000 surgeries in adult patients. But according to statistics, about 250,000 people have curvature more than 30 degrees. Therefore, potential candidate for correction of scoliosis. Problems with rigid stabilization is adult. It's PJK, DJK, EJK. It's very often from especially adult population. And bone resorption, instability of instrumentation, pseudoarthrosis, broken of metal structures who need revision surgery. And total limitation of mobility, as you can see. And overall complication rate in adult population up of 49%. And the risk of new operation within 6 years after initial operation is 44%. Improve the results of surgical intervention, it's necessary to determine the appropriate time for surgery for patients with spinal deformity in adolescence. Main goals of improving spinal deformity surgery techniques is reducing invasiveness, risk reduction, safety, early activation, reduce hospital stay time, and optimal long-term results. Now we have 2 basic technology for dynamic correction of scoliosis. First technology is VBT. is correction due to growth modulation of the spine, partial restriction of vertebral growth for the convex side of the deformity. And next technique, ISC anterior scoliosis correction for adult. Another term is used, ventral dynamic correction of scoliosis, since the principle of remodeling is impossible in this situation. Initially, this is an approach to the correction deformity in conditions of complete growth of the spine, allowing to maintain its flexibility. Now, a total 311 patients who have been operated on since 2019. One-stage dynamic correction of the growth spine was 79. One-stage ventral dynamic correction in adult scoliosis 147. Two-stage correction is using dynamic system is 59. Combined correction using dynamic and rigid systems 26. The observation period is more than 1 year, 107. The observation period more than 2 years, 46. Average time of surgery quite short. Average time spent in hospital near 7 days, which is more than minimum required. However, the duration of inpatient follow-up is due to novelty of the mention and desire of minimal potential risk in the postoperative period. We can use thoracoscopic and open mini thoracotomy. Implant placement is possible, but not clear long-term results were obtained for children. What's ideal patients? There's no information for adult. Release, nucleotomy, do we need in some cases or not? Now at Russian market we have only Denesis system, but now there is no system at the market because factory who producing Denesis system was closed. Advantages of anterior scoliosis corrections is prevention mobility of the spine, does not lead to fusion vertebra, ensuring confirmed growth of the spine, early recovery of activity, combination with a rigid system is possible, one-stage treatment, retain the possibility of rigid fixation in the future. It's possible to use the elderly patients over the 60 years old. Now, if we compare patients with the same level of fixation with rigid construct and dynamic constructions, we can see big difference in mobility of the spine. Both girls near 16 years old. And patients 50 plus, the same level of fixation. About 1 year after surgery, we can, if we compare mobility of the spine in patients with dynamic correction, mobility is more. This technology does not lead to fusion vertebra. X-rays after 2 years of dynamic correction, we can see mobility of the spine, flexion, extension, and lateral bending. Ensure continued growth of the spine. We can see after 6 months after surgery, increased deformity of the thoracic spine. It's real spine growth modulation. And after surgery, patient can do different exercises who need very good mobility of the spine. We can do combination with rigid system. For example, thoracic curvature near 79 degree and lumbar curvature about 64 degree. In thoracic spine, we have used rigid fixation, at lumbar spine dynamic correction. Using for the first time in the world for the correction in adult scoliosis. For example, in this case, we can see good correction, and after ISC technique, we can do real rotation of the spine for more correction of the lumbar spine. And it's possible to use dynamic correction of scoliosis in patients over the 60 years old. Lumbar scoliosis, about 45 degree, and very severe right side coxarthrosis. And first surgery was on the lumbar spine, and next will be endoprothesis of the hip to right side. And many years ago, in 60th years of 20th century, it was a big discussion, what's better, arthrodesis hip or endoprothesis. And after some years discussions, Sivash endoprothesis, who was first factory producing in USSR endoprothesis, have win. And patents was using in 35 countries and have acquired manufacturing patients. And now this technology may be very useful, like endoprothesis for hip, for knee, because it's possible early activation, physical therapy, returning to sports after 4-6 weeks, and more active in patients' behavior and better the systems works. For example, some months after surgery can do a very severe trick. And man became champion of the Moscow region in powerlifting in the weight up of 63 kilograms with dynamic correction system. We published some paper about results after dynamic correction. And we are planning prospective, multicentral, retrospective compare studies scanning of the method. We have done a prototype of new dynamic correction system with CanMed company. If we compare these implants with Zimmer or Globus companies, the quality of this implant quite same. And optimal patients for dynamic correction is scoliosis from 30 to 70 degree, hip or normokyphosis. In some cases, is effective for deformities more than 80-90 degree. Most effective for thoracolumbar and lumbar deformities, Lenke 5. But it's work well with Lenke 1, Lenke 2, and we suppose that about 50% of adult scoliosis can be operated using dynamic system from 18 to 40 years old. We have, of course, some complication after this surgery. Pulmonary problem, hemothorax, pneumothorax, neuropathy, malposition of the screws, but level of complication very low. One patient had neuropathic pain because there was radicular root compression of head of the screw. And it needs to remove the screw. And some cases we have malposition of the screw on the opposite side of was surgery made. For prophylaxis of malposition of screw, we need neuromonitoring control for spinal cord. In conclusion, we can say that dynamic correction of the spine in adult is a new direction of spine deformity surgeries is I suppose, third generation of instrumentation, low level of complication, high efficiency of correction, rapid recovery. A Russian product has been created that will be distributed in Eurasian market and priority for Russia and Central Institute of Traumatologic Orthopedic. Thank you.
Thank you very much, and I have to introduce the next speaker, Renato Muniz Teixeira, and will be sagittal thoracolumbar profile alignment, consideration through posterior X anterior interbody fusion. What are the limits? Please.
This is the image of the first meetings we have in Rio in 2017, the first BRICS meeting. This is the hospital, the public hospital where we work in Rio. It's the National Institute of Orthopedics and Traumatology. And I would like to show you our experience through these years in our reality. The goals for surgical measurement are to restore the spinal biomechanic, cosmetic by improved by sagittal contour, restore physiological lordosis and sagittal balance, improve self-esteem, pain, comfort, respiratory, visceral impairment, decompress the neurostructures, and stabilize the unstable segments. The aim of surgical management, the goals you all might know is SVA less than 15 millimeter, PT less than 20, and spinal pelvic harmony, lordosis, and PI around 10 degrees of average. We consider in lumbar spine the difference between the segment L4-S1 and the upper segment. The lower segment corresponds to 75% of lumbar lordosis. And that's why we concern different for each segment and treat in different way. Frequent cause of lumbar sagittal. Multi-level lumbar stenosis, previous surgeries, ADS progression, PJK, isolated laminectomy, stress fractures, post-traumatic deformities, osteoporotic deformities, pseudoarthrosis, ankylosis, infections, and tumors. But the most frequently are degenerative and iatrogenic causes in the majority of the cases. The factors in obtaining an ideal spinopelvic alignment depends of factors related to the patient, comorbidities, general conditions, factors related to the surgeon, factors related with the surgical procedure, hospital facilities, and some family and social contexts. Type of surgeries being a posterior approach, we got PLIF, TLIF, SPO, eggshell modification, FPO, polysegment, wedge, osteotomy, and in VCR. Restriction correction, symptomatic ASD to obtain a spinopelvic alignment, we still have problems related to the patient, failed back, issues related to medication, factors related to the severity of malalignment, and factors related with bone quality. The PLIF is possible to obtain a lateral alignment using with the correct position of the case and the position of the patient and a careful study of the case. PLIF and TLIF, introduced in 1998, and you can work with a reasonable safety for many patients, and is worldwide more used for realignment in daily patients. The pros for PLIF and TLIF. PLIF and TLIF permits 360 fusion in one incision, access to posterior elements, no anterior column distracts, hinge, anterior middle column, good even in collapse IVD, correction between 5 to 15 degrees per level, good neurological decompression. Limited correct coronal imbalance, requires banana-type cage, relies on surgery expertise to reach the best results, good bone quality, extensive epidural managed, arachnoidite and muscle injuries. Smith-Peterson is also useful in mobile spines, but introduced in 1945. The modifications, just like eggshells, and with anterior approach used with Smith-Peterson permits a better correction with better rates of well-succeed results. Pros: remove posterior elements, can be repeated at several levels. Asymmetrical resection for coronal deformity correction. 5 to 15 degrees of correction per level, if you use alone, of course. It's good for elderly and frail population. Cons: elongates length anterior column. It's not possible. When it happens, it can cause some kind of vascular complications. Difficult closing gaps in the levels, which leads to a high percentage of pseudarthrosis when it's used alone. A frequent need for anterior release and fusion. For example, if you got a mobile spine, you have treated in a different way than a fixed spine. In a mobile spine, we have a compensatory mechanism, so you can have flex hip, and you got a thoracic lordose. And when the patient has a high PA, the high PA is the most important measuring for the balance of the spine, because indicates a high capacity of compensation. Then with the posterior and simple approach, you can restore the alignment. PSO is most suitable when you need to do a big correction in appropriate to a rigid spine. Okay. We need different solutions according to deformity. There are some modifications on PSO, just like corneal osteotomy that permits a large correction, introduced in 2015. In this paper, we can see that we can get almost good correction with different kind of technique, just like anterior dissection with posterior enclosed wedge. PSO, isolator PSO with resection proximal disc and plate. You can get different results, but they are quite similar. PSO is a surgery that's a high risk, high bleeding, high tax of complication in our hands, but we perform it in some case, but not always. The pros for pedicle substructure osteotomy preserve the length of the anterior column, sagittal correct in one single level, asymmetric resection for coronal deformity correction between 25 to 55% per level. Cons: technically demanding, substantial bleeding, good patient selection, risk neurologic injury, high pseudoarthrosis as a standalone traditional way. VCR is technically demanding and exhausting procedure with possible risk for complication. We avoid to use this procedure in lumbar spine. But it permits a radical correction in a single level in both planes, coronal plus sagittal, shorten the spine, relieves tension neurovascular structures and correction between 50 to 70%. Cons: technically extremely demanding, high perioperative morbidity, thoracolumbar nerve roots, high complication rate in 3 columns osteotomies. And what are the limits? You see, we have a high tax of complication, between 20 to 6% in almost all kinds of osteotomies. And why not think anterior with more frequency? In sagittal deformity, for example, in scoliosis deformity, we should think about flexible and partial flexible or rigid. When we got flexible deformity, we try to perform the lowest risk procedure. Use of anterior is useful to reduce tissue damage, accelerate chance for fusion, accelerate opportunity for alignment. But it needs a careful evaluation of the patient. When the main patient clinics complain related to mechanical symptoms, axial pain is better than patients with radicular pain and claudical symptoms. Is useful, especially in previous anterior surgery, posterior surgery. And the best anatomical level to be achieved is L4-S1. It needs anatomical knowledge, patient selection. Of course, a fat patient is different from a thin patient. And we need a good study of the exons. The goals of the treatment, of course, are the same as in posterior approach: nerve compression, pain generators, instability, and alignment. You see, in this case, we got a deformity, a traumatic deformity. We can, if we use for anterior approach in this case, you're gonna have a lower risk for patient, in my opinion. So made anterior approach, a 2-step surgery in one time of anesthetic procedure, and you can have low bleeding and less aggressive than, in my point of view, PSO osteotomy. The limits of correction of sagittal imbalance, talking about X-leaf or lateral leaf, is that you correct less than 10 to 10 degrees of correction, and 5 centimeters or SVA. So, and there's a lack of constant reporting on sagittal balance restoration with missed lateral leaf, and this is our experience. The positioning of the case is important. in lateral lift to get a reasonable restoration. And lateral lift, the pros for lateral lift, that you can reach 212 to L5, good for correction in mild or moderate coronal and sagittal deformity with lateral listhesis, and is superior to posterior approach in disc height restoration. But in contrary, neuromonitoring is essential, not suitable for L5S1. There's a risk of neurological and vascular injury in distal levels, and there's a high cost. The contraindications also is severe central stenosis, high-grade spondylolisthesis, and recessed stenosis. The ALIF is used to reach L5451, but frequently we can do in 3 levels, including 3 and 4. The problem is surgeon has no daily anatomy familiarity with the procedure. The pros, there's a good lordotic restoration. The unique procedure that address L5S1, as the majority of patients has failed back surgery, they underwent to surgery, in the majority of these procedures is located between 5-4 and 5 L5S1. So the ALIF is very useful in daily proceduring. Indirect decompression or neuroforamen is also an advantage of anterior restoration height and high tax of fusion. We never had, as I remember, pseudoarthrosis in ALIF. The contrary is limit above L4 and 5, obesity, almost all required posterior procedures, long learning curve, vascular lesion, ureteral lesion, and retrograde ejaculation, but these are not so high incidence. So, talking about ALIF, we address L5, L4, S1. We're concerned that 75% of lumbar lordosis is between this. Okay, wrong. So, failed back. 2 previous surgery. You see, you can restore 23 degrees in 1 step anterior proceeding. 2 days after surgery, a few years later, it is a top in the magazine by a female rescue. 57 years old, congenital fixed deformity present with intractable back pain. Anterior approach, you can get 4 levels and a good mobility in spite of fixation, arthrodesis. That's why people with high PA has a good compensatory, is different from people with low PA. So you can get a good restoration. That's the most, the assess we do. We reach the posterior peritoneum, hepatoperitoneum without no bleeding. If you take care with the vessels and hypogastric plexus using cold blades, there's a low incidence of complication, retrograde ejaculation, for example. In this case, you can see 3 levels of anterior approach. The bleeding is very slow, and we have some in the daily, a lot of revisions like this that comes people with laminectomy, we underwent surgery, so it's very difficult to restore this patient by a posterior approach. So a combined approach is very useful. We try to use 2 cases instead of 1. With templates, you can spread and restore the lordose better than the other methods that we know. So it's a local brand, I made it there. And we use the last 30 years, the same techniques using templates. And then you can you can get this result with any kind of cage that you have can use. We just pre-cut in 35 degrees L5S1, and you got always a good arthrodesis. Is another case, 3 levels with a good restoration balance. It's anterior-posterior approach. When you use coverage for stability, you can have a good coverage of bone chips if you insert around the cage in the even T-leaf and getting 50 or more, 50% of cover of bone chips, the same as you got in I-leaf, if you can use an extra bone. The limits and conclusion. Limits related to the patient, to the surgeon, and to the hospital. Wrong perception of the type of deformity in both planes. Calculate the ideal spinopelvic alignment for each patient. Each type of osteotomy, posterior interbony fusion has its expected goals. Mechanical correction has no limits, but does it work for the PT? We always look for the PT restoration. And the main goal is an harmonious balance to spine in both planes. We work to PT and SVA. This is the main goal for the sagittal restoration. Weigh the pros and cons of all issues discussed in order to know the limits, when to stop and make the best final decision. Less invasive anterior-posterior techniques for fusion procedure has also lowered the threshold for fusion operations, especially in less health patients. Спасибо.
Thank you very much, Рената. Можем задать пару вопросов, потому что у нас одного китайского товарища пока нету.
Сергей Васильевич, у меня к вам вопросы. Но все мы знаем, что если вкручиваем винт, через какое-то время может быть расшатывание внутри кости. Вот относительно динамических систем, я понимаю, там срок наблюдения довольно уже большой. Были ли случаи, когда вы видите, что, когда вы делаете КТ, вы видите подвижность винта внутри установленного позвонка?
Ни одного, честно говоря, расшатывания не было. Было 316 пациентов, больше, чем есть 3-летнее наблюдение, ни одного. Потому что динамический корд, он, видимо, так скажем, снижает нагрузку на винт в кости, поэтому этого не видели.
И второй вопрос. Динамическая фиксация. Есть ли возрастные ограничения? Мы с вами обсуждали неоднократно, что у пожилых людей делать корректирующие операции при сколиозах довольно рисково, большой процент осложнений, есть какой-то возрастной порог. Относительно динамической конструкции, это такие же по породе возрастные, либо вы можете более пожилых людей оперировать, либо все равно здесь больше хирургии для молодых людей, учитывая, что должна быть сохранена подвижность.
В основном, конечно, контингент молодой этому должен подвергаться. Но в отдельных случаях можно и у взрослых это делать. Мы же делаем не традиционную динамическую коррекцию, а делаем ASC. То есть делаем нуклеотомию и релиз небольшой. И при коррекции не повреждаем замыкательные пластины. Поэтому там подвижность, в принципе, она ограничена. Не такая, как на прицелом диске. Она есть, но небольшая. Поэтому вот у пожилых, как опция, в принципе, возможно. Так скажем, опыта ни у кого в мире нет, поэтому так вот постепенно будем смотреть. Но вообще это для молодых. Динамическая коррекция для молодых.
И все же, Сергей Васильевич, у меня вопрос, где вот эта граница, потому что оперировав пациентов за 55, как вы говорите, 50 плюс, все-таки это же не пациенты со сколиозом, это пациенты с генеративными изменениями на фоне сколиотической деформации. И идея хирургии в этой ситуации фатальная, она по своему смыслу, но другого варианта, как исключить движение в позвоночнике, чтобы избавить пациента от боли, ну, там, с коррекцией, сагитального баланса, с коронального баланса и так далее, это понятно. Но все-таки минимизация движения – это же не решение проблемы боли. Есть ли какие-то у вас цифры, которые могли бы подтвердить эффективность этого метода? Или все-таки это метод такой, мы пробуем, берем пациента, он соглашается на операцию, как мы вчера не раз с вами обсуждали, позавчера говорили, что с пациентом надо разговаривать. Понятно, что мы можем уговорить любого пациента на ту или иную операцию, но все-таки здесь должна быть какая-то доказательная база, чтобы пациенту предложить тот или иной эффективный метод лечения. Все-таки операции не настолько уж низкотравматичные, как мы тут с нашего площадки представляем. Вот. Это вот такой вот. Есть какие-то даты, цифры?
Ну, цифры есть. Мы их приведем. Но возрастных пациентов у нас мало пока. Там 60 плюс – это 3 человека. 50 плюс – тоже, наверное, человек 5. Поэтому у них в целом все хорошо. Но срок примерно, наверное, там чуть больше года. Ну, будем потихонечку набирать материал, будем смотреть. Но, на мой взгляд, в принципе, это все об этом многократно говорили. Позвоночник, он должен двигаться. Когда же мы делаем жесткую фиксацию, процент осложнений у пожилых он очень высокий. 50% – это очень много. Поэтому как-то эту проблему надо решать. И, возможно, это будет альтернативный, так скажем, вариант. Но пока он, естественно, это инновационная технология, новая. Поэтому все начинается, в конце концов, через, так скажем, накопление опыта. Поэтому будем делать, будем смотреть.
А Игорь Вадимович нет? А Игорь Вадимович Басанкин? Басанкин нет в зале? Нет. Ну ладно, тогда вопрос снимаю. Да, Сергей Валентинович. Ну, наверное, да.
Сергей Васильевич, у меня к вам тогда вопрос по поводу вот все-таки вашей технологии и методики динамической коррекции. И у вас есть уже большой опыт, вы продемонстрировали пациентов детского возраста. И, насколько я понимаю, это все-таки продолжающие расти дети, пациенты, с небольшими деформациями, ну, не критическими, не запредельными. Проводили ли вы сравнение с лечением этих пациентов и ведение их коррегирующими корсетами типа Шино? Вот был ли этот сравнительный анализ и какова тогда эффективность вашей предложенной методики и корсетного лечения? Спасибо.
Спасибо за вопрос. Мы это проводим, смотрим, и я думаю, что такую работу опубликуем. Ну, конечно, мы предпочитаем, конечно, начинать с корсетного лечения, и все дети, в общем-то, проходят через корсетное лечение. И по нашему убеждению, в принципе, вот этот метод динамической коррекции хорош для пациентов, которые уже, так скажем, дошли до возраста костного и полового созревания и имеют остаточную деформацию более чем там 35 градусов, который потенциально после отмены корсета может прогрессировать. Поэтому вот то, что корсетом не удалось вывести, на мой взгляд, оптимально доделать динамическим имплантатом. И дать пациенту возможность двигаться, активно жить, не думать о деформации, что она будет увеличиваться и ползти в перспективе. Потому что мы же все знаем, что они к нам приходят там, в возрасте, рожают, и потом это все дело прогрессирует, болит, и мы их там делаем в 40-50 лет уже с большим процентом осложнений. А по корсетам, да, такая работа планируется, мы накапливаем. Но вообще, вот, честно говоря, на мой взгляд, вот эта классическая модуляция роста, она все-таки дает, по данным литературы, тоже до 30% осложнений, особенно если в раннем возрасте делают. Оптимально, мне кажется, все-таки делать, когда уже позвоночник уже вот на грани завершения, может быть, чуть-чуть остается. Потому что очень сложно спрогнозировать, как вот эта модуляция будет делать. Бывают гиперкоррекции, либо мы, допустим, планируем, что пациент будет расти, а он не растет. И мы ему оставили на рост эту систему, он не справилась. И приходится тогда что делать? Повторно вмешиваться и докоррегировать то, что мы эта система не доделала. Ну, тут много, короче, вопросов. В общем, поэтапно будем решать. Ну, у нас уже время поджимает. Сейчас у нас Саджан Хейдж подключился. Можно? Ага. Тогда next presentation will be Indian experience of robotic assisted spine surgery. Индийский опыт роботассистированной хирургии. Доктор Саджан Хейдж, Индия.
Ladies and gentlemen, it's an absolute pleasure to be part of the BRIC meeting being held in the great nation of Russia in the wonderful city of Moscow. It would have been an even great pleasure to be there in person. Russia is, as you know, a great friend of India, and we are very happy to be part of this meeting. I will talk about the Indian experience with robotic-assisted spine surgery. So we have been doing spine surgery for over 10 years. And we have been, we always wonder, why do we need robotic spine surgery? I've been placing pedicle screws for well over 25 years, and my technique has primarily been freehand. We have had, of course, issues with obese patients, revision and severe revision surgeries, and severely deformed spines. And of course, I always had a reluctance to adopting minimal invasive techniques because of radiation issues. I had tried navigation and jigs in the past without much success. And so when we posted on LinkedIn about our experience of fixing a high-grade spondy with robotic surgery, we were posed with a comment, what does it take to put pedicle screws? It is all about the knowledge and the anatomical landmarks. But we will show why it is necessary. Now, we all know that wrongly done spine surgery, like you see here, this is a senior nurse who was operated in another country, and you can see all the screws have been misplaced. This was a treatment for a spondylolisthesis, which went horribly wrong. The patient then needed diapers. She had severe deficit in her lower limbs. So we asked, why do we need? And this is what I'm going to show in the next few slides, how robotic surgery improves the outcomes. Of course, we have been putting pedicle screws for years. Some of us have been using freehand technique. Some have been using the funnel technique as described by Bob James of US, and some have been putting under fluoroscopy. But misplaced pedicle screws can cause serious issues. Up to 2.5 to 40% of complications have been reported. These include dural tears, root injuries, paraplegia, and vascular problems. And of course, when we come to revision surgery, it's the most challenging obstacle of placing pedicle screws safely in a fusion mass or current pseudarthrosis is the difficulty in finding the exact location for the entry of the pedicle screws. So whether one uses freehand technique, intraoperative markers, radiographic control, navigation, even mini laminotomy before screw insertion, the incidence of patients with pedicle screw malposition still remains very high in taking into account the large number of screws that we all place. So it is all about making dangerous spine surgery safer and getting higher levels of accuracy and, of course, reducing the radiation hazards to the surgeon and the operating team. We started at Apollo Hospitals, Chennai, way back in 2012, when we started using the Mazor Renaissance, which was the second generation spine robot from them, way back in 2012. And it was about sitting before you even entered the operation theater. You did a robotic guidance or a virtual pedicle screw placement using a high resolution CT of the patient to plan. So you did it on your computer screen even before you entered the operation theater. You had your plan ready. You knew exactly which pedicles to fix, the sizes of the screw, the thickness of the screw. So, and here you see the virtual planning, which has been done using the Renaissance software. And we were able to take this to the operation theater. And then you did a 3D syncing of the software with images, fluoro images, and AP and oblique, which was done with the first generation robot. And then you mounted the robot on a mount. And here you can see on the lower right, the robot, which is mounted, which is like a small Coca-Cola can, and that helped you to guide your screws. So here you see a 14-year-old child with a very obvious severe deformity. As you can see here, she has multiple hemivertebrae. Her spine is displaced in all directions, and she has severe rotational deformity. The deformity is quite severe and rigid. This is her traction film, which shows some degree of flexibility and the multiple hemivertebrae. This is a CT scan, which shows the multiple hemivertebrae at different levels. And you can see the rotation of the spine, which would become very difficult to precisely place screws if one wanted to do it manually. But if you did it virtually, and then you took this, you are able to do it very easily. Here you see the trajectories of the screws in extremely difficult trajectories that are necessary to precisely place the screws in the vertebrae, which are so distorted and rotated. And the screws are placed, and very safely, very precisely, you do a hemivertebral excision, and then you correct the deformity, and the child has an excellent result. Now we come to a 10-year-old child with a very severe congenital deformity. She had multiple previous interventions. She had undergone posterior surgery. She had undergone anterior surgery. All of these surgeries had failed. The implants were broken. So the challenges were a small child, tiny vertebrae, very small pedicles, multiple surgeries, and a large fusion mass with pseudoarthrosis. Here you see the child before surgery, the multiple scars, the severe deformity, and obviously the child is in agony. Here you see the broken implants of the previous surgeries. So the first stage is about removing those implants and then getting a CT scan. And based on the CT scan, here you see the CT scan, which shows a complete obliteration of all the landmarks. So fixing this child's spine would be a huge challenge. Here you see the CT scan of this reconstruction. And after guidance with the robot, we are able to precisely place the implants safely to get a good correction, and the child has a good result. So what is new? From 2019, we have been using a new generation robot, which is called the Excelsius GPS. And this is a floor-mounted robot, which gives the very precise trajectories for the placement of the screws. And this has been a huge help in us doing minimal invasive robotic surgery. So when we have a burst fracture, like you see here, with a normal neurology, this we can plan on the robot, the placement of the screws. Then we do that exactly, take this plan to the theater, and through minimal invasive incisions, place the implants in the morning. The patient is given a brace and made to walk after a few hours and go home. Tuberculosis is an ancient disease and it is quite common in our part of the world. We have a 14-year-old child here who complains of severe back pain and weight loss and fever. And as you can see, she has severe destruction of one of her lumbar vertebrae. The CT scan and MRI shows the extent of destruction. She has an impending neurological deficit. Here you see the CT scan on the right and left showing the extensive destruction. So we plan to use a robot. The idea is to do a single stage lateral position surgery, robotic minimal invasive fixation, as well as corpectomy. Here you see the patient is positioned for the surgery and the pictures are taken and the robotic planning is done. And here you see that the robot moving for the placement of the screws in the lateral position. The screws are fixed. As you can see here, the minimal invasive lateral fixation of the pedicle screws. At the same time, an anterior corpectomy is done in the same setting and a Harm's cage has been fixed and the patient has an excellent result. This is a patient who comes with a severe cervicothoracic kyphosis. He is barely able to stand straight because his gaze is downward and his daily activities is severely restricted and he finds performing normal human activities very difficult. To look forward, he has to bend at his knees because of the fixed deformity at the cervicothoracic junction. Here you see the X-ray showing the cervicothoracic deformity, which is very severe. In the CT scan, you can see that the landmarks are all lost. If one has to do regular standard fixation, it would be very difficult as the landmarks are not there to help you to place these implants. Here we do a spin with the Zeem prior to surgery after the patient has been positioned. This CT scan is fed into the, go back. The CT scan is fed into the robot and under live picturization on the seat on the robotic screen, we are able to place those implants quickly, safely. Go forward. Yeah. After that, we make an osteotomy at the C7 level. Take it a little there. The patient's head is manually lifted and the implants are fixed. As you can see, he has an excellent correction. He is able to look forward and he is able to walk normally without any issues. This is a patient who came to us from another country. He had undergone previous surgeries, but he had what is called as a flat back, a sagittal deformity, and all his sagittal parameters were severely disturbed. He also had compression at a couple of levels in the upper lumbar spine. So this needed to be addressed. So an anterior-posterior reconstruction of the deformity is planned. Here you see the patient is positioned and an anterior surgery is done to put lateral interbody cages at the upper lumbar levels. Once that is done, the patient is then position for S2 ALR fixation, which is robotic guided. Robotic screws can be very, very complex to put, but with the robot, S2 iliac screws can be very difficult to put, but with the robot, they are very, very simple and performed very quickly. And once this is done, the other screws are also quickly placed with robotic accuracy. And a good correction is achieved. And when he goes back to his country, he is back to normal and he is able to walk and return back to normal daily activities. So our robotic experience is one of the earliest in the world. We started way back in 2012. And we have done, now we are coming close to almost 500 cases. And I would think that using a robot helps in complex, difficult situations. Thank you.
Thank you. Thank you very much for your excellent presentation. Keep in touch with us, because we have... У нас есть Аарон Зу подключился. After next presentation will be a short discussion. Maybe we have some questions for you.
That will be a pleasure. That will be a pleasure.
Следующий у нас next presentation, scoliosis treatment in osteogenesis imperfecta. Лечение сколиоза у пациентов с несовершенным остеогенезом. Аарон Зу, Гонконг, Китай.
Thank you, Chairman. Thanks to the organizing committee for the invitation to give a presentation on the BRICS. So this is Aaron Zhu from the University of Hong Kong, China. So actually, this is the second time for me to attend the BRICS. So, but it's a pity and a shame that because of the pandemics, so I cannot join the conference face to face and to meet all the old friends and for the detailed discussion. And today I would like to talk about the osteogenesis imperfect. So actually, this is a rare disease. I would like to say it's one out of the 15 or 20,000 of young populations. So it was known that it's an inherited genetic problem, inherited connective tissue disease. With the advance of the basic science, we know that, but it have different phenotypes. Although the presentation may be also various because of the different gene mutations. So it varies. Although it's only have one name, osteogenesis imperfect, but have different forms. With the worst forms, the patient may die at the earlier perinatal period. Some mild forms may just the main manifestation only the premature osteoporosis. Okay, so it also varies about the incidence of the scoliosis in this group of the patient from the literature. So it can be go far away to the 60 or 70 years ago. That varies from 20% to nearly 80%. So, and clinical classification, there are main 4 types: type 1, 2, 3, 4. The type 1 is very mild, as I mentioned. Type 2 is very devastating. So the patient may die at an early age. So you will not see in your clinical in the hospital. So most common one is type 3. And type 4 is just in between type 1 and type 2, between mild and severe. So there is another type of the classification, but it's mainly based on the genetic test. So there are more than 20 different types, but the presentation may be similar. So this is a literature review, talk about the different types and their incidence. Okay. And our experience that there are nearly 80% of the patient with osteogenesis will present with a scoliosis. So it's a huge amount of the patient in this specific populations. So main presentation would be with a deformity progress, the patient will have the collapsed trunk, has the trunk lifting, and most of the patients are not ambulatory, so they're wheelchair banded. So they will present with severe back pain, and if the corpse angle deteriorates to more than 90 to 100 degree, there may be some problem with the cardiopulmonary function. I will talk. So I would like to introduce this disease and our treatment case by case. So for sure, the first presentation for the patient would be the kind of osteoporosis and multiple fracture of the four-limbs, so there you can see a lot of deformities. So this is, but nowadays we have some treatment like bisphosphonate for the anti-osteoporotic treatment to increase the bone mineral density. This is an example. The patient bone mineral density increased from minus 2.4 to minus 1. So this is the natural history of the patient with like more than 5 years follow-ups. The patient presented with a straight spine, but with the patient become older, you can see the lower limb got the fracture, and we put the intramedullary nails to correct the deformity and the fracture. And as well, the patient also present with a mild scoliosis and slowly progress. So this is a WNT1 mutations. It's a type 15. So we can call it mild because the curve progress not obvious. So this type of patient, we can try the progress as you can see on the slide. Yeah, but unfortunately, probably the breast treatment is not as effective as in the AIS group. Because why? The patient have the very poor bone quality. You can see that the minus patient with -4, -3. So very easy to have the ribs. If the pressure is too high, the patient may easily have a fracture of the rib cage and the rib deformities. So the force cannot be transmitted from the breast to the spine, to the ribs, to the spine. So the correction effect is not that good. So most of the patients, the outcome is not that good. So this is another patient, 16 years old, female, and bone mineral density is not that bad, but you can see very severe lower limb problem and the pelvic tilt. So the curve keep progress. The bone mineral density is not that bad. So we did this type of patient. The correction is not that bad, not that difficult, but this is a mild type of B. And this is another case with also more than 5 years follow-up. The curve type, this type is totally different from the AIS we can know, because the apex, in terms of the apex of the lumbar curve, because most of the AIS patients, the apex will be kind of L1, L2, but this one is very low. And as well with the pelvic twisting and the tilting, so the patient have a very severe back pain. So the objective of the surgery would be kind of to level up the pelvics so that the patient can sit comfortably on the wheelchairs, and you can see the correction after the surgery. This is another case. And during the treatment, we also give the anti-osteoporotic chain treatment, so you can see the dramatic improvement of the bone minerals. So this is very good for the anchorage of the pedicle screws, just in case the patient have any implant failure. So this is our study and on the different types of the osteogenesis imperfecta with the bisphosphonate treatment. Although that this kind of medical treatment cannot improve any scoliosis, but it's very good for our corrective surgery in terms of the implant failure, other complications. So this is another type 12 and BMP mutations, mild curve. And the correction is not that challenge, but there is another type, just as I mentioned, type 3. The curve will rapidly progress to 80 or 100 degree, and the pulmonary and cardio function will be compromised with the disease progress. So this is one severe case. You can see beside the scoliosis, there's also wedge-shaped and big rotation of the lumbar curves. So the patient will present with a very severe back pain. So it's very indicated for the surgery. And this is a CT scanning. So because it's have a thoracic curve and a lumbar curve, so we performed a long construct fusion for this patient. So this is a case for the rapid progress. It's a worst type. So you can see the curve progress from the nearly 40 degree to nearly 100 degree only in less than 1 year time. So for this type of curve, we need a traction, we need a pre-op preparations, and then posterior navigations will insert as pedicle screws because of very severe rotation because of deformity of the pedicles. Not easy to insert one. So this is a dramatic change before and after the surgery. Another type. So this patient you can see the thoracic trunk is very collapsed. So the patient will present with some respiratory dysfunctions as well, and the trunk collapse. So you can see the rib cage already sit on the pelvis. So the indication for the surgery will to straighten up the spine and lift up enlarge the space between the thoracic cage and the iliac crest. And don't forget that to assess the upper cervical and occipital-cervical junctions. But some of the patients may present with syringomelia and some kind of dense deformities on the C1-2 deformities on the upper cervical junctional region. So this is our treatment of we all the way go down because the curve is so big and the collapse, the trunk shift. So we perform go all the way down to the pelvis to lift up the patient. This is another one. You can see the very severe rotation and the deformed, very osteoporotic. You can see from the even from the X-ray and the deformed lower limbs. Actually, the patient, all these patients are not ambulatory. They sit on the wheelchair, but the end of the surgery is that the patient can sit comfortably on the chairs. This is before the surgery. Before the surgery, because of deformities, her two arms is not independent. Has use the arms to support herself. So after surgery, we stretch out the spine so the patient can free their hands. Yeah, this is another case of the very severe curves. So you can see that the scoliosis in OI varies from very mild one, which is mimic to the AIS patient, and to very severe, weird, bizarre one. So you can see from the CT scans. And one thing is we should be careful about this patient that for this kind of big curve, if it's an AIS patient, we can very comfortably to put on the harrow traction. But don't forget that even the skulls, the bones are very fragile. So this is a complication that when we put on the harrow, there is some fractures of the skull bones. So you should be careful when you want to put the patient on the traction. So this is the surgical outcomes. You can see that we try to insert as many as we can the pedicle screws just to increase the density of the implants because of the osteoporosis, the purchase, the power of each pedicle screws is not as strong as in normal bones. So this is very important. This is a comparison between before and after the surgery. another case. So this one is a little bit bizarre. Although we use navigation, sometimes we cannot insert the pedicle screws. Why? Because this version we only can fix the lumbar spine. We have to give up the thoracic spine. We can see that it's very uncommon. You can see the congenital changes on the lumbar spine. Okay, and this is 3D printing of this patient. Very unusual. So pre-operative proper assessment is very important for this time the patient. You can see why we cannot insert any implants in the thoracic spine. You can see the vertebral body is already synced, and all the trajectory of the pedicle screw is blocked by the rib cage. So we cannot insert any pedicles at that levels, T6 to 7. Okay. So as I mentioned, this patient may be combined with some basilar invaginations, some other congenital deformities. So you can see the hydrocephalus and the basilar invaginations. So pre-op, don't forget to do the CAT scan on your brain and upper cervical spine. This is our. So this patient as well, we put on the traction. For sure, that with the traction we can increase a certain percentage of the corrections and make our on the surgery and the correction on the table much easier. So the treatment for OI type 1 is quite mild, but type 3 and the type 3 especially will become very vicious. So we should be very careful about this type of patient that very rapid progress and become very severe one and compromise our cardiopulmonary functions. So you can put a patient on the skull halo traction, but be careful about the skull fracture. And the osteoporosis and the rib cage deformities is a big challenge to our corrective surgery. Don't forget the C1-2 and occipital deformities in this type of patient. So this is the end of my presentation. Welcome to our hospital, which is based in Shenzhen, close to Hong Kong. And hope to see you all guys soon, and welcome any questions. Thank you.
Thank you very much, Zhu. Very glad to see you. I hope in nearest future it will be possible to face-to-face meeting. I have one question for you. Have you used hologravity traction from OI patients during 2.5 months? How is safe? Where patients stay, at hospital or at home during 2.5 months?
So
traction?
actually, so this kind of disease is very rare, right? So you don't have many patients, right? So most of the patients is come from not in our city, come from all of the South China. So maybe 500 miles away or 1,000 miles away. So they have to stay in our hospital. So it'll be for the financial problem, we're trying to find some kind of charity support for this kind of poor patients. So usually, so for me, I don't like that put the patient on the traction for more than 2 months. Okay, so maybe usually one month or 1.5 months. So if it works, it will work. So if it doesn't work, you don't need to put the patient on the long-term tractions.
Thank you very much. Thank you very much for your participation in BRICS meeting.
Thank you. Thank you. Great conference.
А можно доктора Хейджа подключить?
Yes.
Yeah, dear Dr. Hedge, I have a question for you. A great experience of using of Mazor robot for deformity cases. I also have a long time experience of using Mazor. Now we stop it. We switch more to navigation systems. Looking forward for creation of new robots, like you show in your presentation. My question is, what kind of which CT films do you use? You have intraoperative CT or you use preoperative CT?
Excellent question. We have been using preoperative CT for most of our patients. Preoperative. Yes.
So you don't have CT in the operation room?
We have used the Zeem machine, few and far between, but we do not at present have a CT machine, a high-end fluoro, which we are planning to get, which will help us in all our severe deformity cases and our cervical spine cases.
Zeem is 3D. You have 3D Zeem or regular one?
Yes, we had the 3D Zeem, but that was
so it's like one Spero CT. It's the same like worm. The same like worm.
Yes.
So yes. So you get all your images in the operating room. Yes. So if I have some
no, but most of our lumbar cases, the MIS cases, we do with preoperative CT.
Because I think there become some mistakes in position of the screws, because when you do the preoperative CT, maybe the patient will be not in the same position at the table. And another thing, if you have a displacement of the vertebrae, you already be not so accurate. So
I fully agree with you, and I think ultimately intraoperative CT will be the way to go.
Yes,
and especially in severe deformity. For lumbar spine cases, it works all right. Yeah. Most of our cases are low back MIS cases, so that works well. But if there are severe deformities, and we do deformity on traction, so the position of the vertebrae changes a lot after the patient is put on the table. So I think intraoperative CT in the form of an O-arm, or there is a new one coming from Globus, which we might plan to use.
So you agree with me that the future will be for the intraoperative CT and automatic registration with the robot, Oh,
yes. I fully agree with you.
Yes. Thank you very much. Appreciate it. Very, very, very great pleasure to see you. Hope one day you see you in Moscow. It's a nice city and always welcome. Thank you very much for taking part in this conference. So we go on. Thank you.
We look forward to cooperation with our Russian colleagues and interaction in person. We look forward to it.
Thank you very much. Appreciate it. We're also looking forward. Bye-bye. Have a nice day.
Следующий у нас Роберт Дан подключился. Все, включаем, да.
Good morning. I'm Robert Dunn, Cape Town, South Africa. I'll be presenting on our study on the impact of surgery in 921 degenerative spine patients, which were assessed by pre- and post-operative health and functional scores. I have no disclosures pertinent to the matter. Degenerative spine surgery is one of the major causes of disability, with poor quality of life and low productivity. The rising cost of surgery for this condition demands supportive outcome data, such as those from the patient's perspective. In this paper, we sought to describe baseline disability and quality of life of our degenerative spine patients across both the private and public platforms. Diagnostic subgroup analysis was used to determine which group gained more from surgery and whether which fusion technique made a difference. We studied the patient-reported outcome measures, PROMs, in degenerative spinal surgery by a single surgeon across both private and public platforms. This was over a period of care of 2003 to 2020, where patients were assessed pre and at 6 months post-op in terms of the PROMs, including Euroqual 5D, Oswestry Disability Score, Roland Morris, and Visual Analog Scale. This included 921 patients with pre and post data. All had undergone decompressive lumbar surgery. 689 had fusions, of which 316 were transforaminal lumbar interbody fusions. Looking at the diagnostic criteria by ICD-10 code, the majority were lumbar stenosis or lytic leucissus, as well as lumbar disc pathology. The average age of the patient cohort was 55 years at surgery, with the even split between the public hospital and the private sector, and more females in the group than males. We looked at Oswestry disability data, and for the entire cohort, the pre-op score was 49% out of 100, which reduced to 28 post-op by 6 months, which was greater than the minimally clinical detectable difference and statistically significant. We looked at the Rowland-Morris score, which is 18 symptoms which the patient selects, and this reduced from about 12 to 7, again, statistically significant and greater than the minimum clinical detectable difference. When asking about the visual analog scale, the entire cohort reduced from 6.2 to 3.7, again, statistically significant. As far as the EQ5D, which consists of multiple domains, mobility, self-care, usual activities, pain, discomfort, and anxiety, and has a slider score of 0 to 100, where patients are asked to place where 100 is the best possible health to choose a marker, and the patients went from a pre-op 54 up to 71 at 6 months. In terms of the EQ5D, what we've done is we've colored the no problems in green, severe problems in red, and you can see for all these categories, mobility, self-care, activities, daily living, pain, and anxiety, there's increased green on the right-hand side in the post-op group, with less red compared to the pre-op. So there's been a shift from higher level of disability to lower level of disability. When comparing the public and private patients, pre-op, the public were 53% and private were 46%. So this means our public patients, or our indigent patients, have a higher level of symptomatology when they report on the forms. Again, likewise, Rowland-Morris again showed that the public system, the indigent patients, had a higher number of complaints recognized than the private group. And if we look at this graph, the public is the dark blue, and this comes down significantly. The private is the black. It also comes down significantly in the ODI, Rowland-Morris, and improves in the QL slider. So you can see, although they all improve, the public patients have a higher level of disability, and although they improve a lot, end up at a higher, post-operatively higher level than the private patients. In terms of, we looked at the subgroup analysis, we went and looked at the ICD-10 code for lumbar stenosis in primary surgery non-deformity patients. Here, the age was a little bit higher than overall at 62 years, a lot more females at more than 2 to 1. This consisted of 200 patients. And once again, you can see the pre-op dropped from 44% down to 31%. The Rowland-Morris 12 to 7, visual analog scale from 6 to 3. The health slider improved from 45 to 73. And again, looking at the EQ5D, there was a general reduction in the number of reds between pre and post, and increasing green. When we compared posterolateral fusions in the primary non-deformity group, again, ODI improved from 41 to 30%, Rowland-Morris 12 to 7, VAS 5.7 to 3.4. The EQ5D, in terms of health slider, improved from 46 to 75. And just to represent the EQ5D, again, increasing green, reducing red. Compared to the transforaminal interbody fusion, again, we had good improvements from 45% down to 28%, Rowland-Morris 12 to 7, VAS 7 to 3, and EQ5D slider 46 improved to 75. And again, reduction in red, improved in green in terms of the EQ5D. When comparing the transforaminal interbody fusions with posterolateral fusions, accepting these are different patient groups with different indications and not directly comparable, there was a similar ODI post-operatively between TLIF 28% and posterolateral fusion 30. Rowland-Morris 7 to 7, VAS 3 to 3. But remember, these are different groups of patients, but we can achieve a similar result with these surgeries. Health slider was about the same post-operatively, and the EQ5D, again, very similar in terms of amount of green and red. So in conclusion, this is the first South African spine patient-related outcome measure study. It supports the value of surgery in degenerative spine disease. Public or indigent patients had a worse preoperative score than private, but achieved the same gain, although the private group maintained their preoperative advantage. Fusion techniques had similar outcome scores, but are not necessarily interchangeable, as they have different indications for each technique. Thank you. Good morning. I'm Robert Dunn from Cape Town, South Africa, and I'll be discussing the surgical management in previously failed pediatric deformity surgery. Spinal deformity surgery in a young patient is challenging enough, but when such surgery fails with rapid growth remaining, the consequences can be catastrophic in terms of cardiopulmonary function, never mind deformity. Management of such patients where there's been prior failed kyphoscoliosis surgery is extremely difficult, fraught with risk, and requires an individualized approach. We reviewed a small set of challenging cases in terms of strategy and outcome. In just over 1,000 deformity surgeries, we identified 9 pediatric patients that had prior deformity surgery that presented with ongoing deformity. 3 of the 9 had had early onset scoliosis, 2 of which had unexplained spondyloepiphyseal type dysplasia, 1 Sotos syndrome. 2 of the 9 had Marfan's, where 1 had undergone an anterior thoracolumbar fusion elsewhere, and 1 had undergone a posterior fusion. 3 had adolescent idiopathic scoliosis, all managed suboptimally with posterior instrumented fusions, with instrumentation failure or early removal with curve progression, and 1 patient had a failed surgery for dysplastic spondylolisthesis. All patients presented with progressive deformity and severe crankshaft in the early onset group. Both Marfans presented with pain. The one at L5 below the anterior thoracolumbar fusion, where there was residual lumbar deformity and also pain in the spondylolisthesis case. Our strategy was dictated by the presence of fusion, and this was assessed on traction X-rays and CT scans, such as this on the right-hand side. We closely look to see if there's cross-trabeculation of the bone. This is an example where the patient had been operated on by the previous surgeons using a very simple construct, which failed. It went on to fuse in a poor position, but the discs were left intact. Such a patient where there was a posterior fusion, but the anterior column was still mobile. Multi-level osteotomies were performed through the posterior bone mass, and a distractor placed in the concavity where this was cracked open. Screws were placed by palpating the medial pedicles and freehanding them in, and good correction could be achieved with compression on the convexity and distraction on the concavity. And here's an example of a patient who had such a posterior fusion, instrumentation removed, unacceptable position to her, which created a lot of psychosocial problems, and she underwent such a posterior osteotomy and correction with a pretty good result. If the posterior fusion and anterior column were deemed rigid, then a 2-stage anterior release, traction, and posterior correction were performed, and a single-stage anterior release and posterior correction performed. Here's a little boy that presented to me many years ago with a mild early onset scoliosis. At the age of 6, he underwent growth rods, which failed, were removed. He defaulted due to social issues, returned with quite a severe kyphoscoliosis, and he underwent an anterior thoracic release, placed in halo traction with counter traction with skin adhesive traction on the legs, and then subsequently a posterior correction with an excellent correction of his kyphoscoliosis. In patients that presented with pain, such as this Marfan syndrome, who had a previous thoracolumbar surgery in the UK, she presented with severe L5 nerve root pain, but the curve was rigid. At that point, I decided to simply decompress and extend the fusion to the pelvis, but she was unhappy with her body shape and ongoing costopelvic pain. I therefore did an anterior surgery to remove the implants and osteotomy, with not perfect, but reasonably happy. Of course, it's a difficult, highly dangerous surgery, and 4 of our 9 patients had surgical complications, 3 early and 1 late, all requiring revision. This 15-year-old patient with a dysplasia had undergone an anterior release with traction following his previous severe kyphoscoliosis fusion. We did the anterior release, did the traction, and took him back the following week to do a posterior correction. All went well up until day 11, when he developed in the ward an acute lower limb paralysis. And then, unfortunately, you can see on the top right over here, there's a proximal junctional failure, and you can see how he's fractured above the construct. This was revised with extension superiorly, and he recovered fully in a matter of, dramatically in a few days and fully by about 6 weeks, and has a pretty acceptable clinical outcome. Here's a child with Sotos syndrome. He had an intraoperative loss of all signals on correction. The rods removed, correction undone, screws left in situ, and an urgent CT scan done while anesthetized. The screws were confirmed to be good, and he awoke, moving his legs. He was taken back a week later, and a reasonable correction obtained. Here's a patient who was managed with a spondylolisthesis. You can see the halos around the S1 screws. She had an L5S1 non-union, presented with severe low back pain and loose screws in S1. This required revision to the pelvis. So in conclusion, this is a complex group of patients with a heterogeneous etiology. It requires an individualized management strategy based on anterior column flexibility and the source of pain. It has a high complication rate, but with careful, individualized management, can have an acceptable final outcome. Thank you very much.
Thank you very much. А Роберт на связи у нас? Можно вопросом задать? Ребята, на связи?
Good morning, I can hear you.
Hi, Robert. Very glad to see you.
Good morning. Yes, good to see you.
We have some questions for you.
Thank you.
Hello, Robert. And so can you tell us about the osteotomy of the bone block? Yeah, in the revision cases, you show exactly then the posterior osteotomy have a good chance for correction. And according to your experience, could you share us how many levels you would recommend us for the osteotomy? 2, 3, or every level osteotomy to achieve the mobility of the spine in this type of the patients? And what the % of neurological complication, or which type of the complication is available to have in this situation? Because it's bone block after the many of years of fixing spine, and we do the osteotomy after the several years of the previous surgery. Is it affected on the spinal cord, or it's the similar like a primary surgery?
Thank you for the question. Look, it's actually amazing. Sometimes you get into the back and you start taking the bone off the back and you realize the fusion has not actually taken. The facet joints are still mobile. The previous surgeon didn't actually do a facetectomy, and then it's relatively easy. Sometimes even the bone overlaps like that, and once you take the top off, you can see the fibrous tissue. But in the case I showed there, I would generally do about 3 or 4 osteotomies spread over the most severe part of the deformity. And I generally use a burr and I run across, because I want to cut that bone out and use it for bone grafts. I just cut the block and then I use a cape and a gouge and I chisel it out. And then what I do in the concavity is I often put a distractor, and with the distractor I slowly open it and it eventually cracks open on the concavity. So that's how I do it. And I don't use any spinal navigation. It's all freehand. So what I do is I then palpate the pedicle from the canal, and then I put my screws in under. I can feel where the pedicle is, and I put my screws in like that. I have not had a neurological complication with that osteotomy type situation. My complications has always been correction of kyphosis. And both those children I showed with the proximal junctional fracture and the other Sotos syndrome were kyphotic corrections. And I think that is the most dangerous, where you've got maybe some scarring down of the thecal sac inside the canal. It's not as resilient. It's much more sensitive to tension. So, as I say, I think this group of patients is a much higher risk than your primary care. But when with a straightforward AIS, when I did bone block cuts like that at the back, I haven't not had a problem. So I think that's relatively safe.
Thank you very much. I want to ask you one question. Now it's very popular compare with result surgical follow-up between different races. For example, Asian and Caucasus. You have big experience in black population people. What can you say about results in degenerative disease follow-up results after surgery between white and black people? Maybe you noticed any difference?
Yeah, look, firstly, the reason we did that study is because our funders, the way the private and state funding work, there's a lot of people who believe we're wasting money on spinal surgery. The funders see a lot more surgery happening around the world and so on. So we wanted to show that we actually make a difference. So we show we make a difference. I did not particularly study race because it's a very sensitive topic in our country. And in fact, if you want to study race, you will not get ethical approval. But I do think, for me, I don't think there's a difference in race, in my perception. I think the difference is in social economics. But obviously, in some countries like ours, there's a combination of, our black people largely have low socioeconomic associations because of our history. But if I look at it, if you're a wealthy person and you're in the private sector, you do better than if you're a poor person in the public sector. Now, I did all the surgery, so the surgery was the same, the techniques are the same, but of course, PROMS is a personal perspective of things. And I think if you're in the public service, often you're doing manual work, you labor, your options after spinal surgery are different. If you are in the private sector, often you're in an office, in administration, it's much, your environment after surgery is different. So I think that's what we're seeing in the difference in the public and private. It's socioeconomics, but it's really your ability to cope with life after your fusion, and depending where you are in society, your options are different. So I think that's all we're seeing. But in terms of race, purely, I don't think there's any difference.
Thank you very much. Может быть, кто хочет спросить?
Can I say something? We don't have much difference in race because, Brazil has all races. The problem is fat and thin patients.
Thank you very much, Robert.
Okay.
We
Bye-bye.
are all very glad to see you. I hope
Good. Okay, I look forward to coming to Moscow again. Cheers. Bye-bye.
We can see you face to face. Thank you very much. Дальше у нас Виктор Викторович Рерих. Хирургическое лечение повреждений грудно-поясничного отдела позвоночника. Surgical treatment of traumatic fractures of thoracolumbar spine.
Уважаемые коллеги, гости этого большого форума, который, к счастью к нашему, проводится... Микрофон нужен? К счастью к нашему, что этот форум состоялся и является регулярным. И я так понимаю, что на территории России большинство это форум состоялся, но я думаю, что когда-то он переместится на другие материки, это очень будет приятно. Но сегодняшняя, конечно, моя речь не о том, лечение хирургическом повреждении позвоночника. Тема достаточно актуальная в силу того, что, несмотря на то, что в течение определенного времени изменяющей классификации давали нам какое-то определенное направление лечения этих повреждений, сейчас новая классификация дает в бальной оценке определение тактики лечения, однако вот вопрос с взрывными переломами, а сегодня посвящу как раз свое сообщение этому, он остается не совсем понятным. Так, полные взрывные переломы нужно все оперировать, а неполные, вот здесь вообще, скажем, большой стоит вопрос. Я понимаю, что есть атипичные переломы, которые формируются из того, как реализуются механизмы травмы. Вот в данном случае, когда один фрагмент средней колонны тела позвонка, он выходит в сторону позвоночного канала, вызывая компрессию корешков или спинного мозга, в данном случае компрессию корешков, он требует хирургического лечения, и этот пациент нам был оперирован, крайне редкое повреждение на самом деле, и он требует подхода заднего, для удаления этого фрагмента, уменьшения и устранения компрессии. Иногда необходима стабилизация, когда вдруг во время выполнения операции в какой-то степени повреждается и задняя опора крови, суставы. Это будет правильно. Но мы говорим, что много литературных данных говорит о том, что взрывные переломы, к сожалению, к нашему, они лечатся и консервативно, и хирургически, и те, и другие говорят, а почему их нужно лечить именно так? Может быть, где-то на какой-то стадии мы неправильно понимаем и занимаемся сверхлечением. Есть такой термин. И, наверное, здесь следует разобраться в следующем, что те, которые говорят о консервативном лечении, в какой-то степени они правы, потому что любое хирургическое лечение влечет за собой определенное количество осложнений и дороговизну этого лечения как такового. Но ведь эти переломы, взрывные и полувзрывные, они занимают практически 40% от существа именно компрессионных переломов, это в группе А. И они же являются основным продуцентом так называемых посттравматических кифозов. И, видимо, все-таки здесь мы недооценим какие-то факторы и не принимаем неправильное решение тогда, когда выходим на именно какой-то вид лечения, на тактику лечения этих больных. Конечно, очень хорошая классификация в свое время, в 1996 году, придуманная и предложена Маккормаком. Она определила некоторое распределение таких переломов взрывных с точки зрения применения технологий. Задний доступ, передний доступ, надальный и вентральный доступ как таковой был тогда необходимо выполнять, когда при наборе баллов более 6, в конечном итоге мы предлагали, что задняя фиксация будет неэффективна. Это была основная часть направленности этой работы, и она, в общем-то, сейчас работает, скажем так. Но когда мы касаемся снова консервативного лечения, существуют, видите, метаанализы, которые говорят, да, можно лечить таких больных консервативно, но альтернативы можно применять заднюю фиксацию, как транскутанную, так и открытую, но авторы говорят о том, если только вы принимаете решение в сторону консервативного лечения, этим больным с повреждениями A3, A4 необходимо обязательно проводить МРТ. Почему? Потому что все-таки мы не знаем точно при таких повреждениях, имеется ли так называемый частичный, неполный разрыв связочного аппарата, который не всегда диагностируется и является как раз тем моментом, который приводит к формированию посттравматических деформаций как таковых. Помимо этого, существует мнение, и не мнение, а это статьи, которые подтверждают, что посттравматические кифозы, которые формируются при лечении больных консервативным сном, имеют определенную предрасположенность к тому, имеются риски их возникновения. И рисками такими являются это возраст свыше 50 лет, индекс массы тела высокий и локальная кифоза от 15 до 20 градусов, которые в большинстве своем дают в конечном итоге при течении и лечении этих более консервативно посттравматические кифозы. Какие же методы лечения применяются, если говорим о задних доступах? Конечно, перкутанные методы лечения или открытые, они между собой практически по эффекту устранения и коррекции кифоза и восстановления высоты, они одинаковы по эффективности. Но имеется преимущество транскутанных в времени операции, в кровопотере, в возможности и нагноения, конечно, меньше же, но и меньше болевые ощущения в послеоперационном периоде, как всегда у них. И таким образом существует определенный пул понимания того, как мы должны все-таки лечить больных со взрывными переломами. Это вот Германское общество травматологов Ортопедов, оно выбрало определенные показания к этому, и мы с ними согласны в этом случае, когда мы говорим, что если локальный кифоз существующий имеется где-то больше, чем 15-20 градусов и боковой скорость 10 градусов, да, то это уже показания хирургии. Но при этом, если все-таки тело позвонка или вентральная колонна снижена менее чем на 1/3, то восстанавливать колонну как такой вентральную не надо. А вот если оно более 50%, то, конечно, вентральную колонну восстанавливать надо обязательно. Конечно же, здесь имеет значение выбор лечения, когда имеется критическое смещение канала, позвоночного канала, которые могут вызвать последующие неврологические проблемы. И очень важный, который фактор должен здесь очень отмечать и применять или знать докторам, в том, что есть так, чем больше раздробленное тело, тем больше показаний к существующему хирургическому лечению. Ну и LC, так называемый Load Sharing Classification, она говорит о большей степени тогда, когда имеется больше баллов, более 6. Какие же методы лечения? Вот нейрохирургическое сообщество, конгресс неврологов говорит о том, что все-таки нет различия между существующими методами, вентральными, длинносегментарными, короткосегментарными и с пластикой тела позвонка, либо короткосегментарно с введением винта тела сломанного позвонка. И это одинаковые эффекты по существующим в конечном итоге результатам лечения. Тем не менее, спорные вопросы, которые вот 91% хирургов из 30 национальных округов были опрошены по отношению к правильности формировки посттравматического кифоза, они сказали на вопрос, а почему он возникает? А они говорят о неправильно выбранного лечения. Вот видите, какие противоречия до сих пор существуют, и они до сих пор не решены. Исходя из этого, мы сделали литературный обзор, достаточно его опубликовали, данные этого обзора, и в этом литературном обзоре мы подобрали те статьи, в которых обсуждается как раз лечение взрывных переломов. Причем преимущество вот между коротко-длинной сегментарной фиксацией, введение винта который увеличивает стабильность, так называемого сломанное тело позвонка, а также преимущество циркулярной фиксации или гибридной стабилизации по отношению к циркулярной фиксации. В результате этого было отобрано 14 публикаций, в которых 22 технологии или методы были освещены. Всего этот пул пациентов, которых был опубликован в этих работах, был более 1000 человек. Они были посвящены как раз и кифозом и коррекции кифоза и так далее. Но меньше в этих статьях обсуждалось исходы, то есть болевые ощущения и функциональные исходы в дальнейшем. В конечном итоге мы получили следующий вариант. Очень интересный. Из существующих 22 и тех методик, о которых мы говорили, примерно все одинаково работают, если кифотическая исходная деформация до 20 градусов. Они одинаковый результат коррекции имеют. И в дальнейшем, когда за ним наблюдают больными, они примерно один результат дают с точки зрения отсутствия потери коррекции и возникновения посттравматической деформации. А вот если все-таки имеется деформация более чем 20 градусов, и тогда на первый план выходит лучший вариант, так называемый лучший результат, который это гибридная стабилизация, а также циркулярная стабилизация, то есть вентральный спондилодез и короткосегментарная фиксация. Таким образом, если мы говорим о выборе метода лечения взрывных переломов, следует учитывать прежде всего и деформацию, прежде всего, это далее по шкале LCD определять обязательно бальную оценку давать, и очень важно это насколько имеется мультифрагментарность перелома, многофрагментарность перелома этого повреждения как такового. Несомненно, в ряду методов лечения, которые направлены на лечение именно таких пациентов с взрывными переломами, первый метод занимает задние методики таковые, но если все-таки деформация превышает 20 градусов и бальная оценка все-таки по LCD будет более 6-7, скажем так, все-таки дается основание тому хирургу принимать решение, чтобы включать в лечение и вовлечение, оперативное лечение на вентральной колонии. Спасибо за внимание.
Спасибо, Виктор Викторович. Next presentation, strategy for the prevention and treatment spinopelvic imbalance. Рената Тешейра.
Okay. Well, let's talk about strategy for prevention treatment spinopelvic imbalance. Please, Sergey, forgive me for the time. I'll do my best. Okay. Well, you all might know about the principles of measuring. We got low SVA, less than 5 millimeters. The PT is very important, less than 25. We also have to have a proportion between lumbar lordosis and PEI. And T1 tilt is becoming more important year after year and included in the measuring planning. Okay. We also, both global malalignment, trunk inclination compensation, pelvic retroversion, the T1 pelvic angle is very useful to be used, especially in post-operative patients, because it doesn't change while the patient changes the position. So it's very useful for following up the patient. We also have Take Care with T1 slope is a reference of global alignment. Sometimes we got difficult to get a good X-rays from the cervical thoracic transition. So many is often this angle is not measured, but it is a very predictable for problems just like failure, proximal failure, or a positive sagittal balance is related to a worsening quality of life. T1 slope CN should be under 20 degrees. Otherwise, you have to have a compensate of C0, C2, and it means something that you can relate it to PI to lumbar spine, a correlation like that. You can consider T1 to the cervical spine. When you think to sagittal balance, you should think global. In this patient, for example, with a high T1 slope, we are not high PI. A high overcorrection lead to a failure in PJK. So you need a revision surgery through C5. So must take care of overcorrection, the T1 slope, and the PI. You know also the sagittal balance, the morphology of sacropelvic determine the alignment of the spine. One must pay attention with low PI, as we have in type 1 and 2, and normal PI in 3 and high PI in 4. Take all in count of this. Low PI has less capacity for compensation. You see in these two cases, the story is different in positive operative follow-up. Well, we used to use a classification of Schwab, but recently we take in count the global alignment. Also, we include the T1S and cervical parameters also to planning the surgery. See this patient. This patient has a well-balanced spine, sagittal, a good sagittal balance. It predicts a good result. It's a stiff adult scoliosis, and we'd like to say that TC is also useful to planning surgery. This patient has a lot of hypoplastic pedicles, so it's a hybrid instrumentation with screws and bands, polyester bands. And just posterior surgeries, just wedging osteotomy, low bleeding. It's a surgery that underwent with low complications. If you use small osteotomies instead of big bone osteotomy. To reach better goals in treatment, we should classify. Classification is useful and help us how to treat patients. So this classification from Berjan is very useful. We talking about type 1 localized, type 2 localized apical, type 3 extensive, and type 4 unbalanced type with sagittal and coronal imbalance, and very easy to. Then we have type 1 non-apical, type 2 apical, type 3 extended, and type 4 A and B sagittal, and coronal. It predicts how we can do the treatment. For example, we know that positive sagittal balance was the most reliable predictor of clinical symptoms. Significant coronal imbalance, or greater than 4 centimeters, was associated with deterioration pain, such as this patient, you see 6 years, SVA 6.5, sagittal imbalance, spinopelvic imbalance, PI less L lumbar lordosis, it's 10 degrees. If we use a Keen rule for calculate a predictable lordosis, we can add PI with thoracic kyphosis, less 45, then it's an average number to reach the lumbar spine and a good balance. This space, there's a listhesis also. And the surgery can be, as we have a flexible spine, it's interesting when you see the MRI, while the patient is laying down, you see there's a good flexibility. So some patients, excuse me, how to come back? I need to come back. Got a problem here. Okay. So this curve is not stiff. You can also you can see easily that there's a thoracic lordotic, and you see there's a high PA. So it's a flexible patient that you see in the MRI when the patient is lying down. It's correct. So you don't need to be a hard osteotomy. Just posterior osteotomy, you can reach a good result, a good balance, and SVA, very good SVA, neutral SVI. The etiology of iatrogenic imbalance is almost the surgery. Instrumentation, thoracolumbar fractures, lumbar disc arthrodese, multiple laminectomies, lumbar disc degeneration, and distracted instrumentations are the main reasons. For example, in this case, we got a flat back lordotic, so we might overcharge the upper disc, and we got a symptomatic spine. Key decisions, to do short or to do long fusions. When powerful correction is necessary, PSO, VCR, always positioning the patient on the operative table with the hips extended. It's very important when you try to get real-line surgery. This patient is a doctor, underwent for two surgeries. He had complications, fistulas, and everything. But he remains with a L4, L5 stenosis, and the main symptoms were when he is stand. When he lays down, he's not so symptomatic when he was laying down. And when you see the X-ray, just the X-ray without charge, you see a completely different patient. So X-ray is very useful, and bending test or laying down X-ray comparing with standing is important. In this case, we just decompress L4-5, and with small osteotomy, just posterior osteotomy without any bloody replace, could reach a good balance. The complication rates in wide osteotomy, just SPO, even VCR or Smith-Meter, PSO, are high. We have to be efficient and effective. In this, for example, this patient is a sportsman, volleyball player. He got a loss of lordosis, 4-5 degenerative disc disease. You do with a posterior approach and restoring lordotic restoring falling King's Road. We reached the correct lordosis and restoration of the balance. 6 years after surgery is a predictive lumbar disc level in the coronal plane with 10 degrees predict proximal disc disease. We take care in coronal plane as well as in sagittal plane. Adjacent disc disease is very frequently after primary surgery. There's a patient with 6 year post-operative, SVA 6.4, 5.3, thorax C4 is 33. And when the patient is laying down, again, laying down, you see there's a compensatory deformity, and it's flexible. So with posterior approach, we don't have any structural thoracic deformity. We got a good PI, 60 degrees, so just posterior surgery with small ostomy, wide ostomy is enough to correct. Another predictable measuring for PJK is this the upper instrumented angle with the hip. When the optimal number is around 11 degrees, this paper is very interesting, and you can see how can it correlate with the deformity, post-operative deformity. Another patient, 2 degrees of posterior collapse, and few times later, a PJK is a predictable measuring, and you got a stiff lumbar spine flat, and of course, in this case, with a good PI, but in this case, you have to do some radical osteotomy because you got a stiff curve, different from the previous case I have shown, extend for thoracic spine. How to prevent PJK? We should try to keep lumbar lordosis bigger than thoracic kyphosis, less than 5 centimeters in SVA, avoid fusion with pelvic in retroversion by PT correction, accurate patient interview and clinical assessment, avoid hypercorrections. PJK risks: age, osteopenia, comorbidity, severe sagittal positive balance, high-grade lordosis corrections necessary. One of the complications is sacral fracture after L5-S1 fusion. Risk factor, high PI, and age. When you got high PI, it's difficult to obtain high lordosis correction. The shear force associated to high pelvic retroverse cause sacral stress fracture. This patient, 72 years, high SVA, with a compensatory spine. You had a sacral fracture, sacral fracture for overcharge, so stress fracture. And let's follow here. Okay. This patient, can you come back. Two slides, please. Just 2 slides before. Okay. We have to take care, for example, this space is interest. There's a lumbosacral junctional sacralization L5. So if you see the measuring, considering the S1, you got a PI of 80 degrees, but if you consider the upper plateau is 47, it's a pitfall. This patient underwent surgery, but they did not consider the sacralization. So he was treated from T10 to L5, and in the immediate follow-up, he was worse than previously. He has now a positive sagittal balance than preoperatively. And we had the retribution of the cage and the screws in the L5. And to solve the problem, we have to went to sacropelvic fixation and relocation L4, L5 screws. When you have high PA, sometimes you have to do that. Pseudoarthrosis is also a very common complication. It's associated with lower functional outcomes, most common in L5S1 and thoracolumbar junctions. Risk factor, age, osteoporotic, thoracolumbar kyphosis over 20 degrees and long fusion levels. Recommended bicortical sacral screws, iliac screws, and interbody fusion. This patient has a pseudoarthrosis and also a predictable sign for a proximal PJK. Underwent to a revision surgery. The fellow tried to use cement screws distally instead of using iliac screws. Initially, you got a good result, but it failed. You can see a pseudoarthrosis in L5S1, so you need really, it's desirable to go to iliac screws. So, sacropelvic fixation is excellent in distal. Fusion rates is around 95%, is recommended for high-grade spondylolisthesis and long adult scoliosis curve corrections. Highlight pitfalls. Be aware with distracting instrumentations. Avoid 90 degrees position in operative table. The greatest correction is obtained with PSO, but the great blood loss also with PSO. SPO is a little corrected. If a little correction is needed, SPO or local osteotomies are desirable, and it can be combined with anterior approach, decreasing the rate of pseudoarthrosis and failure. Use iliac screws when necessary, and always think global. Study all aspects of the spine, from cervical to the pelvis. The high incidence of mechanical complication can be greatly reduced with knowledge of spinopelvic relation and always looking for sagittal balance. Muito obrigado. Ogromnie spasiba.
Thank you very much, Renato, for excellent presentation. Next presentation, gap score evaluation for prevent mechanical complication. Dr. Kaglar Yugor. Hi.
Hello. Thank you, Mr. Chairman, for this great invitation to be a part of the BRICS spine session. I will be presenting this talk on behalf of me and also my colleagues from the European Spine Study Group. And there are no disclosures that are relevant to this talk. So the gap concept and the normalized targets around it is actually, if we wanted to talk about it from the beginning to the end, it would take us maybe hours, but in this 8 minutes, what I want to stress is actually about 3 main points about this score, which is the PI-adjusted parameters of the radiographic measurements of the pelvic tilt and sacral slope in relative pelvic version, lumbar lordosis, and global tilt or T1 pelvic angle, which is the relative spinopelvic alignment. So these 3 are adjusted according to PI. And I want to talk about the lordosis distribution index we have, and the age factor, which are the 3 main philosophies behind the GAP score. And here you see them in writing: the PI-adjusted parameters, distribution of lordosis, and alignment goals through the ages. So I want to start with an allegory. As you know, in Turkey, we have a national drink, which is rakı. So let's assume that we were doing a study on rakı, how you drink it. And what you do is actually you pour the alcohol and then you add water and you end up having a magical drink like this. But actually the thing is there are so many different brands with so many different alcohol levels. So there are 2 components in the glass. One is alcohol, but the amount of alcohol from brand to brand differs from 40 to 60%. And then you add water, which has no alcohol in it. But these 2 actually affect the amount of alcohol in the glass, because you can use singles, you can use doubles, or you can use all these other options of rakı versus water in the glass. So let's take an example of a study where the aim is to drink rakı without getting drunk. So we have exactly same glass of glasses in our hands. And let's say that we put rakı from 3 different brands, 40%, 45%, and 50%. And let's say that we use the same amount of rakı for both, and then same amount of water. So here, if I were to ask anyone in the room which has more alcohol in the glass, everybody will be able to say that this one. Okay, so next step, let's make it a little bit harder. Let's put a 50% alcohol in a single, 45% in a double, and then 40% in a triple, and then add water. Now, if I ask you, you cannot answer in a second, but you can think about it for 10 seconds, and then you can figure it out. But let's make it, one more level up. Now, it's just, I'm not telling you the doubles or triples, and it's not exactly, in proportional amounts. So now try to guess which one has more alcohol in it. And now it's getting even tougher and tougher. But how you can do it is actually looking at the relative amount. This is relative 20, this is relative 19.3, and this is relative 15. So now if you just see the relative amount, you can know it in a single second. So this is actually the mentality behind the PI adjustment. So we know PI and sacral slope, PI and lordosis, sacral slope and lordosis are in a relation, in a correlation. So this means that when pelvic incidence increases, the pelvic tilt also increases. And this is an anatomical parameter. This is not a way of understanding retroversion of the pelvis. So this is, in statistics, is referred to as covariate. And to be able to make the analysis, the covariate has to be removed statistically and mathematically. So we have this covariance of pelvic incidence in the pelvic version, in lordosis and spinopelvic alignment. So we have to use these, the pelvic tilt, the sacral slope, the lordosis, global tilt and TPI. All of this has to be adjusted according to the PI. So what does actually that mean is, if you look at this image, let's say that we have 3 different patients, all of them having the same PT. We measure the X-ray, the pelvic tilt is 25. So what we think, because it's over 20, we assume that it is retroverted because it's 25. But in reality, if the pelvic incidence is 50, the expected value of PT is lower, and this is retroverted. This is true. For a pelvic incidence of 65, this is exactly at the expected value. So this is normal version. For a pelvic incidence of 80, actually the expected value is much higher. So 25 is anteversion. So the same number of PT or sacral slope can mean retroversion, normal version, and anteversion. And this is true for alignment. This is true for lordosis. But why we are talking about this? It's because this is affecting the mechanical complication rates. So what about the distribution of lordosis? So let's assume we have 3 patients with the same PI, 50, 50, 50, and same lordosis, 60, 60, 60. If we drove the midline and make different lower arcs, so this is lower arc 40, this is lower arc 50, and this is lower arc 25, then actually, if we want to stand up tall, if we want our head to be over our hips, actually these 3 will get very different very different kyphosis distributions. And this is important again, because what we thought before was that distribution of lordosis was 2/3. We always thought that 2/3 of the lordosis was in the lower arc, but this is not a constant number. Depending on the PI, the distribution can be as low as 50 or it can be as high as 80. And this is again affecting mechanical complications, as if we get both aligned, we get very low percentages of complications. If one of them is either the amount or distribution of lordosis is not good enough, we get 47%. And if one of them is severely malaligned, then we get more complications. And lastly, about the alignment goals through ages, what we tend to think is that, okay, with aging, we change. With aging, we lose lordosis. With aging, we increase kyphosis. So some of the colleagues think that when we operate on older people, we have to do age adjustment, saying that we have to do less correction on them because they are old. But actually, in the gap concept, the age factor is exactly saying the opposite. We are saying that, okay, so aging is important because of osteoporosis, sarcopenia, balance failure, all of these things are important. It's increasing our frailty, but the alignment goals are the same. But the biology, the tolerance to this alignment is different. So if you are younger, you tolerate deviations more. If you are older, you tolerate deviations less. But biomechanically thinking, a non-fused spine in a non-ideal alignment, it might be okay. But if you fuse this patient in the same position and override the compensation ability, it's not the same. So these might be having same lordosis, but these are very different 2 situations. And here in the ESSG database, what we did was a principal component analysis and an unsupervised clustering. Mainly this blue and the brown is frail and non-frail patients according to these 120 different parameters that we looked at. So, okay, here are the young ones, the non-frail ones. They are getting 30% of mechanical complications in general. And here in blue, we see the frail patients. They are getting twice as much complications. But this is the whole population. If we distribute them according to the gap scores postoperatively, if you do a proper alignment, then these guys who used to have 30% of complications will only get 8.5% of complications, while the old ones, the frail ones, are going to get twice as much. So even if you do perfect alignment, these guys will get more complications, of course, because of all the other problems they have. But if you consider having less than ideal correction, they will get 5 times more complications, up to 60%. So we have to align them proportionally, but again, they will be more risky than the youngs. So, okay, life is a kyphosing process, but if we do that in spine surgery, that's called flat back and we shouldn't do it. So all in all, when we get all these together, the relative parameters, the distribution and the age factor, we get the gap score, and we call them proportioned, moderate, or severely disproportioned. We use this sheet to put where the patient is, and it's a surrogate for the conus of economy. And here is one patient example as to show. So 84 years old, very old, operated 9 months ago, and already the patient is loosening, and the patient can't stand up straight. And looking at it with the gap score, this is a PI of 64. It's a little bit big PI. And you can see this is a severe disproportion, 51 degrees of lordosis lag. So when we plan accordingly what we want to do according to the gap score and plan an aligned, proportioned alignment, looking at it in 3D, looking at the rod shape we should have, and the rod shape we have, and actually we go and do the surgery, What happens is, as you can see from here, in the coronal plane and in the sagittal plane, the patient was compensating from the lower extremities. Now it's not. The thoracic kyphosis now looks better. The patient looks taller. And 2 years, no mechanical complications, and the quality of life improves. So in summary, this is what we call personalized planning on the GAP score. We use these indices of relative measurements and the distribution, and we use this independent of age. Of course, to understand about the mechanical complications, you have to know the bone quality, you have to know the muscle quality and everything. You have to know whether pelvis is fixated or not. But regardless of all these other things, if you want to get good alignment, which is most important in the complications, you have to do it according to the GAP score and get rid of the need for compensation in a way to get lower mechanical complication rates and better patient-reported outcomes. Thank you.
Thank you very much, Егор. У кого-то есть вопросы? Могут задать?
So can I make a comment?
Yes, please.
Dr. Yilgard, this is a wonderful, wonderful talk. And I think we are all very, very confused about adult deformity, especially in our country, where we do not treat our older patients as frequently as we do in Europe or in other countries. So this is a very important concept that we have to understand, and you put it beautifully. Thank you so much.
Thank you. Thank you for the great comment.
Егор, I have a question for you. Have you ever estimated condition of the muscles from patients with deformity? Because we always focus on the balance, on the bone quality, implants, different parameters, but sarcopenia, it's always can change everything. If patient in bad muscle condition, how do you decide this question?
So I think this is a really important question. So this is actually, so we use age factor, which is very basic, like 60 or lower than 60 in the GAP score. But it's, it doesn't really give you an understanding of the muscles or the bone quality, of course. But we are just adding there to make you realize that you already have 1 point from the age factor. So now you have to be more precise. But of course, in real life, we have to do what you are telling us. So we have to look at the MRI. We have to look at the shape of the psoas. We have to look at the fatty degeneration. And how we use it in GAP score planning is, so in the examination, if we see that the patient has really low muscle volume and functionally the compensation ability with the muscles is not good enough, maybe you can think that this patient is not a good candidate for stopping at T10. Let's say if you are, if you have to go to the pelvis, then T10 pelvis in this patient may be a little tricky because of the compensation. So maybe then you need to go higher. But in other cases, you can use it the other way around. And in a patient that you think you should go to T2, because you think that PJK is going to happen, what you can do is, if you have good musculature, then you can use a good proportioned alignment up to T10 or L1 or T12, and then stop there, and then you don't need to do the rest, and the patient can, keep their posture. But of course, we cannot beat the natural history of the disease. So let's say if we operate the patient at an age of 65 or 70, in 5 years, in 10 years, of course, the musculature is going to go, worse, and the bone quality. But this is how we tend to think. Or what we do is, let's say we have a single level or 2 level problems with a spinal stenosis or a very easy level 1 slip. Then what we do is, if we look at the GAP score and the musculature, and if we think that doing a 1 level or 2 level surgery, we cannot reshape the patients, so we are not going to get good alignment, we are going to end up in severe or moderate disproportion, then actually what we use this information to as doing non-instrumented surgery. So we just do a minimal invasive decompression maybe, do no instruments, no fusion, and then, buy some time because we know that if we do a single level with this musculature and this alignment, in 1 or 2 years, the patient is going to come back with adjacent segment disease or a PJK, and we have to do additional surgery. So it's not included in the gap score, but it's included in our thought process of all these other, muscles, bones, the balance of the patient and everything.
Thank you very much. Stay with us. One more question.
Можно по-русски задам, если перевести можно будет. Спасибо большое за интересный доклад. Данной системой мы используем в своей практике. Мне один маленький технический вопрос. Вот у вас в программе есть так называемый параметр индекс распределения лордоза. Как вы его рассчитываете? От идеального поясничного лордоза или от фактического?
Можно еще раз короткий вопрос повторить?
How do you measure lumbar index lordosis from ideal lumbar lordosis or other?
So what we do is actually we always measure L1S1 and L4S1. And we know we have made this talk, many times with Professor Rusoli and their team as well. And we know that in different PIs, in different shapes of the spine, we have actually different, length of lordosis and different length of lower arm. But in the sense of practicality and having the made analysis between this lordosis shape and that lordosis shape, what we are always doing is we are measuring from L1, S1 and L4, S1. And we have shown that this works for different PIs and different Rusoli types the same way. So actually, the best thing would be to measure lordosis at every segment. So you have to measure L5S1, you have to measure L3S1. But, always we have to make a decision between being more precise or being more practical. If you have enough time and if you have this software that can measure every segment, then I think it's better to think segment by segment. But if you just have, like in the clinic, you are seeing the patient for, a small amount of time, then L1 and L4 will give you enough information. And then when you divide L4 by L1 and get the distribution indexed, what you have to know is that throughout the PI, it's not the same. It's not 2/3. So the reason for it is because L5S1 and L4, L5 is 2 levels of disc, and there is a limit what lordosis you can get with only 2 levels. Maybe let's say L5S1 is 20 degrees and L5 is 15. So these 2 discs can give you 35 degrees or 40 degrees at maximum. And if you have a small PI and the amount of lordosis you need is not too much, then the upper discs do not have to be lordotic, because you already have enough lordosis in the lower arc, so that it means that the distribution is high. So the lower arc compared to the everything is like 80% or 85%. But let's say if you get bigger and bigger PI and the amount of lordosis you need increases, now the upper segments has to get lordotic as well. So when you divide L4S1 to the L1S1, actually now the distribution is smaller. It's almost, let's say, half is in the lower arc and half is in the upper arc. But what we were told before was that 2/3 is in the lower arc. And this is true for a medium-sized pelvis, let's say a pelvis around 50, maybe 40 to 60 degrees of PI, 2/3 might be okay. But if the PI is smaller, then you get more of distribution. If the PI is small or bigger, then you get a smaller distribution.
Thank you very much.
Как исключить дефицит лизосомной кислой липазы и гипофосфатазию? Краткое руководство из 5 шагов. Позвоните на бесплатную горячую линию программы диагностики. Зарегистрируйтесь в программе, заполнив информированное согласие. Вызовите курьера и получите индивидуальный конверт с фильтр-картами и сопроводительными бланками. Воспользуйтесь фильтр-картой для забора крови любым из доступных способов. Из специальной пробирки СДТА, из шприца сразу после забора крови, непосредственно из прокола на пальце или пятке. Капли крови должны полностью пропитать все круги с обратной стороны. Аккуратно высушите пятна крови в течение 4 часов при комнатной температуре без прямого попадания солнечного света. Не прикасайтесь к пятну крови. Упакуйте фильтр-карту в чистый конверт или в зип-пакет с осушителем и отправьте образцы, направление пациента на исследование и информированное согласие пациента через горячую линию программы. Ожидайте результаты, которые поступят вам на электронную почту от 25 до 45 рабочих дней. Ранняя и точная диагностика дефицита лизосомной кислой липазы и гипофосфатазии имеет решающее значение. Оформите заявку на участие в программе 8 800 301 06 51.
Виатрис. Мы помогаем людям во всем мире сохранять здоровье в течение всей жизни. Мы стремимся расширить доступ к высококачественным препаратам для всех пациентов всегда и везде. Виатрис. Мы видим здравоохранение не таким, какое оно есть, а таким, каким оно должно быть.
Двигаемся дальше. Профессор Михайловский. Long-term results of the surgical treatments of Sherman disease.
Уважаемые коллеги, Хольгер Верфель Шерман 102 года тому назад опубликовал вот эту работу в маленьком датском журнальчике. Первое описание так называемой болезни Шейермана, как мы сейчас ее определяем. И, в общем, с тех пор очень мало изменилось в представлениях о том, откуда эта болезнь берется и как она течет. Консервативное лечение более или менее бывает эффективным, если оно применено правильно и по соответствующим показаниям, можно исправить до 35-39% деформации. Правда, и потеря коррекции бывает существенной. В хирургии болезни Шейермана, которая по-серьезному началась где-то в начале 80-х годов прошлого столетия, до сих пор остается довольно много неопределенных вопросов, и на некоторые из них мы попытались ответить. Одна или две стадии, одно- или двухэтапное вмешательство, проблема проксимальных и дистальных переходных кифозов, качество жизни, связанное со здоровьем после хирургии, и проблема публикаций с большими сроками наблюдения. Показания хирургии у нас всегда были такими же, как обычно по всему миру, то есть деформация 65-70 градусов, косметический дефект, выраженный болевой синдром, неврологический дефицит бывает крайне редко, у нас не было, по-моему, один случай был всего. Из 213 больных, оперированных начиная с 1997 года, мы отобрали 43 пациента, у которых был полный пакет данных при сроках наблюдения более 5 лет. Большинство – мужчины. Средний срок наблюдения – 7 лет. Мы разбили их на две группы. В первой группе А было 35 человек, оперированных 2 этапа. Передний релиз, дискоктомия, задний спондилодез и инструментирование. И вторая группа, где был только задний этап. Значит, группы по таким показателям, как возраст, соотношение мужчин и женщин, BMI совершенно одинаковы. И по всем остальным показателям эти группы также одинаковые. Если есть только один показатель, выделенный темно-синим, третья строка сверху, это предоперационная мобильность деформации. Что касается коррекции, потери коррекции в разных группах, нет достоверных различий между полученными данными. Таким образом, мы делаем вывод о том, что в общей группе нет преимуществ у операций, выполняемых в два этапа. Мы получили 48,6% коррекции, причем 86% из этой коррекции мы сумели сохранить в течение всего периода наблюдения. Поясничный лордоз вел себя вполне приемлемо и не выходил за пределы нормальных показателей. Проксимальные переходные кифозы – это очень большая серьезная проблема, всем нам хорошо известная. Мы отмечали их у 21 больного из нашей группы, то есть 48%. Нас интересовало два фактора, вообще очень много факторов выделяют, возможных факторов развития PGK. Нас интересовали два: включение в зону инструментирования верхнего концевого позвонка и объем достигаемой коррекции. Так вот, если включали мы верхний концевой позвонок в зону инструментирования, PGK был в 45% случаев, если не включали в 60%, достоверного различия нет. То же самое касается объема достигаемой коррекции. Больше 50% или меньше 50% абсолютно идентичный результат. Вот пример проксимального переходного кифоза до операции, сразу после первого вмешательства и после того, как нам пришлось продлить инструментарий в нижний шейный отдел. Дистальные переходные кифозы в нашем материале мы отметили в 39%. Мы опирались здесь на так называемый сагитально стабильный позвонок, который выделил доктор Чо. И если нижний инструментированный позвонок расположен был проксимально по отношению к сагитально стабильному позвонку, дистальный переходный кифоз формировался в 75% случаев, а если на уровне сагитально стабильного позвонка или дистальное, всего лишь в 5%, и это различие совершенно достоверно статистически. Вот, пожалуйста, пример правильно избранный нижний инструментированный позвонок, все совершенно нормально. Вот здесь выбран неправильно и развился дистальный переходный кифоз. Осложнений было всего 16 у 14 больных. В основном это были так называемые implant-related complications, 2 PGF, которые потребовали повторного вмешательства, ну и некоторые общехирургические, которые не повлияли никак на результат лечения. Качество жизни. Вот здесь любопытные данные. Мы пользовались опросником СРС-24. Я прошу вас обратить внимание, что по всем 7 доменам было отмечено улучшение в течение всего периода наблюдения. Не всегда это улучшение было статистически достоверным, не по всем параметрам, но оно всегда имело место, и особенно вот этот вопрос: согласились бы вы сейчас на эту операцию на тех же условиях? Количество ответов «да» увеличилось с 82 до 86%. Мы исследовали всегда наших больных компьютерным топографом. Вот как выглядит болезнь Шейермана. Слева это до операции, вот этот овал, характеризующий вершину грудного кифоза. После операции и через 2 года после операции, где видны уже совершенно определенно овалы, соответствующие лопаткам, потому что кифоз исправлен соответствующим образом. И, наконец, несколько слов о литературных данных, потому что они здесь чрезвычайно важны. Мы нашли всего 4 работы, посвященные отдаленным результатам хирургии болезни Шейермана. И из них наиболее интересна выделенная красным цветом работа доктора Грата, потому что здесь сроки наблюдения в среднем 18 лет. Это очень много, таких сроков больше нет ни у кого. Так вот, у него очень любопытные вещи выяснились. при том, что клинически все было не очень хорошо, потому что была большая потеря коррекции, большое количество проксимальных переходных кифозов, но больные были довольны результатами, причем уровень удовлетворения был достаточно высокий. Вот это несоответствие между не самыми лучшими рентгеновскими и очень качественными клиническими данными, это, конечно же, нуждается в дальнейшем исследовании. И несколько примеров: гибридный инструментарий, тотальный педикулярный инструментарий. И в заключение: двухэтапное вмешательство не имеет преимуществ перед одноэтапным вмешательством. Проблема переходных кифозов очень далека от разрешения. Качество жизни у этих больных улучшается на протяжении периода наблюдения. И необходимы следующие, дальнейшие новые исследования. Спасибо за внимание.
Спасибо большое, Михаил Витальевич. У нас вопросы в конце.
Хорошо.
Next presentation, VBT for treatment of idiopathic scoliosis, expectation and reality.
Thank you again for this invitation. This time we are changing the gears a little bit. So we talked about the adults and the sagittal plane. Now what we are talking about is the adolescent patients. And anterior VBT, we have also seen examples in the session earlier in the morning. And my topic is expectations versus reality. And this is a talk that will be given by me and also on behalf of Professor Ahmet Alanay. And in the relevant disclosures, Ahmet Alanay receives royalties from one of the companies that are producing this device. So as you know, vertebral body tethering is a growth modulation technique. We do it thoracoscopically. Other colleagues do it in an open fashion. And as scoliosis is a wedging and shape-changing disease according to the Hütter-Volkmann law and Stokes' vicious cycle, what we do is we put the tether on the convex side and we tighten it, which affects the growth on the convex and concave sides, and actually reversing the Hütter-Volkmann law. And we have demonstrated that with a change of shape of the wedging of the vertebra during the growth period. So this is why we call it growth modulation. We want to change the way the patient grows. But let's talk about the expectations about VBT. What we expect: the motion preservation, the growth to continue, less complications, better health-related quality of life. And in our heads, we think that, okay, this is an alternative to fusion. This is a definitive non-fusion treatment modality. And let's see if this is matching the reality. So here I'm showing you our first case we ever did 8-9 years ago with Ahmet. We started off with a very slightly easy case who was not wearing her brace. And actually in the 8 years, we have a perfect result with 10 centimeters of growth and still very stable curve, very low measurements. And with the MRI at 5 years and 8 years, the discs are perfectly healthy. But let's see if this is true for every patient. So in our minds, the ideal case and the ideal outcome, the first part is this tree I'm highlighting in red, is the patient selection, who we should operate, and we should predict the growth potential, how much this patient is going to grow, because if you correct too much, it's going to be overcorrection. If you don't correct enough, it's going to be undercorrection. And then let's say that you selected the right patient, you predicted the growth, then how can you determine the amount of correction that's going to happen over the course of the years? So this tree is the key, and it's not very easy. So currently what we are doing is we are operating patients between 10 and 16. We classify them as really fast growing and then slowly growing. We have some limits. We generally go up to 70, sometimes 75 degrees, but those should be very flexible and bend down to 30. Otherwise, we generally go up to 60, 65 degrees. And we don't want really hyperkyphotic patients. And generally, a rib hump that's over 20 degrees might be a relative contraindication. And for the estimation of growth, we tend to look at almost everything that we can clinically, pelvis, hand, wrist, and we try to use Sanders and all the others together. And when we do, we have published this study 2 years ago. What we have shown was after the postoperative first image, when we think of it as the 0 point, what happens is if you are Sanders 1 or 2, if you have big growth potential, then you have big changes in the curve size. Compared to if you are Sanders 6 and 7, you don't have, much of an effect. And this is very variable between patients. So as you can see with the confidence intervals, there is a big variance according to the patients. And according to these observations, we have put this table in our publication. According to the Sanders stage, we have a recommendation and we have published the rationale of why we said what we said. But let's take this example. So this example is a 10-year-old Sanders 2. The triradiate cartilage is still open, so very huge growth potential. The curve is not too big, but the patient used brace for almost 2 years and she is now denying using the brace. So what we did in this patient was we, on purpose, undercorrected this patient in the first direct. You can look at the initial image and the first direct and you can think that we even didn't do any correction because we knew that the time would do a lot of correction, which it did until 3 years. Actually, you can see in the upper arc of the thoracic area some overcorrection as well. But then due to the tether breakages, there was some loss of correction, but at least she is Sanders 8 now, 5 years. And if this stays like this, this is perfect. If this is going to get more worsening, then we'll have to think about what to do. But, and this is the sagittal plane of the patient, and clinically she looks okay. But this is not enough. We think that, we have to do some AI studies. We have to know better about the bone growth. We have to look at the BMI, the hormonal status, and technical details, so we can have an understanding of, which patient to operate, when to operate, and how much to correct. And let's say that we figured out all of this, which is very hard to do, but let's say that we figured that out. Now, the next question is about the tether integrity, because this is a moving construct, and if it moves, it's going to wear out and it's going to break for sure in every patient in the long term. But how can we provide long-lasting, durable tether integrity? Because if you make it harder, then it's a rod and it's a fusion. If you make it softer to allow more motion, then it breaks. So what we have done over the years was we have used 2 tethers in the same vertebra, which we call double row. And we used to do it in the apex because these were where the tethers were broken the most. But we are not doing it anymore because the thing is that it breaks between the 2 rods and the single rod. So this we don't do anymore. And instead what we do is we do more and more double rows all around the construct. But the thing is that it still breaks. So if it's going to break, if you want motion to stay there, and if the patient moves, then eventually it breaks. But the thing is, what we want is to have this last as long as possible, 1 year, 2 years, 3 years. And we have some remodeling of the bone and some remodeling of the soft tissue that when it breaks, it doesn't really cause a big problem. So in this patient, it looks nice clinically, but in the image, there's a problem of 18, 20 degrees. And if it gets worse over the years, it might require a revision surgery. So then let's also imagine that we know how to select patient, we know how much to correct, and we have a durable tether. Now the next question is, what should be the optimal outcome? Should we expect the same as we expect in fusion in regards to correction, let's say about the rotational correction, sagittal plane correction? What is the optimal outcome of a VBT? So first, does it preserve motion as we think it is? And looking at many studies, it looks like more motion in the thoracic and significantly more motion in the lumbar area. So this is good. But if you look at the literature about having less than 35 degrees at the final follow-up, because this is intuitively, we think that if you are an adult, if you are skeletally mature, and you have less than 35 degrees at the final follow-up, then it will be okay for long term. But as you can see here, some report 90 or more of the patients being at 35. Some is 70%, but the others are 50% or even at 20%. So how can we guarantee having this? And what if we compare VBT versus posterior spinal fusion? We see that superior curve correction in PSF, more complications in VBT, and more frequent return to OR in VBT. So what is the optimum outcome? Maybe the best thing is about preventing fusion. So if we prevent fusion, maybe it's a good outcome. And generally speaking, if it's below 30, 35, it might be a good outcome. But we know that VBT, whatever we do, is not going to be as effective in terms of curve correction, but it might require more additional surgeries. So because of this shortcoming, what we think is that VBT is indicated for curves that are more than 40, 45 degrees, which are failing bracing treatment, and they are still growing. Other than that, this might not be resulting in an optimum outcome. So let's take this case as an example. This is a Sanders tree. We started off with 40 degrees, corrected to 21. So it modulated down to 10. But the thing is, in the long run, the tethers break. And if this patient, although it stayed up for 2 years like this, it lost correction, but now is stable over a year. But we don't know what's going to happen in 10 years, 20 years, if this is going to get worse or not. If it stays like this, it's perfect. If not, then we'll see. And this is the sagittal plane and the clinical pictures. So this is another example, 32 degrees in the thoracic and 46 in the lumbar. And this is Sanders 6, so she's not going to grow too much. So what we did was we only did the lumbar area. And as you have seen, the patient didn't grow too much, so it didn't have too much correction. But both curves are stable over 4 years. And this is also true for the sagittal plane and the clinics. So maybe this is okay, but we don't know what's going to happen in the long run. So then what we thought was maybe the best thing was to have a hybrid solution to get use of the good things about fusion and to get use of the good things about VBT. And this is because of the rates of tether breakages. So you can see here in the thoracic area, the tether breakage rate is 13% in our experience. In the thoracolumbar area, it's 40%. And if you do bilateral VBTs, actually the tether breakage rate is up to 80%. So almost all tethers break. But in our series, the hybrids have not broken yet. But as you can see with the mean follow-up, the mean follow-up for hybrids is only 8 months and the maximum is 2 years. So it's very early. We have just started doing the hybrids. But again, according to all this, tether breakage rates might look like it's too much. But if you look at the percentage of patients below 35 degrees, despite the tether breakage rates, 90%, 80%, 78%, or 87% of the patients are still below 35. So all broken tethers does not mean, failure. And you can see that the patients converted to fusion is around 5%. So this is, in our understanding today, is a no-go. So this patient had an open heart surgery, so already has a chest surgery, so stiffness in the chest area, 2 very big curves, and doing a single row VBT on both curves. This is almost all risk factors for a definitive failure because it's also a Sanders 5. She's not going to grow too much. But a similar or an easier patient can be treated like this, good kyphosis restoration, good correction in the thoracic area, and then using a double row tether in the lumbar, hopefully will be durable for long term. So in summary, VBT is a new way of treating patients in our practice. We still do more fusion than we do VBT. We try to select our patients, and our best results are with Sanders 2 and 3s. We don't have a good enough final prediction of the final call. Overcorrection used to be a big problem, especially in the earlier series. If you look at the literature, overcorrection was a big problem. Now it's not. We can take it under control. Today, the main problem is the tether breakage, and double row is not the solution. It still breaks. But the good news is that all broken tethers are not big failures. And tether breakage is most common with the bilateral VBT and thoracolumbar. So maybe hybrid can be a solution. Thank you.
Дальше Николай Александрович Коновалов докладывает минимально инвазивная хирургия экстрамедулярных опухолей. Minimal invasive surgery of extramedullary tumors.
Okay, so I'll talk in English, and this is talk about minimal invasive surgery of extramedullary cord tumors. Most of the medullary cord tumors, I mean, angiomas, schwannomas, and some different kind of tumors is also can be in the field of spinal surgeon who deal with these tumors. Most articles who describe the surgery of extramedullary cord tumors says about the number of the series, number of the cases. But today we're going to talk about the technique. Usually for the resection of an extramedullary cord tumor, usually you use laminectomy. It's standard, it's a big approach, big damage of the muscle. But looking forward that we start now to do the degenerative disease with the small approaches, tube approaches, also think that we can switch the surgery for extramedullary cord tumors to minimally invasive surgery. So here is the example of the first patient. It's a nevrinoma. Surely, look how small tumor this is. So you don't need a big cut for it. And so how we decide to do this? We use a navigation to find out exactly entering point for this. Then small cut, and we use a tube retractor from I think EasyGo, and through this retractor you can, if you put it correctly on the tumor, and you don't need a big cut, so you can. Not a big cut, so you. Так, у нас фильмы. Секунду. So here you see, you open the dura, you identify this tumor. It's small, so for removing the neuronoma, you have to cut both entering and going out the root, and then you can take this tumor easily out. У нас тут немножко все зависает. Почему-то не. Так, немножко технически неправильно передается изображение, но ладно. Okay. So this is the end of this case. Я прошу прощения, немножко скачет изображение, потому что видно из-за проблем с подключением системы. This is another case. This is already epidymoma of cauda equina, and so for this case we use a Caspar quadrant retractor. So, and we use the technique like we use it for the stenosis. So you do gemelaminectomy, then enlarge your approach with drilling the spinal process, and now you open the dura, and then you find the tumor. You coagulate also the linea fili terminale, and as you can see, when you remove the tumor, the approach is like the size of the tumor. Most difficult part in this surgeries is closing the dura, because it's deep, and you really need to have very experienced microneurosurgeon to put the stitches in this case. This is another example of ventral tumor. So what was the idea? So it's very easy when you do the surgery on the cauda equina, but then we understood that this technique is very. Почему у нас ничего не идет? This technique is very useful to do the surgery for the ventral allocated tumor. Why? Because if you do traditional posterior approach, you do traditional laminectomy, you see only the spinal cord in front of you. If you put your retractor, also with the navigation, little bit from the midline, you get the oblique approach, and with this oblique approach, you go under the spinal cord. And so you don't do any destruction of the spinal cord. Here you can see we open the dura, and
I will jump a little bit forward. Open the door. Okay. And so you can see here the tumor, and here is the spinal cord on the top of it. So you go directly under it. And in this particular case, it's very easy was to remove the soft part of the tumor. This is a meningioma, but it's an very old one, and you can see that the rest of the tumor is just solid stone, and it's like a ball which is hide under the spinal cord. If you go a regular approach, it will be very difficult to remove it, and you surely will get neurological deficit after it. And you can see how it's difficult, even from a lateral approach, when you have enough space to remove this calcified part of the tumor. And with very gentle preparation, we managed at the end remove it. You can see it's also sticked to the dura, and so even using the rongers, finally we managed to remove this part of the tumor, and you see how difficult it is, because it's slippery. But if you once again, because it's a lateral approach, you see a spinal cord staying under you, and here finally we managed to take it out, and you can remove such big piece of the bone under the spinal cord safely without any neurological deficit after the surgery. So we go for a more tough case. This is a craniovertebral meningioma. This is a huge tumor. The vertebral artery is also is inside the tumor, as you can see. And also we use Caspar retractor, small incision, lateral incision, and we go also under the spinal cord. So we drill, first of all, we drill C1 and C2, do only gimme laminectomy. I'll go forward. Then you see when we open the dura, you see only the tumor. You don't see the spinal cord. So in most cases, you don't need to recognize the spinal cord at the very beginning. You go directly to the tumor. Then for the old meningiomas, you have to coagulate the matrix, and do the debulking. And after doing the debulking, and surely need to send some piece for biopsy, but in this case, it's we are sure this is meningioma, because you have a matrix. Then you do the debulking, and piece by piece remove it under the spinal cord. So see, lateral approach, you don't see the spinal cord, you're just debulking the tumor, go directly to the tumor, and slowly and surely remove it. This is, I think, one of the end of the surgery. You see it's still bleeding, because not all the vessels are coagulating on the matrix, but and I'll go to the final picture, okay. And this is at the end of the surgery. You can see all the structures are safe. We still don't see, now we can see this is the spinal cord and closing of the dura. So, and this is a CT after the surgery. You see only gimme laminectomy on the level of incision. And I'll go to the last case. This is most difficult case, is also meningioma on the C1, C0 level, and it's totally ventral. And the matrix is exactly in front of the spinal cord. And if you go traditional laminectomy approach, you can never remove this tumor without getting severe neurological deficit. The same, I will pass it the same drilling, and now you open the dura, and here you see we see that we are very lateral. Still at the beginning we see some part of the spinal cord. So, and we start also with the CUSA, coagulating the matrix, debulking all this tumor, and only using the lateral approach with a small Caspar retractor, you can get the image like this, and you can safely work. When you see no traction of the spinal cord, you can working to remove part, then you can gently put another pieces in your to your approach, and also debulk it, and piece by piece you can remove it totally. I'll go a little bit forward. This is, sorry. And this is already the end of the surgery. And you know that it's very important for the meningioma is to remove it totally and also split the dura and split the place from which the tumor is growing in. And in the case of this minimal invasive lateral approach of using the Kaspar retractor, you see that we are going directly under the spinal cord, and we have enough space to split the dura and coagulate matrix to do the total removal and prevent any recurrence. So this is, you see all the nerve roots, which is C1 is safe. C1 is safe. Total removal of this huge tumor from one side from this approach, and doing only gemelinectomy. And this is, I think, very big beneficial from this minimal invasive surgery for extramedullary cord tumors, especially for ventral tumors. And I'll talk about take-home messages. So the idea is, for sure, at the very beginning, if you start only, you have big experience to do open surgeries, and then you can switch to minimum invasive surgeries. It's very important to put your retractor in a correct position. Because you need to be exactly on the tumor, and you don't need to see at the beginning all important structures like the spinal cord. You can go directly inside the tumor, do the debulking, and then in the end gently push all the pieces, and then in the end you can identify the spinal cord. So this technique is very important for ventral tumors, because you can go lateral. There's no destruction of the spinal cord during the surgery, and it's also because it's small damage of the muscles, small damage of the bones. Patients get up from the bed from this day, in 1-2 days they go home like the same, like from disc herniation. So it is a lot of clinical effect and a lot of economical benefits. Thank you.
Спасибо большое, Николай Александрович. Вопрос? Welcome.
Спасибо за блестящую демонстрацию шикарной хирургии. Николай Александрович, у меня вопрос. Есть ли какие-то критерии, такие, по которым вы определяете, вот эту опухоль мы можем прооперировать через МАЭС-хирургию, а вот эту опухоль лучше оперировать открыто?
Мы оперируем сейчас все через МЭС.
Независимо.
Ну, фактически 99, может быть, какие-то редчайшие исключения, там, когда там, ну, практически все. И причем это такая кривая была несколько лет, потому что вначале мышцы какие-то простые, и потом просто вот стали понимать, что даже вот доступ для ассистента, скорость доступа, это не стилетирование, это не ламинэктомия, здесь скорость доступа очень быстрая, это очень ускоряет операцию, скорость закрывания раны. И со временем вы понимаете, что хирургия это вещь такая, что любое растягивание операции вам нужно уже следующую делать. Мы полностью перешли на эту хирургию. Фактически все опухоли мы стараемся сейчас идти. Вот обратите внимание, полностью вентральная огромная менингиома крайневертебрального перехода. Куда сложнее.
Спасибо. А процент осложнений?
Но с ними меньше, потому что вы работаете, у вас нет тракции спинного мозга. Меньше кровопотери, меньше гематом, меньше процентов ликварей, потому что у вас нет ламинэктомии. Это то же самое, как при хирургии дегенеративных заболеваний.
Спасибо.
Самое главное, там сложность зашивать оболочку. Но если вы умеете пользоваться 6 нулями, иметь хороший микроиглодержатель с пинцетом, ну, это стандартная ситуация в трубке зашивать грудномозговую. И рекомендовано, несомненно, если у вас есть сомнения в швах, это тахокомб и клей. Сделать сэндвич. Да, пожалуйста.
Спасибо. Там у нас, я так понял, доктор Хедж подключился, да? Ну, давайте его.
So, Ilgor made some very important points, and this was just to talk about our Indian experience. Now, we all know that instrumentation in spinal deformity started about 60, 70 years back, and Harrington instrumentation was considered the gold standard. But was it really the gold standard? We all progressed to doing, for example, in a severe deformity like this, we all did the standard posterior surgery with using pedicle screws, and this was the standard of treatment, or has been the standard of treatment even now. And we know that anterior approaches to the spine steadily reduced over the last 2 or 3 decades, and this was primarily because of a belief that amongst very senior respectable surgeons that posteriors was better, and also most orthopedic surgeons were familiar with the posterior approach. But some of us who spent time with legends like Professor Jürgen Harms and Klaus Zielke in Germany, we were trained to treat deformities, also look at anterior surgery, like in this patient who had a very severe deformity. Here you see the patient has a primary severe rigid thoracic deformity with a counter curve in the lumbar spine and a counter curve in the upper thoracic spine. Traditionally, this would be done from the back, which would mean D2 to L4 and a thoracoplasty, as well as PSOs at multiple levels. This would mean a blood loss of more than 1,500 ml. But we were able to do this because of our training, selective anterior surgery for the main rigid part of the deformity, and correct it and allow spontaneous correction to happen below and above and get an excellent result. So this is what was also described by other leading surgeons who talked about saving levels when you did anterior surgery as compared to posterior surgery. And we presented our experiences where we could show saving of at least 2 to 2.4 levels in our series. And we know that to date, the surgical goals for patients with AIS, especially when they are skeletally mature, for say 40 to 50 degrees, we tend to treat them with, we tend to wait till they become more severe. But we have newer modalities of treatment, and we can look at doing different options. Now we know that bracing was used for most of these patients early on for their deformities, but the results of bracing were not very good. The failures of bracing were very high, and most of these patients had to be finally instrumented. So our treatment is based on the assessment of the curve progression, that is the degree of truncal shift, the rotation of the apical vertebrae, the skeletal maturity, and the clinical deformity and the curve progression. And we know that, as was mentioned earlier, that non-fusion anterior scoliosis. I was mentioning that bracing, especially in our warm country, has had very poor acceptance with our patients. So what non-fusion offers is that it works as an internal brace, as Dr. Ilgar had mentioned, that it works on the Heuter-Walkman law and helps to maintain the correction, and the complications are minimal, and there are no detrimental long-term side effects that we have seen. So we started also as a growth modulation, that is the classical VBT. But the word tethering in English has a very inert connotation, and it means only to hold the deformity but not correct the deformity. So when we had the child like this with the Risser 0 and the Sanders 4, with this deformity, and as Dr. Ilgar suggested, we undercorrected the deformity, and over the years, at 2 years, you can see her spine has become straight. She has a beautiful sagittal profile. And on the right side, you can see her clinical picture. She is holding well. Yes, of course, in the long term, the tethers may break. And that may be an issue that we have to wait for a long-term follow-up on tethers. Here we have a 13-year-old child who had a gradually progressive deformity. They had tried a variety of yoga and exercise treatments which had not worked. As you can see, she has a very severe lumbar deformity, what we call as a Lenke 5CN. And she had an apparent limb length lengthening because of the pelvic obliquity. Also, she had an incidental spondylolisthesis at L5S1. Now, you can see here on the left side, she is reasonably flexible. What would be the standard options? The standard options would be posterior fixation from D8 to L5. But if you stop at L5, you have to worry about the listhesis at L5S1, which may. So you may want to go to the pelvis. But that in a child who is a dancer, this would be a big issue. And the parents were not at all keen on standard posterior fusion surgery. We did a non-fusion correction of the main lumbar deformity. She has held well at 1 year. There is a slight increase. There may be a suspicion of the tether breakage. Here you see her pre-op, immediate post-op, 1 year follow-up. At 2 years, she is reasonably well. And her sagittal profile is also holding very well. And here you see her doing the traditional dance. And she is able to do extreme bending, which perhaps a child who would have been fixed into the pelvis may not have been able to do. This is another child. The important thing about non-fusion is that they are so comfortable. This child comes 3 days after her lumbar spine has been fixed, and she is so flexible. They don't have the kind of pain that most posterior fusion surgery patients have, and they are very, very comfortable. And of course, the blood loss in this surgery is minimal. And this same child at 1 year is holding well. This was done right in the beginning of our experience with non-fusion. Perhaps we would have gone one level lower in her case if we were to do it today. But at 2 years, she is still holding well. There is some increase in the curvature, but we do not suspect any tether breakage. Perhaps in Indian patients, lighter patients, we may not see early breakage of these tethers. So we now recommend that we should intervene early rather than late. Like you see in this child, in November 2021, she had all the signs of progression of deformity in classical lumbar scoliosis. And you can see that in 6 months, she has gone from 35 to 44 degrees. And in October 2022, she was 55 degrees. Having the tether now, we would rather intervene earlier rather than later. Of course, we did a correction and she has had an excellent result. But this is what we recommend. In light of our experience with non-fusion, we recommend that when we see these deformities, we do not have to follow the traditional rules of waiting till the deformity progresses to 45 or 50 degrees. We can intervene when they are even at 30 or 35 degrees. As we know, as this study which was presented recently in the Scoliosis Research Society meeting, all these deformities do tend to progress. And in the long run, we now know that if we were to intervene earlier, it is better. We have presented our experience, and it's now coming in the Asian Spine Journal, our 2 to 5 year experience. And we are happy to say that we have had Though complications have been reported with anterior surgery, we have not seen any thoracic duct injury. We have not had any atelectasis or ureteric or incisional hernias or even vascular types of injuries. So this technique in surgeons who are comfortable with anterior spine surgery, it has very low level of complications. And as Dr. Yilgar suggested, that this would be a good option in some of our patients, and we can use it to get good results. Of course, long-term has to be followed. And once we know, why would we use a specific technique when we know that the natural history of a condition is undesirable and the patient's deformity is going to progress, and the intervention alters this natural history in a favorable and reproducible manner with minimal complications, and the long-term side effects of the intervention are not detrimental, and we are not burning any bridges. We can always intervene, do in the small number of patients in where the tether may really fail and the deformity recurs to a significant extent. That small percentage of patients may require posterior correction, but most patients will be happy with the correction that they have. And this is a very good way to and a new option to manage deformity in our young children. Thank you.
Dr. Hedge, I have one question for you. What kind of system do you use? It's the first question. And what kind of system do you use for dynamic correction of the instrument? What kind of instrumentation? Yes.
Unlike the Turkish experience, we prefer to do mini open, and we actively go to correct segmentally. Like in the olden days when we were doing anterior fusion surgery, we actively correct the rotational deformity as well as the coronal deformity. And the system that we use is the Globus system from Philadelphia. This, now we have the availability of a thicker cord, and the screws are hydroxyapatite coated, which get long-term fixation in the vertebrae. The closure mechanism is of a very specific type, which does not put strain on the screws when we close on the tether. And I think it is an important factor in preventing the frequency of breakages of the cord.
Do you always use only one screw in the vertebral body, or in some cases?
I did not show, Dr. Kolsov, I did not show our elderly patients or older patients. In the older patients, in the bigger patients, we prefer to use a double cord. But now we have started using a thicker cord, which is about 2 millimeters thicker than the older cord. And we hope to see less breakages with that.
Thank you very much. Thank you very much. Stay with us. Следующий доклад Роберт Мэвес. When to add anterior approach in thoracolumbar fracture.
My name is Robert Maves. I work in Santa Casa Spine Center, São Paulo, Brazil. I'd like to thank the opportunity to participate in this meeting and represent Brazilian Spinal Society. I'm going to talk about when to add anterior approach in thoracolumbar fracture with convolution. What's the clinical relevance of this topic? First, thoracolumbar with convolution are 20% of all spine injuries, with 40% in neurologic injury in young patients. The vertebral convolution can cause kyphotic deformities and neurologic deaths because the retroprotrusion fragments into the spinal canal. There are controversial discussion about when we have to perform anterior approach after posterior fixation in these fractures. For instance, this clinical case with thoracolumbar fracture with convolution, we perform posterior approach, but despite we have the compression of spinal canal, we have implant failure with kyphotic deformities. because we don't add an anterior approach in these patients. So we can measure this combination by using load sharing classification. This classification ranges from 3 to 9 according to convolution, apposition, and kyphosis. So we assess whether it's possible to define the best therapeutic approach based on the load sharing classification. This study was a systematic literature review of randomized controlled trials. You use Embase, PubMed, Cochrane Library, Scopes, Web of Science, Lilex, and the others. These are the search strategy. The population was patients with the thoracolumbar burst fracture. We used load sharing classification to observe in 1 year implant failure with breaks or loosening the screws, loss of correction of segmental kyphosis, loss of 10 degrees of curve, and we correlate with this classification. We split in 2 big groups, less than 6 and more than 6 points. And we use this random fixated models with 5% of clinical relevance. We had 189 papers. According our criteria, we selected 9 papers to answer this question. Papers around the world. We can see in red some bias risk of these papers. However, these 90 papers are the best papers to answer these questions. When load sharing classification was greater than 6, we had 284 patients with 6 studies. We had 7 implant failures, 14 losing the correction of segmental kyphosis, and 4 patients with both complications. These are the numbers of implant failure, loss of correction of segmental kyphosis, and implant failure and kyphosis loss. By using load sharing classification, we can observe that all cases of up to load sharing 6 would show good results with isolated posterior fixation. So we don't need to add anterior approach in these patients. However, when load sharing is more than 6, the results are unpredictable. So we can conclude the load sharing classification for thoracolumbar burst fractures is reliable when the score is up to 6, and the posterior instrumentation is effective in preventing complications. When the score is greater than 6, other fractures have to be taken into account in order to define the best therapeutic approach. Thank you.
Thank you very much. And next talk is from India. Evolution of management of Hagman structure from pedicle alignment to pedicle reformation. Pankaj Singh.
Thanks. I will be speaking on how we evolved in the management of Hangman's fracture. Initially, we used to do this pedicle alignment procedure, and later on, when we got complex cases, we started doing a pedicle reformation. So this is my cases, which I did from 2012 to 2018. So I will start with what is the fundamental is that we want to preserve motion at C1, C2 joints. So we usually don't include C1 in our repair of the Hangman's fracture. So first of all, what we normally do, that is pedicle realignment technique. And this was a patient, 50-year-old male, who presented to us with a history of fall of a bamboo on his neck. He was Asia B. This was his MRI, and you can see there's quad signal change, and this is the Hangman fracture. And you can also see there is a retrolisthesis of the C2 over C3, plus the fractures on both sides. What we do is we keep the patient in prone position, do exposure from C1 to C5, and we reduce the this fracture by first positioning and then doing compression of the C2 lamina anteriorly. And sometimes we pull the C1 arch posteriorly also to do the reduction. Then we put under O-arm guidance, we put K-wires on both sides. You can see this is on the other side. And then we tap and put screws, lateral mass screws. Then we do C3-4 lateral mass screw and put a rod and do the correction. You can see there was retroangulation. What we did in this case was we did a distraction between C2 and C3 to correct the retroangulation. The patient improved to ACIC as there was cord signal change. You can see there was associated C1 3 points fracture. This is the anterior left, the posterior, and this is posterior right. And you can see a 6-7 month CT scan, there is callus formation, healing of the posterior arches on the both sides. So for a combined fracture, the basic treatment is of the hangman fracture. And you can see the healing of the fracture. This is the fracture. This is the healed fracture. Then we got a patient who had he had a fall. He had a fight in the school, and he didn't tell his parents 6 months back. Later on, he started having neck pain and quadriparesis. So he came to us. We evaluated him. This was his X-ray. You can see there was a flexion extension X-ray. There was minimal reduction on the extension X-ray. So you can see this pedicle is reabsorbed, CT angio. You can see the reabsorbed pedicle. This was the upper part of the C3, which was compressing the cord, which was leading to his quadriparesis. So we planned the surgery. This was the first time we were doing this. There was no pedicle, C2 pedicle, so we decided to put direct body screws in the C2. So we chose the entry point. You can see there was no pedicle. This is a diagrammatic representation. What we did was we put the body screws with bicortical purchase parallel to the inferior border of the C2. We did reduce it and did the pedicle reformation by putting bone chips from C2 posterior body up to the facet. So this was the intra-op photograph. You can see we have put bilateral C2 body screws. What we do is dissect the vertebral arteries laterally and directly go to the vertebral C2 body and put the screws. And 3-4 pedicle screws we used as we have to do a lot of correction and we didn't strength. That's why I didn't put lateral mass screws in these cases. And you can see the correction. And this was a post-op X-ray. This is the CT scan. And you can see the follow-up pedicle has been reformed on both the sides. And the rotation of the neck was preserved in this case. Then we got another very complex case. He had this RTA 1 year back. He came to us with quadriparesis. At that time of first injury, he had left side this right side chest infection. He got amputation of the left upper limb. So we did a radiology. You can see this was a hangman fracture, and the C2 is coming up to the upper border of the C4 vertebra. We haven't seen a case like this. We thought that it is fused, but firstly we decided that we will go for a traction. And you can see also there is lateral displacement of the C2 over C3 also, anterior plus lateral. These are the angiograms. You can see 3D recon. And this was his MRI. You can see the kinked cord here. But with support, he was able to walk. Power was 4-4. So we put him on traction and we got a breakthrough. There was slight reduction. From 4 to, it came to C3. We again did soft tissue release and put him on traction. There was further reduction. Again, we did, after that, this was this. Then again, we went in anterior and this time posterior also, do soft tissue release and put him on traction. And we can see that it has come up to the upper border of the C3. So we decided that we will go with the standard posterior C2 body screws and 3 lateral 4 pedicle screw. So this was this intra-op images. You can see this is the normal. it is not coming fully back. So we pulled the C1 arch posteriorly. So you can see there is reduction. It is coming posterior. So now it was confirmed that we can be able to do the reduction posterior only. So what we did was put a C3 lateral, C4 pedicle screws and put a rod and hooked it anterior to the posterior C1 arch so that the C2 body doesn't move. And then we put the pedicle screws, this body screws, and put the rod. And same procedure we did on the opposite side. So we put 2 body screws, C2, 3 lateral and 4 pedicle screw. And then we went interior, again anterior, and we put a bone graft and plate. So this was post-op X-ray. And you can see CT, post-op CT, lateral displacement auto got corrected. And these are the follow-up with pedicle reformation. This is the diagrammatic representation. Up to C4, it has displaced, lateral displacement. After traction, it has gone this much. After anterior release, this has gone slightly more up. After anterior and posterior release, it has gone up to the upper border. And this is intra-op. We have put a body screws, 3 lateral, 4 pedicle screw, and we have put the bone grafts from the body to the facet to form the pedicle. The post-op course was very stormy. He has at least it took, the patient was admitted for around 2 months. He had 4 surgeries. So it was around 720-degree approach. There was a chest infection, so we gradually weaned him off and put him on this stilette with oxygen for 7-8 days. Anesthetist helped a lot, and finally he was discharged. And you can see the preservation of rotation of this patient, and you can see good fusion, pedicle reformation, lateral displacement correction. So we published this. This is the first case report of pedicle reformation in world literature. And the take-home message is C1, C2 motion preservation should be tried. And big diameter screws can be put in C2 pedicle. And we can easily avoid, in these cases, the vertebral artery injury by dissecting and displacing them on the lateral side and putting direct body screws. Thank you.
Thank you very much. Может, у кого-то есть вопрос? Доктор. I have one question for you. How often do you use hollow traction in C1, C2 dislocation?
In these hangman's fracture, we don't use this traction.
Thank you.
You are asking for AD, axis dislocation, congenital.
Hollow traction only for reposition of the dislocation C1, C2.
In the hangman's fracture, we don't use, but for fixed AD, we usually go from posterior. We don't use traction nowadays. We have a procedure called DCER. So we directly go from posterior, put spacers in C1, C2 joint and do reduction. We have our own technique. Our unit head, Dr. Chandra, has devised that, and we have published that in neurosurgery also. So we usually don't put patients on traction nowadays of AD with BI.
Thank you very much.
Excuse me, I have one more question. Hello, nice to see you again, a few months later. So it's a very, very nice talk. Thank you very much. And would you recommend, in case of the pedicle reconstruction, for how long time post-op you would recommend the collar for the patients?
3 months. The standard is 3 months. We put for 3 months.
For 3 months, yeah. Thank you.
Next presentation. Gush Artem Olegovich, minimal invasive surgery of the lumbar spine.
Thank you, Mr. Chairman. I'm very happy to be here, and my special greetings to Professor Teixeira, who has only reached Moscow this time. I hope your prominent act will be signed in the history of brick spine. But anyway, I like that Professor Konovalov, who suddenly disappeared, to start discussion regarding some minimal invasive surgery for oncology, extramedullary tumors. I want to follow with this surgery for spinal stenosis process, especially for lumbar spine. And next, sorry. And we all know that some kind of algorithm already exists in treatment of stenotic process. For this theme, we actually follow the idea that it doesn't matter what's provide compression. It's very important that we stay in the position of minimal invasive decompression, and just having this process, we can perform the compression based on the idea that different kind of stenosis is actually anatomical landmarks of the spinal canal, and if the central anterior-posterior diameter less than 10 millimeters, it's stenotic process. If it's lateral canal less than 2 millimeters, it's lateral stenosis. So we can subdivide the stenosis on the actually on cervical or on the lumbar level according to this anatomical landmark, and to provide them some minimal invasive decompression in case if you don't need to provide the stabilization, and if there is no real instability, which of course needs additional instrumentation to treat such kind of patients. And also we all based on the well-known anatomical classification for stenotic process as SHIZAS, which already 10 years old, and which based on the ratio between nerve structure, liquor inside the spinal canal, and subdivide the degree of stenosis for 7 rentgenological classification, and you can understood what's the level of stenotic on the certain level. I like that now we have the nice stenosis algorithm, which actually it's provided by Timothy Deere groups, and it's already include the consideration to perform in minimal invasive decompression on the left side. You can see if it's a stable central lateral stenosis process, you can perform the direct decompression, which we actually discussed now, or indirect, like X-leaf, just for stretching the yellow ligament. It's also very attractive minimal invasive procedure, which could be done with some lateral approach, minimal invasive. So we also create some kind of minimal invasive algorithm which subdivide the process according to anatomical landmarks of stenosis. Central, if it's density of the compressive structure like osteophytes, it's another procedure which normally done via portal navigation approach. And finally, we are going to some algorithm, anatomical, very easy used for the young surgeon algorithm, which combine the clinical science with monoradicular, with, let's say, lateral stenotic process. We are doing normally transforaminal approach. It could be TESIS, as the JOIMAX suggests, but it also can be posterolateral procedure, which just need to be cared with the navigation, positioning of cannula in the right way. And then it's not very easy, but after a certain learning of the understandable procedure with removing of annulus fibrosis and a procedure named in-out. So via disc we are going inside the spinal canal, removing the herniation, checking the position of passing and transversing nerves, and then finally 90% you have a reduction of pain and nice view on the MRI. It's lateral recess stenosis, for example, or even soft herniation. But now, due to a very severe quantity of patients which have osteopenia with long process of stenosis, with central stenosis, the percutaneous procedure for the severe stenosis also very very popular, and we increased the amount of this procedure in our institution 2 times now at 50, 70 procedures per year. And there are many different approaches. We actually use the so-called ELESIS or Delta approach, but it's a lot of variants. You can use even K-leaf, so-called, when instrumentation, additional instrumentation via percutaneous approach also can be applied. So ELESIS in case of central or severe lateral stenosis could be performed, and you just limited intralaminar space. And what's important in this situation, you always use the same instruments and generally the same anatomical landmarks as you perform when you perform open approach for the stenosis. So it's next slide. Can you click on the video, each of 3? And theoretically, you are doing the same procedure as when you do in the open. So you position on the cannula, you are drilling and a little bit increasing the intralaminar space, and you start to remove yellow ligament. But you're doing in constant irrigation. You have only 1 to 5 millimeter stitch incision, and you don't need to perform any bleeding correction. And actually, you even wouldn't care for the laceration of the. Can you click again? Кликните на изображение. And you can even see the unilateral radicular, and the same easy way you can see the contralateral radicular using the over-the-top technique, because you can reposition the cannula all the direction inside this interlaminar space. So the let's say a learning curve for this procedure, it's, I would say, even easier than for thesis, because all the structure is very seeable and very understandable. And what's important, I probably will show it on the cervical level, and you having the pressure of water, you can always a little bit detach the dura from the yellow ligament and avoid any laceration. So finally, you always have the minimum 100% increasing of the transverse area. It's 1.5 centimeters, so it's really normal spinal canal. You normally have the good clinical results. Here's just it's one of the first trial when we start to perform percutaneous endoscopic decompression for cervical stenosis. But of course, it's a little different because you have drill a lot, and you always should avoid bleeding, because the vein which located epidurally provides some difficulties to detach the radicular from the herniation. But in general, the procedure is the same, and it's always the tricky to provide the right direction of this drilling, because you have to little bit move the radicular and to detach and remove the normally soft herniation from the radicular. It's quite similar to the procedure which we are doing on the lumbar way, but instruments is smaller than a lumbar level. So finally, having percutaneous endoscopic procedure, we reach the early rehabilitation for the patient. Minimal bleeding. 1 day after surgery, they stay at hospital, and the results is quite promising, because next day they can ready to go home, and 3 weeks they can completely social rehabilitated. Of course, we have some contraindication, but it's quite critical. Severity of stenosis, osteophytes, some very severe neurological deficit. Probably if you have claudication, patient is stop moving, you will perform the severe and very extensive decompression. But in general, this procedure is available for all kind of the stenotic process, lateral, central, cervical, lumbar, depending on the instrumentation you have, and just you need enough interlaminar approach to position your endoscope in there. just some figures at the end that the pain has disappeared first day, and having 70 patients, we haven't recover or return of the pain, and just promising result for ODI and McNabb score. Learning curve, that's discussable. Our international friends recommended 70 procedure to reach the level of 60 minutes procedure. So after 60 procedure, you will perform the operation for 1 hour. Yes, probably it's reasonable, but for stenosis, I think it's 20 procedure, it's enough, and you will be the expert. And to conclude, I think the minimally invasive way very attractive for the and as an alternative for the open procedure, and percutaneous endoscopic irrigation procedure is very nice and very future for this kind of degenerative disease. Thank you.
Thank you very much. Вот два вопроса, Артем Олегович, к вам есть. В каком возрасте чаще всего встречается стеноз поясничного отдела позвоночника и какие сопутствующие заболевания этому способствуют?
Курение, Сергей Васильевич, курение, алкоголь. Это шутка, конечно. На самом деле мы считаем, что стеноз выраженный хирургически начинается после 65 лет. Наш контингент это 65-75. Мы почти всегда имеем больше женщин, примерно 70%, и он сопровождается развитием остеопении или остеопороза. Поэтому мы часто и идем на эти операции малоинвазивно, потому что какая-либо инструментация в данном случае невозможна.
И второй вопрос. Вот какая тактика при повреждении дуральной оболочки или квореи?
Вот это прекрасный вопрос, самый лучший, потому что никакой. Если перкутанной операции у вас появляется дырка в оболочке, что, конечно, возможно, и у нас она появляется, и вы видите вылезший даже фасцикулу, вы просто ее тампонируете и спокойно закрываете рану. Мы проверяли, после этого максимум, что вы получите, это очень небольшая, меньше сантиметра кубического киста, потому что разреза нет, мышцы все сохранны. Это, кстати, большое дело. Мы сейчас проводим исследования состояния мышечной ткани после перкутанных операций и надеемся, что это выльется в определенную стратегию такую достаточно масштабного плана.
Спасибо большое.
Спасибо.
Следующий доклад Дмитрий Александрович Пташников. Surgical treatment of metastatic lesions of the spine.
Dear chairmen, dear colleagues, and first of all, I want to say thanks a lot to Sergey, who invited me for this meeting. And it's a big honor for me to be here at the third BRIC Spine meeting. And I want to, in our talk, I want to share our experience in the hard way of treatment of patients in the metastatic spine. How you can see, our experience is the more than 2,000 patients, for more than 2,000 surgeries for the patient with a tumor spine, which with a follow-up for 15 years. And you can see that the surgical activity for this category of people is dramatically increasing year by year. And now we have, I would say that it's 25-30% of all spine cases in our center. So you can see that metastatic spine takes more than 60% of all tumor cases. I would say that the surgery is the last chance to help these patients. It's not the preventive medicine for them. Today we have a lot of opportunity to treat these patients with the chemotherapy, radiotherapy, and you can see here the examples. The patients from the one's left side is the patient with the multiple myeloma, with the spinal cord compression and the neurological complications, and after the some chemotherapy with the total restoration of the shape of the vertebral channel and total recovery of the patient. The next one is the two cases is the patient with the breast cancer. That's why
I would say that in the last 10 years, the quantity of the patients with the primary tumor site is dramatically changed in our operation field. I would say that there maybe 10 years ago, the patients with the breast cancer and multiple myeloma, prostate cancer was the best candidate for surgery, and now you can see that they are disappeared from our operation theaters because the effectiveness of the chemotherapy, hormone therapy, and radiotherapy is very high for them, and almost maybe 15% need the surgery still now. But another way, for result of the good chemotherapy and extension of the life of the patients, we can see that the patient with the kidney, renal cell carcinoma metastasis, lung metastasis, gastrointestinal metastasis, I mean, even liver metastasis. I mean, these patients, which maybe 10 years ago, we couldn't even expect to do the surgery for them because they are not, it was not candidate with a good prognosis for the life expectancy. That's why they are coming now, they are coming to our operation, and we have to do with them something to improve the quality of life for them. That's why the decision-making process for this category of patients, it's a very hard way. It looks a little bit simple, just 3 main steps: histological verification of the tumor, then evaluation of the staging of the tumors, a staging of the oncological process, and then the third one, the very important, it's the oncologist consult. It's the multidisciplinary approach. It's the decision about the surgery and about the treatment strategy for these patients. It's the part of the oncologist, chemotherapy, radiologist, pathologist, and surgeons. That's why only group of the people individually can do the strategy for these patients. So you can ask me about the prognosis, because in the beginning of our way, a lot of people ask about what the prognosis of this patient, what the life expectancy for them, and what reason to do the surgery for them. And we studied a lot of scales which we have for today, and I would say no one is work. We don't have prediction factors which can be we can orientate using them for the prognosis of the tumor process. And then that's why you can see just a few factors. It's primary tumor site, performance status, SAA classification, age, gender, number of metastasis, location, and pathological fracture. Only these prognostic factors are very strong, and we can use to decide about the surgical strategy for them. But anyway, today we have only one factor to do the surgery for these patients. The main, you can see, that's operability of these patients. If they can be operated, we can do the surgery. So, what is surgical strategy? It's the multi-stage. It's the minimal as short as minimal. You can use the percutaneous techniques if you can do and can help this patient with the percutaneous vertebroplasty. It's a great deal. But if you're not, you can do the surgery. Percutaneous, minimal invasive. Your approach to this tumor must be straight. Please avoid 360 degrees surgery for this category of patient. It should be target surgery. And here you can see example, for example, this man with the lung cancer with a not so good prognosis of the life, and the idea to relieve the pain and stabilize the spine. You can see this is the approach and the surgery with a few days of the post-op in the clinic, with a good satisfaction of the patients.
Multi-stage surgery, because the people are living longer. I mean, our patients, the patients with the multiple myeloma, how you can see here, the patients with the breast metastasis, even with the renal cell carcinoma metastasis, patients could be operated several times after the evaluation of their metastatic process for several years after that diagnosis. And here you can see the patients which in 2002 verified the multiple myeloma, and with the progression of the disease in 2020 with the multi-level decompression and stabilization. Then there was the pain syndrome and problem in both hips. We did this stabilization of the hips. Then that was the prognosis 3 years ago. After that, it was the progression with the local progression of the disease in L2 level with the stenosis and neurological deficits for the patients. And we did the anterior approach and this. And so you can see in 15 years out of her life, we did the surgery, because all this surgery helps to improve life condition. Можно обратно? Sorry, я пролистнул, как на обратно. So another problem, it's the revision surgery for metastatic patients. Maybe 10 years ago we cannot expect about that, but now they are living longer till again, and we have to do the revision for these patients. We increase the surgical aggression in this case, and according to my first talk in this Congress, I would say we have to plan in before the surgical, to decide the surgical strategy, which type of technology we have to use to reduce the risk of the instability of implant and fracture of the hard way. Combination of the treatment, the radiation therapy. Here you can see the example of the renal cell carcinoma, minimal invasive approach. It's the new way which called separation surgery. So we retrospectively studied the group of the 40 patients with the renal cell carcinoma. We divided in two groups in which we did the, in case of the solitary metastasis of renal cell carcinoma, we did the metastasectomy. In other group, we did the palliative decompression, the separation surgery with the stereotactic radiation therapy first month after the surgery. And you can see that the result was the same. I mean, that's the disease-free survival and overall survival for this patient was this similar results. That means it's not necessary to do the very aggressive surgery today anymore, because we can use the cooperation with our rentgenologist and achieve the similar results. Another point in the treatment way of these patients is what to do in the acute situation when they have severe spinal cord compression with a neurological deficit and not verified histology, verified tumor, because it takes time. For example, this case, the young lady with the stenosis of the spinal cord, tetraparesis, and asphyxia also. And we don't have the time for biopsy and waiting several days or weeks for histology verification. But that was the only one tumor mass, and we decided for young patient with a good somatic status, and we did the aggressive surgery for this radical resection, and she was pretty lucky because it was the giant cell tumor. And anyway, the second stage in this situation, we recommended to do the MIS surgery. Decompression is like a open biopsy with sometimes with the short fixation, percutaneous fixation, and then we, in few days or weeks, we have the histological verification of the tumor, and then to decide what to do with this patient in a post-op. So, and also don't forget that the cause of pain for this patient could be not only the tumor. Here you can see the patient with the breast cancer, the metastasis, and the degenerative spine in the lumbar area. And you can see there was
two small surgery about metastasis resection, removing from the in the compression of the nerve roots, and then percutaneous fixation of L4, L5 level to reduce the pain for this patient. These patients also can get the help from this pathology too, because don't afraid the oncologist patients if you want to help them to limit pain result of degenerative disorders. In conclusion, I would say that the idea of the surgery is the good selection of the patients, because it's very important. It's multidisciplinary approach personally to each patient. And you have to choose the effective strategy of their treatment with the consult of your colleagues. And I would say that the modern techniques and combination of our modern technologies with the radiologist, for example, in this case, and chemotherapy can achieve us a good results, similar with the aggressive tumor that today I would say it's help us to avoid the aggressive surgery for this category of patients. Thank you very much.
Спасибо, Дмитрий Александрович. А вопросы к вам? Вот какой метастаз вот все-таки самый благоприятный для лечения, а какой самый опасный, как вы считаете?
Это хороший вопрос, просто если можно вообще метастаз считать каким-то благоприятным делом, да, в принципе, наверное, самый благоприятный метастатический процесс это, на сегодняшний день, это, конечно, заболевание молочной железы. Да? То есть это те заболевания, которые на сегодняшний день контролируются при помощи химии, гормонотерапии, лучевой терапии и бон-модифицирующих агентов, да, то есть бифосфонаты. Вот. Что касается опасности хирургии, наверное, самые неприятные это те, которые хорошо васкуляризованные опухоли. То есть это метастазы рака почки, которые требуют несколько смелости от хирургов, предоперационной эмболизации в некоторых случаях, использование гемостатиков и так далее. То есть это дает как бы немножко, так скажем, нам необходимость собраться. Вот. А так, конечно, тяжело говорить, что хорошо, что плохо. Мы, в общем-то, на сегодняшний день главное попытаться избежать хирургии. Но если она потребуется, то, в общем, на сегодняшний день есть все необходимые технологии и условия для достижения позитивного результата.
Спасибо большое. Следующий у нас...
Can I ask a question?
Yes, please.
Yeah, I'm Dr. Pankaj. Dr. Dimitri, very nice talk. Can you tell me, suppose the patient is having 4 plus power with partial compression due to metastasis, how will you proceed in those cases?
You mean...
the spine is quite stable, there is small soft tissue compression. You will go for radiotherapy or just in metastatic case, or you will do instrumentation?
Yeah, thanks. It's a very good, nice question, because, it's very difficult to decide in this situation how stable it will be after the decompression, because if your installation is not big and then you're planning the surgery, then you understand that you can resect the tumor mass without disturbance of the stability of the spine. It's okay. We can do only decompression. But if you decide, because if you talk about the radiotherapy, here is the one problem, because our colleagues ask us the possibility to have about 1 or 2 millimeters space between the tumor mass and their neurological structures. Because if we do if we don't have this space, that means this is the high risk of the radiological complication of the nerve roots and spinal cord. That's why this is the key and idea of the separation therapy, separation surgery. We do the decompression, we do just the space, and immediately, maybe in a couple of weeks after post-op, we send this patient to the radiologist, and then they achieve a good results. Another, it's a very important point to have an agreement with the radiologist, because sometimes the radiosurgery decrease the bone density, and after that, we can see the pathological fracture, I mean, after the radiotherapy. And that's why, in some cases, we do the prophylactic percutaneous short fixation to avoid this, just for prophylactic.
One more question. Suppose you are putting a bone graft, and you want to give radiotherapy. You will wait for 3 months to bony fusion to occur, or you will immediately go for radiotherapy after surgery?
Yes.
You have instrumentation and bone grafting also. More 2-3 levels, corpectomy and bone graft. So you will wait for 3 months, or you will immediately go for radiotherapy after surgery?
Yes, yeah, it's also a very nice question, but you know, it depends on the tumor aggression. If it's soft tumor with, for example, very aggressive, the lung metastasis like this, it's not possible to wait 3 months after the surgery. Yeah, that's why we have to send these patients. But you know, it's the problem of the tumor prognosis. That's why we never use the bone graft for fusion. We use the bone cement and maybe some bone graft in the end plates of the above the cement in the cage, just for good adaptation of the mesh to the end plates of the level above and below the resection. That's why, because it's I'm not believe in the real healing in the metastatic spine. Of course, if you do this, the radical resection in the prime tumor, it's okay. But in metastatic spine, it's we have the two problems. It's the it's a decreasing of the healing process and the short life expectancy of the patients. Some of them not achieve the fusion, yeah, because of their life can be half a year or 1 year. That's why it's not necessary, and we can achieve the primary stability of the spine just using the using the hardware. I mean the implants.
Okay, so for GCT and all those things, we can wait for 3 months, and for metastatic, you will go for immediately.
Yeah.
Thank you.
Thanks. Thank you.
Спасибо большое, Дмитрий Александрович. Дальше у нас идет доктор Шалеш Ханджакар, если я правильно произношу имя. O-arm navigation is again changing spine surgery, changing cervical fracture dislocation is severe, cervicothoracic deformities and ankylosing spondylitis, and spinal deformity with O-arm navigation.
Hello. Good evening, everyone. First of all, Dr. Shailesh had to travel for some emergency, so I'm Dr. Amog, his colleague, and I hope I do the justice to his presentation. So this talk is regarding the O-arm navigation in complex spinal pathologies, and we'll be covering all the 3 topics in one. So this is an experience of more than about 1.5 decades with open as well as MIS fixation spine surgeries. And thankfully it has given us good outcomes, whereas since the last 3 years with the 3rd generation navigation O-arm based fixation spine surgeries, it has been a game changer completely. So we have had fortunately great experience and good outcomes in the cases where we have used O-arm in complex spinal pathologies. So what are the various challenges which you can expect while instrumentation, especially the pedicle screw insertion? First of all, in cases of deformities, the angles and rotations are anatomically distorted. In revision spine surgeries as well, the bony anatomy is distorted because you may be unaware of what has happened before. In cases of spinal tumors as well, a lot of bony and the posterior element involvements occur, which can make pedicle screw insertion challenging. In osteoporotic spine as well, because the bony hold may not be good, and you may not get multiple chances in cases of pedicle screw breaches. Cervical pedicle screw fixation is a challenge in itself because even a smaller breach can lead to catastrophic complications. And of course, in traumatic fracture spine, where the alignment is of utmost importance. So mainly kyphosis, scoliosis, and spondylolisthesis are of challenging, they possess a lot of challenges for pedicle screw insertions, along with spinal tumors and cervical spine pedicle screw fixations. So in terms of kyphosis and scoliosis, the pedicle morphology obviously differs, and it differs between neuromuscular, dystrophic, or congenital types. Morphology, which may vary, include very thin pedicles and altered pedicle and body angles, wavy pedicles, which we have also seen, hypoplastic pedicles, or in rare cases, completely absent pedicles. So just sharing a few cases, this is a 15-year-old girl who had a progressive deformity which was noticed 2 years back, and she did not complain of any sort of pain. Neither did she complain of any motor weakness or sensory loss in any of the 4 limbs. It was just the deformity which was noticed, and it was progressive. So these were her x-rays. She had kyphoscoliosis with apex at T5, which was a hemivertebra Cobb's angle of 50 degrees, and recess 5. So she also had a thoracolumbar curve, which had a Cobb's angle of 15 degrees, S1, S2 occupancy. There was some coronal imbalance as well as a lot of sagittal imbalance, and shoulders were symmetrical bilaterally. So in such cases, this was her pre-operative CT scan. She had her menstrual onset about 2 years back. And as you can see, the hemivertebras and a lot of bony malalignment. So these were her intraoperative pictures. This was the plan. Her upper instrumented vertebra was L1 and the lower was S1. And this is a short video of how the O-arm navigation worked in our case. This is the intra-op image from the O-arm. And this is what we had achieved post-operatively, correction of about 25 degrees, from 50 down to 25 degrees. The other challenge was dysplastic spondylolisthesis. Obviously, the challenges include a small pedicle, rounded sacral dome, and she also had an associated spina bifida, which made it all the more challenging. So what are the options? You can either do a transsacral delta fixation, a transsacral strut fibula grafting, or you need a long pedicle screw. The other one was 63-year-old. This is a degenerative spondylolisthesis, 63-year-old female, low back pain radiating to right lower limb due to a fall, and had a claudication distance, a palpable step at the lumbosacral junction, and the distal power in the muscles was about 3/5 on either side. So these were her imaging. She also had an osteoporotic fracture at the thoracolumbar level, along with a degenerative spondylolisthesis at 4/5, but a lytic listhesis at 5/S1 due to the fall. And these were her preoperative MR imaging. And so we decided to fix her up with the help of O-arm navigation. And this is what we could achieve. We inserted a delta screw from S1 to L5, and also fixed the osteoporotic fracture at the above level in situ. Another case of a 74-year-old female. She had a low back pain and bilateral lower limb claudication. Distance was less than 50 meters, and she had some sensory hypoesthesia over the L5 dermatom. This was her MR imaging preoperatively, which showed listhesis at 4/5 and CT scan. So we did all the pelvic parameters. the pelvic tilt, sacral slope, and the pelvis incidence. And accordingly, we planned her for delta screw fixation with O-arm navigation. The advantage being you can clearly see the pedicle morphology and the track in which we intend the screw to be put. And this is how it looked on the O-arm. You get a full 360-degree view of what instrumentation you have done along with the bone grafting status. So this is a short video. In terms of revision spine surgeries as well, it's a boon. The challenges which you may face is the established fusion mass, which may make the anatomical landmarks less reliable, and you have limited fixation options. So this is a case of a 61-year-old gentleman. He had a severe thoracolumbar back pain since last 8 months, difficulty in standing and walking and turning in bed. Somewhere down the line, 14 years ago, he had undergone decompression from L2 to S1 with stabilization, and this would be a classical case of proximal junctional failure with an angle of 43 degrees. So we did a CT scan, and subsequently the MR imaging showed cord compression and pain unrelating to conservative treatment. So these were his intraoperative images, and we plan to revise the case and extend the fusion and extend it proximally until D10 with the correction of the kyphosis with the help of O-arm navigation. In terms of spinal tumors as well, you have distorted anatomical landmarks due to the encroaching tumor mass, and the margins may not be well visible. Also, the vascularity is an issue because the tumors are highly vascular, and it can lead to catastrophic complications on table. So this was a case of a 48-year-old gentleman, back pain, numbness, both lower limbs, and the power was almost 0/5 with absent reflexes, but the Babinski was positive. He was diagnosed eventually as a case of adenocarcinoma of left lung with metastasis to T11 3 years ago, and he had an operative intervention from T9 to L1 posteriorly. So this was his previous surgery, and this was what we did later. We had to extend the fixation from T7 to L2 and decompress the involved cord compression. In terms of osteoporotic spine as well, the pedicle walls are very fragile. There are chances of neurodeficit. The screw purchase may not be as good as you would expect. Later on, there may be screw loosening and back out. So you need a very specific screw trajectory, and you may not be able to revise your screw intraoperatively once you feel it's a pedicle weak. So it's a single shot screw fixation, and you may need vertebral augmentation with the help of a cement as well. So again, this was a case of osteoporotic compression fracture with dynamic x-rays at the thoracolumbar level, and this was a retropulsed fragment indenting the cord. As you can see on these TEOR images, it's a fresh fracture. So he had multiple wedge compression fractures with a non-union or a cleft with retropulsion and cord compression, and this is what we could achieve: a T11 to L3 posterior fixation and fusion. And this has been published, the accuracy of O-arm in osteoporotic spine with the precious pedicle, which shows 99.6% of accuracy using O-arm pedicle screw fixation. Also, in cases of traumatic thoracolumbar fracture dislocations, there are abnormal translation in both the planes and along with rotation. So putting in pedicle screw in the fracture vertebrae can be a task, and there is also a high risk of neurological deficit. So this was a 26-year-old gentleman who fell from a height and lost his power in both lower limbs with absent sensations below T10, and it was a T9 burst fracture with paraplegia. So this was his MR imaging, and this was his intra-op OM images. We had to stabilize it from D7 to D11 and decompress D8 to 10. So you can exactly see the tract with the help of the instrumentations on live OM feed, and plan your screws accordingly. And then review your fixation immediately after you're done, just to see the canal clearance, which is of utmost importance in such cases, and also the pedicle screw tracts. So the other part of my talk, sir's talk, was ankylosing spondylitis with cervical spine fracture. So we had a 54-year-old gentleman with tenderness over the cervical spine region, and had a fall in an already known case of angspond. And since then, he was unable to stand or walk, or also unable to avoid his urine. He had upper limb and lower limb neurodeficit with C81 about 1/5, and even L5S1 around 2/5. Bowel and bladder was intact, and sensations were patchy. These were his pre-op imaging. You could see a fracture dislocation over 6/7, and this was his clinical picture. Absolutely unable to lie down, and severe pain when he presented in the emergency. So we ran through his scans, and this was a CT scan. There was displacement as well as dislocation, and it was a C6/7 fracture dislocation at the discovertebral junction with an exaggerated cervicodorsal kyphotic deformity. So initially we planned him for an anterior fixation from C5 to C7 with a mesh cage and a plate, but shifting to OT and intubating him was a task in itself, along with positioning on table. So we had to take utmost precaution while shifting him to the patient to maintain exactly the amount of angles to which he presented to us, not allowing any further trauma to the cord. And along with a very difficult intubation, he had to be intubated with a video laryngoscope. And this was how we positioned him. There was a bolster under cervical and dorsal region, along with traction, Gardner-Well tongs for intraoperative traction. So we had to obviously mold the implants accordingly, and that's when the O-arm is of value, because you can exactly plan your implant molding so that you don't struggle intraoperatively. And this is what we achieved while fixation. And these are the videos for the O-arm fixation. You get a full 360-degree view, and you can see if the alignment is okay, if the cord clearance is okay, the canal clearance. And this is what we had achieved post-operatively. Unfortunately, he developed a CSF leak on post-operative day 2. So we planned to put him on a lumbar drain and a fused spine, which was again a challenge in itself. And lumbar drain was inserted through a small defect which we found on around L4, and we kept it for 5 days, and eventually the wound healed completely, and the sutures were removed on 3 weeks interval. 1 month follow-up, the scar was completely okay, but the x-rays showed some sort of implant back out from the anterior aspect. The distal part of the plate was backing out from the fixation segment. But eventually his neurology had improved post-operatively from about 1 or 2, he had improved to 4 in the proximal segments and 3 in the distal segments. So we planned him to revise him, but thankfully on imaging there was no compression over the trachea or the esophagus, even with the implant back out anteriorly. So we planned him for posterior cervical fixation, and we took him to the OT again. And this is how we had to position him, keeping the abdomen free, but also taking care of the inherent kyphosis which he had due to the ankylosing spondylitis. This was all done under neuromonitoring, and to get the best hold, we put in cervical pedicle screws under CM navigation gradually, and so that we have the best of these pedicle screw holds and avoid any further implant-related complications. So this is how we plan to put in the cervical pedicle screws under constant live monitoring of the O-arm, and also the neuromonitoring just to look at the neurological status of the patient. So this is what we achieved finally, a very challenging case of ankylosing spondylitis with cervicothoracic fracture dislocation. We had to go in twice, and so it had double the challenges which you would expect. This is his final outcome.
Thank you very much for your interesting presentation.
Thank you.
I want to ask you one question. Do you compare with O-arm navigation, pedicle screw insertion, and freehand technique for insertion pedicle screws? What's the difference between?
The accuracy is the main difference. As I said, we have published one of the papers, especially in osteoporotic spine, which showed 99.6% of accuracy. So in order to avoid inadvertent pedicle screw complications, the O-arm guided pedicle screw placement may help you, along with, especially in deformity cases and challenging spinal pathology cases.
Thank you very much. Следующий доклад аддитивные технологии в хирургии позвоночника, Addictive Technologies in Spine Surgery. Марчел Степанович Ветрилэ будет делать.
Добрый день, good afternoon. Будет у нас презентация, да? We'd like to share our experience of using additive technologies in spinal surgery. We started to use additive technologies in 2011, and there are two main fields of using additive technologies. This is biomodeling and custom-made spinal implants. So biomodeling is a very useful tool to appreciate the severe spinal deformity, especially in cases of congenital spinal deformities. And a short survey which was done in our institute showed that in 25 persons, the spinal surgeons changed their preoperative plan, which was made due to the data from CT and MRI, when they can take in consideration this spinal biomodeling and this tactile feedback. So another way to use spinal biomodeling is not only to model only the bone tissue, but also the soft tissue components such as spinal cord, and we could appreciate the spinal cord compression and planned decompressive surgery. Of course, it's very interesting that we can do personalized spinal implants for spinal surgery. Different plates for anterior atlantoaxial and atlantoaxial fixation was designed and produced to treat different pathological situations. One of these plates was expandable for fixation of C1, C4. And these are two clinical examples. First is C1, C2 transoral decompression after the consequences of C2 fracture with spinal stenosis, and another one with C2, C4 fixation with expandable plate after tumor pathological fracture of C2, C3. Another implants for spine surgery is personalized plates for occipital spondylolisthesis in 6 cases. And this is first patients with MPS type 1 with severe kyphotic deformity of the cervical spine with spinal stenosis and myelopathy. So the first stage was hull traction with kyphosis correction with occipitocervical thoracodesis. And we've got here a complication, a skin penetration of hardware elements. So to resolve it, we do an individual plan, taking in consideration of skull anatomy, and create such an individual plate for occipital spondylolisthesis. And also we planned and create an individual cervicothoracic plate for anterior fixation. So this is a clinical outcome with good kyphosis correction and spinal decompression. Also, we use personalized implants for anterior cervicothoracic fixation in severe congenital and post-traumatic deformities. It's one clinical case with a 3-year-old patient with congenital cervicothoracic deformity with spinal stenosis and myelopathy, and due to the use of personalized implant, we can do a good decompression and stable fixation of the cervicothoracic spine. One of the advantages of personal plan for patients is that we can plan the direction of the screws, and this case demonstrate that we can even fixate C5, T5 without sternal osteotomy. And this is a short video demonstrating the stages of the surgery. First stage is hull traction, posterior correction and fixation. The second stage is anterior decompression. And then we can use a plate with a mesh combined or a single mesh, and then anterior fixation with individual plate. And these are clinical data of this patient. It's a congenital kyphoscoliosis with tetraparesis syndrome. And the stage of approval and development of plate and planning the surgery. And this is CT scans after the surgery with stable fixation, and we got, due to the good decompression, neurologic amelioration. Different types of implants for lumbosacral spine fixation also was created, such as pelvic supports for vertebropelvic fixation in such a severe case of neurofibromatosis with secondary pelvic deformity and destruction. And this boy was operated at 5 years old, and this is 5 years follow-up with good result and stable fixation. Another very interesting possibility is direct repair of spondylolytic defect of L5 vertebra. Such in this case, you can see the grade 1 spondylolisthesis in a 15-year-old girl. She's a sports athlete. And this is a surgery with direct spondylolisthesis repair. We preserved the supraspinatal ligament in this case. And this is a 1-month follow-up. And this is 3 months follow-up with a very good clinical and functional result. And the last case we'd like to present is the possibility of restoration of rib cage. This is a case with a patient with hemangioma T5 with kyphotic deformity. She was operated, and it was such a huge excessive decompression and tumor excision, and the integrity of the rib cage was destroyed. So we planned the special personalized implants of the ribs, which was fixated to the rod to the transpedicular fixation. These are implants. We can see them mobile. And this is a clinical result of the surgery. The problem with this patient was that when first it was when he tried to raise her hand, he got blocked with the scapula, and the second, of course, was a cosmetic defect. So we resolved all these problems. So additive technology seems to be very useful in spine surgery. Is of course not in the standard procedures, but in the very severe and non-common deformities. First of all, in the congenital deformities, it gives us a possibility to make a more precise preoperative planning and to create a personalized spinal implants. And in some cases, this is the only chance to perform the surgery in these patients. Thank you very much.
Спасибо большое, Маршал Степанович. У кого-то есть вопросы? Вот у меня вопрос в плане вот этого ребра подвижного. Ну вот какой фоллоуап у этой пациентки? Не наступает ли перелома вот в этих подвижных частях?
Фоллоуап относительно небольшой. Это 5 месяцев получается. Ну, нестабильности нету. Конечно, это уникальные случаи все по сути свои. Будем наблюдать.
Хорошо. Спасибо большое. Мушкина у нас нету, да? Ага, ну подключайте тогда.
Hello.
Марчел Степанович, вопрос есть.
Can I ask a question?
Yes, please.
He has talked about the nice presentation. He has talked about the artificial ribs. They are all custom made, or they are standard sizes. And if how you attach those to vertebra, the transverse process is gone in this case. How did you fix those artificial ribs?
Я не очень понял, конечно. Of course, they are individual. They was done by 3D printing, and they were fixated to the rod. As you can see on the picture, they were transpedicular fixation from one side, and we fixate the ribs to the rod.
Okay, so they get there is a fusion process also there, or just you put into vertebra. Or ultimately it fuses, or it doesn't fuse?
No, there was no fusion there. It was 1 year after the surgery, after the huge oncological surgery due to hemangioma. And then we take this.
Okay, thank you.
Thank you.
Марчел, можно еще один вопрос?
Да, конечно, Александр Ильич. Непривычно вас видеть. Дистанционно еще вчера здесь, да.
Да. Были ли у вас ситуации, когда для достижения грудных позвонков приходилось проводить манубриотомию?
Нет, у нас не было таких ситуаций. В принципе, вот во всех случаях, которые показывали, собственно говоря, это является преимуществом, ну, таким возможностью, которую мы можем получить при планировании создания этих имплантатов. Отверстие под винты сделано таким образом, и там был слайд, где изображены, вот, собственно говоря, эти отвертки под разными углами. То есть во время операции мы можем, во время планирования операции на компьютере, то есть мы можем планировать дизайн таким образом, чтобы провести точно винты, соответственно, вот это направление нам задается специальным направлением и отверткой. Благодаря этому мы, в общем-то, да, мы избежали манубриотомии. Спасибо.
Can I have one more question? What about the listhesis part you have shown, this L5? You have produced an artificial, this facet joint, or the last case you have presented with the athletic girl. You have put an artificial facet in L5 to reduce listhesis, or what was that?
Thank you very much for the question. Yes, we've got 5 patients with this operated with this technology. There is no any artificial facet joint. We preserve facet joints. It's a variation of direct spondylolisthesis repair. As you know, there are two possibilities to use to make this surgery with a transpedicular screw and hook under the lamina, or with a U-shaped rod, and we compress the zone of spondylolisthesis. So in fact we restore the bone hook in this case, and we do the same surgery but with the individual implant. We preserve the facet joints, and we do the direct repair, but due to this construct, it was possible to reduce the grade 1 spondylolisthesis.
Okay, so mobility is preserved in these joints.
Thank you.
I want to ask, the mobility is preserved at L5?
Yes, of course. Of course, this is the aim of this surgery. We do not any segmental fixation. It's just a local L5 restoration of the integrity of L5 vertebrae.
Can I just know, just curiosity, where do you work? Because I didn't get your information in the slides. Which place you work in Russia?
Once again, please.
Which place you work? Where is your institute?
In Moscow, in Central Institute of Trauma and Orthopedics, Priorov Institute. We can share our contacts if you are interested in these technologies. We can discuss it.
You can, please. Okay.
Okay, thank you.
Thank you very much.
Thank you very much. Тогда у нас сейчас Александр Юрьевич выступает.
I'm ready.
Yeah. Unexpected effect of severe neuromuscular and congenital deformities correction in pediatric patients.
Thank you very much for inviting, but if it's possible, I will do the presentation in Russian. Мы говорили недавно о том, что сам по себе термин синдром торакальной недостаточности был предложен в начале 2000-х годов, но я обращу внимание не столько на него, сколько на предложенную в это же время методику оценки объемов гемитораксов, которая была предложена Робертом Кэмпбеллом и достаточно широко используется, особенно в хирургии пороков развития, хотя обращу внимание на то, что, говоря о синдроме торакальной недостаточности, все-таки исходно авторы указывали не только на врожденные деформации, но и на другие, и прежде всего на нейромышечные деформации. Если мы обратим внимание на современные подходы в классификации пациентов с нейромышечными деформациями, то должны указать на две принципиальных категории пациентов. Первое – оценка пациентов с точки зрения ортопедической, это с точки зрения возможности сидеть, вставать или ходить. И второе – это с точки зрения дыхательного, необходимости дыхательной поддержки. И здесь точно так же выделяется несколько категорий, в том числе полностью аппаратозависимые, нуждающиеся в длительной респираторной поддержке, нуждающиеся в периодической поддержке, например, ночной поддержке, и независимые от респираторной поддержки. И для меня было на самом деле очень интересно определить, какие же показания к коррекции деформации позвоночника имеются при тех или иных состояниях, прежде всего при нейромышечных деформациях. Мы привыкли говорить о том, и мы привыкли думать о том, что коррекция деформации позвоночника улучшает функцию легких. И вот крайне неожиданным явилось то, что, во-первых, во многих публикациях, особенно посвященных тяжелым деформациям и тяжелым, нейромышечным заболеваниям, вопрос улучшения функций не всегда стоит, и чаще ставится вопрос о том, чтобы сохранить имеющуюся функцию. С другой стороны, еще одна работа, на которую позавчера уже ссылался, работа группы авторов американских, которые показывают, что при коррекции тяжелых деформаций различной этиологии с применением инструментария вектор, который на самом деле направлен именно на увеличение объемов грудной клетки, не во всех случаях происходит улучшение дыхательной функции, а пусть в небольшом проценте случаев, но у части пациентов эти функции даже ухудшаются. Это подтверждают и данные, касающиеся коррекции сколиозов при спинальной мышечной атрофии. В 2021 году метаанализ из 127 публикаций отобраны 10. Из этих 10 публикаций только одна указывает на то, что функция легких после операции и необходимость в респираторной поддержке улучшается. 4 публикации говорят о том, что она не меняется, а в 5 отмечено, что в процессе послеоперационного наблюдения функция легких ухудшается. Но обратите внимание, что это ухудшение функции наблюдается при достаточно большом длительном периоде follow-up, до 12 лет, и вот в этой ситуации, возможно, это связано не столько с самой коррекцией сколиоза, сколько с естественным течением нейромышечной деформации. И мы сочли возможным оценить, пусть небольшой, но все-таки опыт лечения врожденных и нейромышечных деформаций с анализом не только нашей традиционной ортопедической ситуации, но и функции легких. Первое, на что обратили внимание, это на то, что у части больных со спинальной мышечной атрофией имеется достаточно хорошие объемные показатели, но что более важным оказалось не только объемные показатели, но и показатели пневматизации легких. Вот на цветовом картировании справа зеленая – это нормальная пневматизация легких при имеющемся объеме. При врожденных деформациях ситуация может быть не менее неожиданной, в том смысле, что вот в данной ситуации при множественном дефекте ребер на стороне порока имеется сочетанная ситуация. С одной стороны, диафрагмальная грыжа, которую мы при оценке на самом деле объема гемиторакса оценить не можем, которая поддавливает легкое, а с другой стороны, то, что изображено на цветовом картировании красным, ну или желтым цветом, это зона повышенной пневматизации, это эмфизематозность легкого, которая также не является нормой и ухудшают на самом деле функциональные показатели легкого. Были проведены исследования по оценке изменения размеров гемиторакса у пациентов с различной патологией, прежде всего с врожденными деформациями позвоночника. Но и было обращено внимание на то, что существуют такие варианты, когда даже увеличение, коррекция деформации врожденной позвоночника может не сопровождаться увеличением объемов гемиторакса, и легкое остается, наоборот, в состоянии повышенной инфильтрации, то есть сниженной пневматизации. В данной ситуации это то, что на картировании выглядит как синий цвет. Ну и закончу тем, что иногда совершенно неожиданные бывают варианты эффектов нашего хирургического лечения, которые мы либо не знаем, потому что не обращаем на это внимания, либо не оцениваем. Ситуация, когда имеются крайне тяжелые деформации, при которых требуется, с одной стороны, по возможности минимальная хирургическая инвазия при вмешательстве, с другой необходимо решать. Это уже не маленький ребенок, это не растущий, не ЕОС, это законченные формирования деформации, но у подростка 17 лет. И в этой ситуации вот такая вот комбинированная методика, ее можно назвать вектор-лайк, потому что верхний сегмент фиксируется латеральным стержнем к реберному каркасу. Но интересно то, что при этом увеличивается объем гемиторакса, но обратите внимание, что при этом объем исходно, условно назовем легкого, здорового легкого, немножко уменьшается. При этом значительно увеличивается объем того легкого, которое было поджато. Ну и совсем критичная ситуация, с которой мы можем столкнуться, это ситуация, например, интеркуррентной патологии. Например, вот как в этом случае развитие ковида у пациента на фоне нейромышечной деформации, приведшее к аппаратозависимости. Вы помните, в классификации, в рекомендациях по нейромышечным деформациям самая тяжелая степень – это постоянная аппаратозависимость пациентов ввиду дыхательной недостаточности. Но вот та ситуация, при которой в ряде случаев пациент может быть оценен как неоперабельный, но тем не менее, если все-таки встает вопрос о том, что он может перенести условно малоинвазивное вмешательство, то вот такое вмешательство, которое делается из трех доступов, позволяет получить, с одной стороны, анатомически очень хороший результат, при этом увеличиваются объемы как поджатого легкого, так и двух обоих легких, при этом нормализуется пневматизация легких от инфильтрированного, они становятся, нормально пневматизируемые. Ну и что самое главное, по крайней мере в этом конкретном наблюдении, это позволило избавить пациента от аппаратозависимости. Спасибо за внимание. Таким образом, заканчиваю тем, что торакальная недостаточность – это не только проблема ранних сколиозов. Объемы гемитораксов и объемы легких – это два понятия, которые требуют параллельной оценки. Современные методы позволяют нам оценивать еще один показатель – это пневматизацию легких. Ну и, наконец, последнее – это то, что у старших пациентов возможно применение методики, условно, которую можно назвать вектор-лайк. Спасибо.
Спасибо большое, Александр Юрьевич. Вопрос есть? То есть вы считаете, что вот этот, ну типа вептор метод возможно его использовать и у взрослых, вот у таких тяжелых пациентов, просто чтобы подрасправить им поджатое вот это легкое?
Мы хорошо знаем работы Андрея Николаевича Бакланова, да, с достаточно хорошими коррекциями при тяжелых нейромышечных деформациях, но иногда возникают ситуации, когда анестезиологи, когда функциональное состояние пациента нам ограничивает возможность проведения больших операций с инструментальной фиксацией. И в этом смысле даже как этапная операция, по сути, ну, условно говоря, по экстренным показаниям, вот такая методика, на мой взгляд, может быть использована.
Спасибо большое. Тогда переходим к следующему докладу. Use pedicular screws and subaxial cervical spine. Comparative analysis between tomographic positioning of 102 screws and clinical repercussion. Single center experience. Igor Chechen, Brazil.
Good morning, everybody. It's a pleasure to be here. I'm Igor Chechen from Into Brazil, and I'm going to present about our experience with pedicle screws in the subaxial cervical spine, where we made a comparative analysis between the tomographic positioning and the clinical repercussion. I have no conflicts of interest in this presentation. So to begin, the pedicle screws are a technical option for instrumentation in almost every condition of the cervical spine. It has an increased stability over the lateral mesh screws, but by the other side, it has an increased neurovascular risk. The pedicle and the vertebral artery malformations are relative contraindications, and in order to evaluate that, we shall perform MRI, CT scan, and X-rays to see the feasibility of this technique. Biomechanical studies shows that the pedicle screws can be even 4 times stronger than the lateral mesh screws. And we see also that this strength remains in a more linear fashion along the time. So the objectives of our study and our practice were to compare the clinical and radiological results and to evaluate the safety of the application of the pedicle screws in subaxial spine, compare the positioning of the pedicle screws and their relationship with the respective instrumented levels, evaluate the deviation rate obtained with our hybrid technique and compare it with the international literature. We've operated 19 patients and inserted 102 screws. Almost all of these screws, the vast majority, were between 2019 and 2021, between C3 and C6. Our technique was a hybrid technique with concepts with the original Abumis technique, the pedicle axis view, and the funnel technique. In the postoperative period, we used the NEO classification to evaluate the positioning and searched for signs and symptoms of cord injuries, nerve root injuries, and vertebral artery injuries. The hybrid technique used the same starting point of the Abumi technique, the original description, with the entry point on the lateral of the center of the lateral mass and close to the posterior border of the upper cervical facet. We've performed 3 fluoroscopic views in each step of the procedure, AP, lateral, and pedicle axis view, and we've removed the cortical bone in order to create a funnel so that the surgeon can gain more mobility with the hand and search for the medial border of the pedicle that is stronger. In this picture we can see the starting point of the technique and also the 3 fluoroscopic views used in each step of the procedure, AP, lateral, and pedicle axis view. The new classification used in the postoperative period, it can be used for lateral or medial deviations and goes from grade 0 to grade 3, being the major perforations grade 2 and 3. This is the demographic data table of our patients. And as results, we found a very good accuracy, the best in C6 with almost 97% of good positioning. The deviations were more lateral than medial. And in the statistical analysis, we found with significance that the deviations occurred more in C4 than in C3, C5, and C6. Comparing to the international literature, we can see that we had a good deviation rate similar to the other big series, and being comparable even with techniques that used tomographic tools for positioning. As complications attributable to the screws on the postoperative period, we had only one patient that developed radicular pain and paresthesia. We had no vertebral artery injuries. This is the case where the patient developed the radicular pain. We can see mispositioning at the right pedicle of C6. The patient improved without the need for removal of the screw. Again, comparing to the international literature, we see that complications related to the misplacement of the screws are not very common, and even the vertebral artery injuries are not common. As advantage, we can set that we may increase the stability of fixations, especially in very unstable lesions. We can see this patient as an example with a tumor of C2 that we've used pedicle screws in C4 to increase the stability. We can also save arthrodesis levels or even avoid circumferential approaches. This can be useful in patients with ankylosing spondylitis or diseases that develops ossification of the spine. In this case, we can see a patient with ankylosing spondylitis where we've performed this technique. Also, we can perform osteosynthesis with preservation of the mobility of the segment. In this example, we can see a floating lateral mass where we've used the technique of the pedicle screw to perform compression. So, as conclusion, we can see that the pedicle screws show to be safe and with a low rate of complications attributable to the screws, being an option for instrumentation in the subaxial cervical spine. I would like to thank you very much, and this is my contact. I'm available for questions, and I hope to see you all in Brazil.
Thank you very much. Между прочим, нас смотрят около 400 человек. Несмотря на то, что в зале как бы мало народу, народ проявляет интерес. Следующий доклад, next presentation, predictors of unfavorable outcomes of surgical treatment of elderly patients with degenerative pathologies of the lumbar spine. Владимир Климов. Предикторы неблагоприятных исходов хирургического лечения пациентов старшей возрастной группы с дегенеративной патологией поясничного отдела позвоночника.
Уважаемый председатель, коллеги, дорогие друзья, хочу выразить слова благодарности организаторам конференции за приглашение выступить с докладом, посвященным предикторам осложнений у возрастных пациентов спинальной хирургии. Последние годы отмечается устойчивый тренд к разработке и использованию различных инструментов для предоперационной оценки рисков возникновения различных неблагоприятных событий. В английском языке adverse event спинальной хирургии. В частности, я вот на слайде привел работу, которая посвящена сравнению двух различных калькуляторов системы оценки, которая посвящена оценке рисков развития механических осложнений при лечении дегенеративных деформаций у пациентов пожилого возраста. В данном исследовании проведено сравнение 3 систем для оценки риска развития осложнений спинальной хирургии. Необходимо отметить, что исследование носило перспективный характер. Авторы проанализировали 73 операции у 69 больных, у которых развились в результате хирургии различные осложнения. Были использованы так называемый Risk Assessment Tool, Charlson Comorbidity Index и калькулятор хирургических рисков Американского колледжа хирургов. Авторы делают вывод о том, что 2 калькулятора, по которым просчитывался теоретический риск развития осложнений, являются надежными инструментами для оценки. И они показали, что теоретический риск развития осложнений оказался сопоставим с фактическим риском их возникновения. Мы видим анализируемые параметры в этих 3 различных системах, и следует отметить, что они очень похожи и сопоставимы. И основные параметры, которые используются здесь, они характеризуют преимущественно тот или иной коморбидный статус пациентов. Но не оцениваются другие, не менее важные показатели. Однако вот в 2017 году тоже опубликовано исследование наших китайских коллег, показывающее, что один из этих инструментов, которые в предыдущей работе были показаны как точные, оказывается не совсем точен, да? И особенно у пациентов старшей возрастной группы, которые были оперированы на поясничном отделе позвоночника. Это говорит о том, что все-таки универсальных каких-то математических систем для оценки предоперационных рисков развития осложнений, ну, наверное, пока еще они не разработаны. Принято считать, что оценка рисков развития осложнений на этапе предоперационного планирования обеспечивает возможность оптимизации процессов подготовки больных высокого риска к оперативному вмешательству. И вот в этой работе наши австрийские коллеги в 2018 году показали, что для прогнозирования развития осложнений принципиальное значение имеют 2 группы факторов. Первое и важное – это коморбидный профиль пациента. И второе, не менее важное, это степень инвазивности хирургии, то есть объем, продолжительность и хирургическая травма самой операции. И с этим трудно не согласиться, поскольку это весьма очевидно. И мы видим, что наиболее часто осложнение развивается у больных как с высокой степенью хирургического риска, так и с низкой степенью хирургического риска. Однако основными предикторами развития неблагоприятных исходов спинальной хирургии, как показано в этой работе, является возраст, коморбидный фон, Charlson Comorbidity Index, и степень хирургической агрессии, так называемый индекс инвазивности операции. И чем хуже эти показатели, тем чаще будут развиваться осложнения. Авторы предлагают использовать вот этот электронный калькулятор Spine Sage. Он показан на слайде, есть в открытом доступе, абсолютно бесплатно можно пользоваться. Я проверял. Для точного прогнозирования риска развития как больших, так и малых осложнений. И на представленном графике мы видим, что теоретически рассчитанные риски развития осложнений... Я могу показывать, да? Нет, не могу. Теоретически рассчитанные риски развития осложнений статистически достоверно не отличаются от фактически полученных данных в результате проведенного исследования. Чтобы определить, как влияет применение именно минимально инвазивных технологий у пациентов старшей возрастной группы на вероятность развития неблагоприятных исходов лечения в течение 5-летнего периода, включая осложнения, мы провели собственное исследование, и в него вошло 1013 больных со средним возрастом 66 лет. Все они были оперированы с применением различных минимально-инвазивных технологий. В зависимости от сложности и травматичности операции пациенты были разделены на 3 группы. Первая группа, которым проводились изолированные микрохирургические декомпрессии. Вторая группа – минимально-инвазивный ТИЛИФ. И третья группа – это двухэтапные минимально-инвазивные операции, выполненные в одну хирургическую сессию, такие как A-лиф и L-лиф. И средняя частота развития осложнений составила 25,3%, из которых наиболее часто отмечена интероперационная кровопотеря более 500 мл и непреднамеренная дуротомия. При этом наименьший риск развития осложнений был в первой группе больных – 15,9%. Следовательно, статистически достоверно индекс хирургической инвазивности четко влияет на этот показатель. Одним из значимых предикторов неблагоприятных исходов, по нашему мнению, следует считать ожирение. Мы получили статистически достоверное негативное влияние индекса массы тела как на частоту развития осложнений в течение 90 дней наблюдения, так и на кумулятивный индекс реопераций в течение 5-летнего периода наблюдений. Необходимо отметить, что у больных с ожирением достоверно выше продолжительность операции и сроки стационарного лечения, несмотря даже на применение исключительно минимально инвазивных хирургических технологий. Одним из важных преимуществ применения МАЭС технику у пациентов старшей возрастной группы с отягощенным коморбидным статусом, на наш взгляд, является нивелирование отрицательного влияния индекса коморбидности на частоту развития хирургических осложнений. Однако мы не отметили статистически значимое влияние CCI на качество, наоборот, мы отметили, вот как показано здесь в нижней табличке, статистически значимое влияние CCI на качество жизни больных как на дооперационном этапе, так и в отдаленном периоде наблюдения. Более подробно с результатами нашего исследования можно ознакомиться в этой статье, она находится в открытом доступе, и ее можно спокойно почитать. В заключение хочу привести исследования, в которые были включены более 1 миллиона больных, оперированных на позвоночнике с различной патологией. Целью работы было определение предикторов неблагоприятных исходов. И важным, на мой взгляд, является использование термина именно не осложнение, а adverse event, то есть нежелательное событие, которое более точно определяет все неблагоприятные возможные исходы, а не только хирургические осложнения. И по данным авторов, наиболее важным предиктором развития неблагоприятных событий спинальной хирургии, как оказалось, является низкий социально-экономический статус пациента, который увеличивает вероятность развития нежелательного события от 20 до 60 раз. На этом у меня все. Большое спасибо за внимание.
Спасибо, Владимир Сергеевич. А почему вот именно низкий этот статус? То есть люди не могут себе позволить нормально реабилитироваться?
Ну, в этой работе не приводится. Почему, да? Ну, я думаю, что здесь несколько причин. Одну из них вы назвали, а второе, то есть в этой работе они брали базы данных частной, private insurance, да, и Medicaid, то есть бесплатную медицину. И те пациенты, которые оперировались по бесплатному полюсу ОМС, они в итоге получали с большей долей вероятности развития тех или иных нежелательных событий в процессе операции. Сложно тут...
Это подтверждает старую российскую пословицу «даром лечиться, лечиться даром». Спасибо. Двигаемся дальше. Может, кто-то хочет спросить? Спасибо тогда, Владимир Сергеевич. Следующий у нас next presentation, Miss Surgery for Using Tubular Approach. Альберто Готфрид, Бразил. Sorry. Тут Китай проснулся все-таки. Шила техник in the treatment of early onset scoliosis. Доктор Хуафенг Занг. Welcome.
Okay. Hello, everyone. I'm the first affiliate is the hospital of Zhengzhou University, Henan, China. First, I want to thank Professor Kolesov for inviting me to join BRICS spine session. I'm very sorry that I couldn't travel to Moscow to join the meeting in person due to pandemic policy in China. My topic to discuss today is the application of Scheler technique in the treatment of early onset scoliosis. Early onset scoliosis is a challenge deformity of a pediatric spine occurring before the age of 10. That may lead to poor respiratory and cardiac outcomes if left untreated. The main goal of the treatment of early onset scoliosis is to allow growth of spine to ensure the sufficient thoracic development while correcting the deformity. Early onset scoliosis includes various side of patients with complex pathologies like their spinal curvature. There are 4 category etiologies were idiopathic, neuromuscular, congenital, and syndromic. Non-operative treatment, including bracing, may achieve satisfactory correction in some patients, and most commonly it helps delay surgery. And high-low gravity traction is commonly an adjunctive treatment and is usually accompanied by other treatments such as surgery. Although conservative treatments should be considered first, they have certain limitations, and if conservative treatment could not control the curvature progression, surgical interventions are usually indicated. For some early onset scoliosis patients, for example, with complete semi-vertebral in situ or short segment fusion, could stop the process of deformity progression and has less negative impact to the growth of spine. But for long spinal fusion in patients with early onset scoliosis may endanger thoracic growth and pulmonary function. Thus, growth-friendly treatments is also called non-fusion surgeries are very important to preserve the growth potential of patients. Friendly surgical techniques are classified as distraction-based, compression-based, and guided growth methods. Traditional growth method has been the most applied technique for treating use. I consider the gold standard for use with the long curves. However, traditional growing rods need repeated general anesthesia and lengthening surgeries every 6 to 8 months, which may pose a threat to mental health. Another concern is about autofusion, because in patients with traditional growth rods, the spine is fixed. But the Scheler technique can significantly reduce the times of lengthening operations. And because only the screws in apical vertebra is fixed, the left spine is not fixed. So the autofusion rate is relatively low. We usually, of course, if a late use patient whose age is between 8 and 10 without vertebral developmental anomalies, for example, an idiopathic use, vertebral body tethering is highly recommended. There is an article about the Scheler technique compared with magnetically controlled growing rods in the treatment of neuromuscular and syndromic use. Scheler technique provides the similar outcomes in deformity correction when compared to magnetically controlled growing rods. There is also a similar height growth between the Scheler group and the MCGR group. And there is also a similar spine. There was also a similar rates of complications compared to the magnetically controlled growing rod. There also an article come from the Growing Spine Study Group reporting the comparison of growing of growth preservation instruments in early onset scoliosis patients with multi-level congenital anomalies. It shows that Sheila technique had the same similar complication rates, but the main complication of technique is device-related problems, and there is almost no other complications such as wound and neural complications. So we improve implants. There is a special spacer between the rod and the set screw. And cephalus and the caudal part of the rod was polished. Therefore, there is less friction to allow the screws glide more smoothly. And we use the 5 millimeter rods to reduce the rod breakage rate. Okay, this is a 7-year-old girl with multi-level congenital anomalies. She received the Sheila technique combined with posterior column osteotomy. There was a satisfactory curve correction. And this is a 80-year-old girl diagnosed as NF1 with a severe scoliosis. So we applied a mini open approach to perform the Sheila technique. So there is a satisfactory correction was achieved. Minimally invasive approach will allow the patient recover fast and reduce the exposed level to reduce the autofusion rate. Okay, there is summary. Sheila technique is as a growth-friendly technique can effectively and safely control the progression of curvature, and there is no need repetitive lengthening surgeries, and therefore there are less complications. But there are also some questions we have to improve in the future. Is the implant improvement? There is more MACE surgery can be applied. So there is a need multi-center research collaborations to for further studies to improve it. Okay, thank you.
Thank you very much for your excellent presentation. У кого-то есть вопросы? I have one question for Dr. Zhang. What kind of instrumentation do you use for Sheila technique? A local Chinese production or other one? What kind?
It's a local manufacturer.
Mm-hmm. Thank you very much.
Thank you for having me.
Двигаемся дальше. Кулкарни у нас там готов? Now we invite Arvind Kulkarni with degenerative spondylolisthesis, when to fuse, when to decompress. Arvind, are you here?
Hello.
Hello.
Yeah.
We are listening for you.
Yeah, good afternoon. So can you hear me?
Yeah.
Yeah. So can you see? Yeah. Can you see my slides?
No.
Now? Yeah, should I start?
We can see.
Yeah. So thank you very much for this kind invitation. So Dr. Alexander remembers this very well. So this was in 2019 when we were invited for the BRICS Summit, and we had great fun. And we had a great academic as well as touristy experience. I'm very grateful for the current invitation also. Now, the management of degenerative spondylolisthesis is highly controversial. We have two polarized groups here, one group supporting fusion and another group which supports decompression alone. The reason we have these two totally polarized situations is because we don't have any proper guidelines. So that is where we try to fill the gap. So this is what we published. So degenerative spondylolisthesis, when to fuse and when not to. This is what we published about 2 years back in clinical spine surgery, and this is what I'll be talking about. Now, the reason we have these two polarized groups supporting fusion and decompression alone is because we consider degenerative spondylolisthesis as a homogeneous entity. And again, when these two groups came up supporting fusion and decompression, the virtues of minimally invasive spinal decompression were largely unknown. So this flawed theory of homogeneity of degenerative spondylolisthesis can lead to overgeneralization and oversimplification of a multifaceted pathological complex entity, and subjecting all such patients to a relatively long procedure is not right. If you're fusing a patient who just needs decompression, you're subjecting him unnecessarily to a more morbid, more expensive operation. And this has been highlighted again and again in the literature. Now, the degenerative spondylolisthesis is a melting point of heterogeneity. No patient, one patient of degenerative spondylolisthesis is different from the other. If you compare one case of degenerative spondylolisthesis with another, it is like comparing apples and oranges. Because in a clinical practice, we have seen that they come with varying clinical presentation. Some have back pain, some don't have back pain, some have leg pain alone, some don't have leg pain, only have back pain. Again, their activity ranges from being very sedentary to being very active, and they could range from anywhere between 35 to 85, 90 years of age. So all these factors come into play when we make decisions. Again, with regards to radiological factors, some are mobile, some are not mobile. The facet orientation may be different, and again, now the morphometry of the spine may not be the same in all patients. So we studied this particular condition. So there are two wings to this particular research project. So one is the retrospective component and the other is the prospective component. In the retrospective study, we try to conceptualize a scoring system to guide treatment plan based on previously operated cases of degenerative spondylolisthesis by us. And in the next wing of the study, that is the prospective group, prospective component, we tested the validity of this scoring system in the prospective cohort. So the scoring system was conceptualized after retrospective analysis of consecutive patients with degenerative spondylolisthesis operated between July 2007 and October 2011. So these were all cases of L4, L5 spondylolisthesis who had failed conservative trial. So these are the factors we took into consideration which influence decision making. A patient having mechanical back pain scored 2. The one without pain scored 0. The younger patient less than 70 scored 1. The elderly patient scored 0. A patient with high activity level scored 1, whereas a patient with a low activity level scored 0. Again, angulation scored 1.5, translation scored 1, and no angulation or no translation scored 0. And we all know that facet orientation has a role to play. So patient with a sagittal orientation such as here on the left side scored 1, whereas the one with the coronally organized oriented facets scored 0. Again, facet effusion is a well-known sign of mobility. So this scored 1, and the one without facet effusion scored 0. Disc height, a taller disc has a higher chance of further degeneration and slippage, whereas a collapsed disc has no potential to slip. So that's why a tall disc, when compared to the next adjacent disc, scored 1, whereas a short disc or a collapsed disc scored 0. Again, morphometry. So on the lesion, the stenosis on the right side is very much feasible for a decompression without compromising on the facet joints. Whereas here, you need to do a midline decompression. So there's then you need to sacrifice the interspinous and supraspinous ligaments, which you can avoid if you're doing a minimal access decompression in this particular picture on the right. So all these factors were added together, and then this was the scoring system that we followed. So there were clinical parameters, radiological parameters, and technical parameters that we took into consideration. So this scoring system was then prospectively applied to all patients with degenerative spondylolisthesis from in the next coming 7 years, that is November 2011 to December 2017. And we checked for the ODI, VAS, back and leg pain at different intervals of time. So in the retrospective group, there were 131 patients with 1-level degenerative spondylolisthesis. And you can see that, about 1/3 of these patients underwent decompression alone. So almost 1/3 of patients were saved from a bigger surgery and a fusion. So, when you compare the fusion group versus the decompression group, they almost did as well with regards to ODI as well as, leg and back pain. So the magic figure we derived from the retrospective study was those patients who had scored less than 5.5 had undergone decompression, and those who had scored 5.5 and above had undergone a fusion. So in the prospective group, you see, when we analyze the prospective group, so there are 52 patients out of 200, that is 1/4 of patients who had undergone standalone decompression. So almost 1/4 of these patients were saved from a bigger operation. So of course there were few in the follow-up there are few failures, about 4 patients who had to undergo fusion later on, and 2 patients were lost to follow-up. But if you see, about almost 1/4 of these patients underwent, so 4 patients underwent a fusion. And again, in the prospective group, they equally did well, both the groups. I'll come to an example. So this is a 74-year-old elderly lady with a very low impact lifestyle. She has only claudicant leg pain. So there is no back pain. She has one-sided leg pain. Now let's go through the scoring system. So 0 back pain, age higher side, lifestyle is low impact, no mobility on dynamic X-ray. She just has a slip. So there is hardly any disc height here. The facets are coronally oriented, and there is no effusion. And this is there's good amount of bone that so there is technically this patient is feasible for a decompression procedure. It's a burnt out degenerated segment L4-5. You can see the stenosis in the axial and the sagittal planes. So the score is just 1. So why will you fuse this patient? So we have described this, tubular decompression, our own technique in various, on various platforms, in conferences, textbooks, journals, articles, etc. So this is what we did. We did a ipsi contra decompression. You can see the sagittal image pre-op and post-op, a very well decompressed canal. Again, a pre-operative axial and a post-operative axial image showing a very well decompressed canal. The lateral recesses are free. So all was done using these tubes with a very small incision. So, when we see a patient like this who comes to the clinic, if you just see the X-ray, you'll think of putting screws, rods, cages, just looking at the lateral X-ray. But this is a one-dimensional approach. We need to see the patients from all dimensions. We need to see them from holistically. You need to take their history first. You need to see their flexion extension X-rays. In this patient, you see there is hardly any mobility. Look at the disc height. Okay, it is almost same when compared to the other adjacent level discs. Look at the axial sections. So the facet joints are coronally placed. So this is an inherently intrinsically stable situation. The patient is having no back pain, so patient doesn't have any instability in flexion extension. She just has a fixed listhesis at L4-5 and a very protective facet orientation. So this patient underwent a decompression alone. On the other end, this patient is quite obvious. The patient is a 59-year-old young male who has back pain, who has neurogenic claudication, he has mobility and flexion extension, he has facet effusion, he has a sagittally oriented facets. So this adds up to 8.5. So this will need fusion. So this scoring system also helps in deciding fusion for a patient. So, in the olden times when the MRI was not available, the degenerative listhesis group as well as the stenosis group was considered as one. And these patients underwent this, Christmas tree decompression. Following this Christmas tree decompression, where all the posterior elements were excised, the patient hardly got up from the bed. So this used to lead to severe back pain, severe leg pain, neurological deficits, and very bad results. This would cause iatrogenic stability. That is when Herkovitz came up with this landmark paper where he suggested fusion for all these patients. This won a Volvo Award, Issel's Volvo Award. And then, everyone followed the Pied Piper. So there are numerous papers supporting fusion for degenerative spondylolisthesis. And at the same time, this coincided with the boom in the pedicle screw market. And once market takes over science, there's no one to stop. But there are drawbacks of imagining or assuming that all cases of listhesis have to be fused, because this is a relatively longer, more morbid and costly operation and is not free from complications. And now that I've shown you that this particular entity is not a homogeneous entity, there are many factors which influence decision making. So the current thinking should be to customize treatment for each individual patient. See, even now, out of 100 people who are, listening to this particular presentation, 40% of us may be having a listhesis which is more than 3 millimeter. That doesn't mean we fuse all of them. Again, we as senior holistic spine surgeons, we know that L4-5 degenerative spondylolisthesis is inherently stable. They do not usually progress beyond grade 1. In many of the situations, even after decompression, they restabilize. Radiological progression does not correlate with clinical progression, and surgery is required in only 10 to 15% of these patients. Again, we had published some time back to say that in case of a disc bulge, a hard disc bulge or a calcified bulge in a patient with canal stenosis only, who has free SLR, who has relief with sitting, there's no need to touch the disc. There's no need to do a discectomy in such situation, because the disc itself acts as a main stabilizer. Again, now we know that minimal axis decompression, there are tons of papers supporting that this leads to excellent results in degenerative listhesis. The progression rate is hardly 2.6%, and many of these restabilize. The need for second surgery is less than 1%. And again, you can't compare the cost of a simple decompression versus a complex fusion procedure. This is another paper which we had published, wherein we had shown that not all synovial cysts are unstable. Almost 90% of them are stable. And in this group of 30 patients, 8 of them had fixed degenerative spondylolisthesis, where we had done decompression alone. So this is our scoring system. So this system is holistic in nature. It looks into patients' demands, radiographs, MRI, the technical feasibility of performing a decompression, and clinical parameters. So it is a very holistic in nature. It takes into a lot of things into parameters. Our paper has been significantly and quite expansively discussed in these 2 recent papers which are published in the Spine Journal by the NAS and this particular journal in Spine. And another journal which is published just this fortnight in JB Bone and Joint Journal, Britain, from a very reputed group from Switzerland, where they also compared a decompression versus fusion, and they have discussed our paper and our classification system in the same paper. There are, however, limitations of this study. It is not a randomized control study. It's a single surgeon study. Hence, it is influenced by surgeon bias. We need to do multicentric studies in Russia, India, BRICS, wherever. It is a technically demanding surgery. So doing a minimal access decompression in such a situation, it may not be feasible for everyone, especially the beginner. Hence, technical expertise is also very important. So to conclude, current literature fails to systematically subclassify patients with degenerative spondylolisthesis. It is a heterogeneous condition requiring surgical intervention, which is to be tailored to each patient. Decompression, just like fusion, has a central place in the management of degenerative spondylolisthesis. This particular scoring system is a reliable tool in planning treatment in degenerative spondylolisthesis. Thank you.
The name Arvind is Renato from Brazil. How are you? We've been here the last time.
Yes.
Yeah. I used to say that we treat the clinics, not the image, but
yes,
yeah. But sometimes it gets difficult to spread these things. I used to be guided by the clinics, but how you consider the circumference arthrodesis when it needed?
I do an interbody fusion.
Pardon?
I do an interbody fusion.
Yeah. Okay, thank you.
Thank you, Arvind. You can start your next presentation, spinal osteoporosis assessment, DEXA or quantitative CT.
Yes. One. So, just a minute, sir. Yeah, can you see the present? Not yet?
Not yet.
Yeah. Yeah, how about now?
Yes.
So thank you again for allowing me to for this invitation. Now there is a universal consensus that everyone above 70 years of age in terms of men and 60 years in terms of women should undergo bone densitometry. This is recommended by the endocrine group long back. So this is again echoed recently in this particular article which was published in Spine. So this says it's a group of spine surgeons, neurosurgeons, rheumatologists, endocrinologists, and many other physicians who have come with these best practice guidelines in the management of osteoporosis. They also recommend that everyone above 60 years of age should undergo a bone density investigation. So why is it relevant? This particular age, why is it relevant to spine? Because this is the age at which we suffer from vertebral compression fractures. This is the age that suffers from complex lumbar canal stenosis. This is the age that suffers from adult spinal deformity for which they need surgery. And this is the age where a large proportion of them complain of low back pain. Now, undiagnosed osteoporosis in this particular group we all agree, can have devastating consequences. It can lead to pedicle screw loosening, instrumentation failure, AVN of the vertebral body,
we all know that proximal junctional kyphosis is a demon which we are all fighting, and one of the reasons is osteoporosis. And again, all these situations may need revision surgery, where again we'll face the same problem of osteoporosis if it is not been corrected earlier. So this particular group of patients who comes to us with for surgery have this age group of above 60 who come for spinal surgery to us is a vulnerable population, because this group of patients suffers from comorbid conditions like diabetes, hypertension, renal failure, ischemic heart disease, etc. So osteoporosis in this particular group of patients is like bull in a china shop. Again, so we should be glad that there is a strong evidence that now with the current medicines that we have, current drugs that we have, such as teriparatide, denosumab, bisphosphonates, etc., these patients can be treated, which is not possible earlier. So what is the problem? What am I talking about? Where is the problem now? See, only less than 20% of this particular group gets investigated. What we see in the society is just the tip of the iceberg. And the investigation of choice that we use, that is DEXA, is totally misplaced. I'll tell you why. The density of a three-dimensional structure, such as bone, is not... it has to be measured in 3 dimensions, that is length, breadth, and depth. If you see DEXA scan, it is based on an anteroposterior or lateral X-ray of a patient. So it takes into purview only the length versus into the breadth. It doesn't look into the 3rd dimension, that is the depth. So that is where it is wrong. So if you ask even a 3rd standard school-going student what is the densitometry of a volumetric substance, he would say that it is quantity per unit volume, and volume is measured by length into breadth into depth. So that is one fault of DEXA. Second, the DEXA is used not because of any scientific reason. It is only used because it is available very easily all over the place and it is of low cost. That is the only reason. And in a majority of patients who need DEXA in this age group, they have facet arthritis, they have calcified aorta. These artifacts interfere with the assessment of bone density. For example, for this particular patient, if you see, if this patient goes, you see on the lateral X-ray, you'll see this is called picture window appearance. Only the outlines of the vertebral body are seen. So looking at the lateral X-ray, you don't even need DEXA to say that this particular patient is having osteoporosis. But if the same patient undergoes a DEXA scan, there will be overlap of this calcified aorta in an AP X-ray. Okay, when that happens, you'll get a false reading, and 40% of the adult population has abdominal aortic calcification. Again, if you have a situation like this where the patient has severe facet arthritis, on the lateral X-ray, you see it looks like the patient is significantly osteoporotic, but on the AP X-ray, it looks white. So that is the problem with DEXA, because most DEXA centers do a AP evaluate or extract bone density from the AP view of the spine. Again, the fat overlap. Many of these patients, are extremely obese because they have stenosis. They don't walk. This particular age group that we treat, and because of that, they are fat and they're obese, and that also adds to the density when you're doing a AP X-ray. And some centers advise a lateral DEXA, but in lateral DEXA, the lower part you have the overlap of the iliac crest, and higher up there is the overlap of these ribs. So again, you will get wrong reading, and it's also affected by the patient's positioning. And this is a very interesting article. See, this is measurement of bone density of all the elements of the vertebra. So this is inferior facet, this is lamina, pedicle, superior facet, spinous process, transverse process, and this is a vertebral body. This is in the descending order of the bone density. You can see the fattest, that is the vertebral body. The vertebral body, which is the fattest, is least dense. It has the least bone mineral density. Now, this is interesting because 80% of the spinal load goes through the vertebral body, and this has the least, bone density. And this is the area, the anterior column where the vertebral bodies are. That is where there is trabecular bone. That is where there is spongy bone. And this relates to compression fractures, pedicle screw loosening, progressive kyphosis and sagittal balance, imbalance, flexion dominant pain. And this is where we try to achieve interbody fusion. So vertebral trabecular bone takes the spotlight in the context of spinal osteoporosis, and its precise evaluation is crucial to address the burden. So optimum trabecular bone density is critical for the success of spinal fusions. So look at this particular patient. So based on the WHO recommendation, if a patient has osteoporotic compression fracture, the bone density should be less than minus 2.5. So this patient has 2 consecutive vertebral body compression fractures where I did a vertebroplasty, and the bone density here is 0.2. When I subject the same patient to a QCT, quantitative CT, it is minus 3.2. Again, a similar patient, vertebral compression fracture, the bone density based on DEXA is minus 1.5. But when I subject the same patient to quantitative CT, it is minus 2.7. And we also know the strength of the pedicle screw gets stronger as it enters the strength of the pedicle screw is directly relates to its depth into the vertebral body. So the vertebral body has to be strong to get a good purchase. Again, when it comes to interbody fusion, there are high rates. There is evidence to show that there is high rates of pseudoarthrosis in osteoporotic patients, and fusion is difficult to achieve in osteoporotic patients. And this leads to systemic failure. And again, at the same time, there is good relations between good bone mineral density and fusion. So there is excellent correlation between bone, Hounsfield units, that is measured by quantitative CT, and compressive strength. So that is why we came out with this particular paper, which was published in Spine this year. Should QCT be the gold standard for detecting spinal osteoporosis? So this is how it is measured. It's a volumetric assessment of the spongy trabecular bone using CT scan. It's a low dose CT. So we compared a age-matched group of postmenopausal women, patients who are more than 60 years of age. There are similar groups. 447 underwent a QCT and 271 underwent DEXA. They were age-matched, and they were all sex matched because they're all post-menopausal women, and they almost belong to the same age group. What we saw was quite alarming. So the most common score, which is mode, in this group of patients was minus 3.8 versus in DEXA where it was minus 1.7. The average was minus 2.71, whereas in DEXA it was minus 1.63. So if you see the bell curve, a large majority of patients belong to the osteoporotic group when QCT was considered. And when the DEXA was considered, a large majority of them were either osteopenic or normal, showing that, the DEXA underestimates the bone strength. So this is a patient who underwent a DEXA. You can see the T-scores here. At the same time, this patient underwent a QCT, and you can see the T-scores here. There's an alarming difference. So the kind of scores we see in quantitative CT is, in the higher range, minus 4, minus 6, minus 7. There are some concerns about radiation when it comes to QCT, but they are all highly misplaced. So these doses of radiation that you give QCT somewhere between X-ray and a CT scan. It is equivalent to a combination of a AP and lateral radiograph. So this is from a textbook. So spine thoracic radiograph, that is chest X-ray AP, is 400. Lateral radiograph is 300, which is equivalent to 3D QCT, which is 700. But however, it is precise. The quantitativity, it is a volumetric measure. It gives a true measure of bone density. There is no discordance related confusion that is not affected by bony overlap or fat. Again, if you want to minimize, you need to have a properly calibrated machine with which it is possible to deal with the lowest dose and get your QCT values. This is called automatic exposure control. So this is a method by which with the least amount of radiation one can get your QCT values. Again, even if there is some extra radiation when compared to DEXA, the trade-off is precision versus extra radiation. So friends, it is time that we rethink the application of DEXA to assess spinal osteoporosis, because most of the times it gives faulty values. I feel that, practical gold standard for assessment of bone density is a quantitative CT. Thank you.
Thank you, Arvind, for your excellent presentation. I want to ask you one question. Do you estimate vitamin D level in osteoporotic patients?
Yes, we do it routinely.
Thank you very much. У кого-то есть вопросы?
I ask you a question. Do you have an experience with sublaminar fixation, just with bands, polyester bands, for example? I used to do it in some cases.
I don't have any experience. What is popular here is sublaminar wires.
Yeah.
Sublaminar wires, because the lamina is thick in elderly patients, so that gives better hold than pedicle screw in these patients.
Well, we stopped using wires in the 90s because there had no way to follow up the patient with an MRI, something like this. We changed for bands, and it's a reasonable solution for some kind of patient. I think, okay.
Sure.
Thank you very much. You can start your next presentation. Spine safety checklist helps. Безопасность позвоночника, чек-лист помогает.
Just a second, sir.
No.
Oh, sorry. Can you see?
No.
All right.
Yes.
Yeah. So this is a very novel component of spine surgery that we have devised. So every big or small enterprise, such as a flight journey or simple holiday, needs some amount of organization, which is called a checklist. So how does a checklist help? It helps in achieving success and preventing failures. Even a meeting today, is based on a checklist. Everyone from BRICS is attending or not. All the, invited faculty, have they logged in or not? You sent us enough messages, etc. This is basically a way of organizing things This covers for the weaknesses of the human memory and forgetfulness and increases efficiency by adopting just simple steps like, ticking against a task. So what better example? Every household now knows what a checklist means. Before leaving your house, you wear your mask, you apply sanitizer. Pre-operatively, we have this checklist of doing RT-PCR, doing HRCT, etc. So every household, not just a doctor's household, every household is aware of the word checklist. So in a way, hospital is a disaster zone because majority of these complications occur in the hospital, and 50% of these complications, especially deaths, can be prevented. About almost 50% of post-operative complications happening everywhere in the world, in the best of surgical units, can be reduced by following a checklist. So why do these particular complications occur? Has expertise failed? Have super specialists failed? Have expensive medicines failed? Is it sophisticated devices that have failed? It's not because of any of these. It's because of oversight, overconfidence, and a casual approach that we have complications, morbidities, and mortalities. So these checklists do not teach you how to operate a complex case of scoliosis. Instead, they provide reminders of only the most critical and important steps, the ones that even the highly skilled surgeons using them could miss. This was adapted from the checklist by Atul Gawande. So as I said, it's basically because of oversight, casual approach, but most importantly, it is the communication gap within the team that leads to forgetfulness and complications. So when you're operating on a patient, when you're taking a patient under your umbrella for his or her treatment, it is not just one person. To save one life, scores of people must perform 1,000 things correctly and simultaneously. It is your admin, it is your ward boy, it is your nurse, your operating nurse, your assistants. Everybody is involved. So a score of people should perform things correctly, simultaneously in a coherent fashion. It is like an orchestra, as I said. Again, the WHO checklist has shown its reputation. There is striking evidence, especially in low and middle economic group countries. It is reduced infection rate by about 50%, reduced mortality by about 50%, and we have a good Indian experience also. So when there is already a checklist, WHO checklist, why should we have another, spine surgery checklist? Why reinvent the wheel when we don't have to? That is because spine surgery lies at the zenith of permutation and combinations. There is significant crowding of thoughts. There are multiple regions, there are multiple junctions, there are multiple vertebrae. Then again there is right and left. Then again there is anterior and posterior. Then when it comes to surgery, whether you're going to just fuse or you're going to, whether you're going to just decompress or you're going to fuse. And if you're going to fuse, are you going to use CM or are you going to use navigation to put your screws? Do you need bone graft? Do you need bone cement? Do you need a drill? Do you need extraordinary infrastructure such as robots, etc. Microscope? Do you need a microscope or not? So there are so many things that we need to take into consideration when it comes to operating on a particular patient. So there is a good scope, there is abundant scope for things to get lost in a flow of thoughts. Look, for example, this particular patient, he came with myelopathy, he underwent an unblocked laminectomy. There was profuse, uncontrollable cluster bleeding from various sources. The blunder was there's no grouping and cross-matching done. It is a very simple part of our pre-operative protocol, but this was not done. And this particular patient, we lost him. Another patient where when we are doing this L5-S1 lytic listhesis, we made a big hole when you're trying to put the S1 pedicle screw. This is a common scenario. And then we had to cover it with a bigger screw, that is a 7.5 mm screw, and that was not there in a tray. And either I had to be happy with the compromise fixation, or I had to wait and waste my time. So I had to wait and waste my time. We had to wait almost for 2 hours for the implant guys to deliver 7.5 mm screws, get it autoclaved and use it. This is not acceptable. And I do minimal access surgeries, and I go to 2-3 hospitals. A couple of times it is so happened that the tubular set which had to arrive in a particular hospital had not arrived. So I was unhappy and I had to go ahead with a micro discectomy. So this is the reason we have something called the pre-operative checklist. So here we take into consideration patient's fitness, what are the essentials required for the patient's surgery. It's an elaborate list where nothing is missed. All the investigations, requirement of blood, if they're necessary for a physician, not a physician, super specialized physician, just like a neurologist or anyone to see, cardiologist, etc. Most of the things are covered in this particular pre-operative checklist. If there is any bailout surgical plan that is required, if a particular plan fails, that is a plan B for a particular surgery. Now, then coming to this particular case, so this was published in JBJSA, where they did a wrong level discectomy because of being negligent in the OT. So that's why we have an intraoperative checklist. The first one is the pre-operative. This is the intraoperative checklist, which takes into consideration the golden hour of giving antibiotics, the positioning of the patient, confirmation of level, any biopsy to be required. Most importantly, final tightening of the top screws, which can be a bit forgetful in some patients. In some patients, we need local vancomycin powder, drain tug so that the drain is not stitched. So these kind of situations are covered in the intraoperative checklist. Then we had a patient who had meningitis following lumbar canal stenosis decompression surgery, and she came back to us, with a full-blown meningitis, and this is another patient whom we lost. So that is why we have something called the post-operative checklist, which apart from evaluating the patient at discharge, also checks into consideration whether discharge advice has been given to the patient or not. So there are 3 components to the this particular checklist. Pre-operative, because all battles are first won in the mind. Second is it considers it takes into consideration basically the WHO components plus components which are specific to spine surgery. Post-operative is the most important part of a checklist because this is when you experience complications, phase of complications. So this we implemented for 1 year in 2016-17 and compared it with the previous year, and we saw that there was a close to 75% reduction in our complication list. This is in spite of us being a very, very vigilant unit. So this is a comprehensive 37 point checklist. So this I'll not go through the details. Basically to show that how there was a change in the percentage of complications in the previous year and the year where we implemented it. So following a checklist is a routine practice for us because we've been doing that. So this is not something new. So this is a pre-operative anesthetic checklist, and this is a checklist of action that needs to be taken in response to an intraoperative monitoring changes. So this is something which we are used to. So why a spine surgery checklist suits our environment, especially in India, or I think many of the BRICS countries, because there is stigma associated with spine surgery. We carry the infamous tag of failed back syndrome. The kind of complications that we face are irreversible and unpardonable. The costs are huge. Our OT boys and nurses are untrained. There's a high volume of surgeries that we do. And we have limited and bizarre distribution of resources. For example, if you need a neuromonitoring machine for us, not every hospital has neuromonitoring machine, and we have to actually book them. So there are 4 or 5 floating neuromonitoring machines in the city, and we need to book them. So we have a limited and bizarre distribution of resources, and we need to book them as early as possible when you are planning a scoliosis surgery, etc., deformity surgery. And we don't have the complete stationery in our hospitals. We usually order stationery. So it is important that we have the right stationery, that means implants, when we are doing a particular surgery, including the bailout implants. And our fellows and residents, they keep changing. So it is important for us to follow a particular checklist, which even a new incoming resident can follow. And we have a very poor and disconnected surgeon and general practitioner algorithm. In case for a general practitioner to pick up a complication and connect with us, we have a very poor algorithm. So checklists bring discipline. Checklists give guidance. Checklists aid in decision making. So this is the checklist that we follow. This is a pre-op, intra-op, and a post-operative protocol that we follow in the checklist. So this one Safety in Spine Surgery Award in 2021. It was published in Asian Spine Journal. And so these are various applications, all positives with regards to checklists. Checklists allow surgeons to concentrate on non-mundane stuff. It is application of knowledge we have consistently, correctly, and reliably known. It's making things happen correctly. Checklists show that each problem has steps of solving. Checklists show that each step is important. Checklists show that the more you repeat it, the more you master it. It reduces error making. It offers the possibility for verifications. It establishes an effective teamwork. It helps in effective utilization of resources and skills. It helps to improve provision of quality services. It provides customer satisfaction, and it provides reminders of the most critical and most important steps. So now we have come out with a web-based checklist, which my fellows and myself can enter using a username and password. Again, this one 2022 award by the same group, that is Safety in Spine Surgery Group. So to conclude, this particular novel checklist is efficient, reliable, and cost-effective. There is a learning curve to application of this particular checklist. It is subspecialty specific to spine. It reduces miscommunication among the primary surgeon, training fellows, and the OT staff. Again, based on your own local circumstances, you can customize it and use it to its best extent. Thank you.
Thank you very much. Arvind, есть у кого вопросы? Do you have some questions?
No.
Thank you very much for your participating in BRICS Spine meeting. Keep in touch.
Yeah.
I hope
thank you.
Maybe we can possibility to see you face to face. Thank you very much.
Sure. Thank you again for the opportunity.
Thank you. Следующий доклад у нас осталось небольшой рывок. Сильвио Мистро, Spinal Infection in Elderly Population. Инфекционное поражение позвоночника у взрослых.
Hello to everyone. I'm Silvio Mistro from Brazil. I work in the University of Campinas and Germanic Hospital Oswaldo Cruz in Brazil. I'm going to tell you today about spinal infection in elderly. There are no conflicts of interest to declare in this class. Well, elderly is a person over 60 years old, and in Brazil we have about 14.7% of the population. That is about 31.2 million of people. And in the world we had about 1 billion in 2020, and we will have 1.4 billion in 2030. Spinal infection is a pathological condition that tends to take a long time to diagnose and requires joint work between spine surgeon, radiologist, and infectologist. The nomenclature under the term infection of the spine is somewhat complex and confusing and can vary between different facets of the infection. This term can vary among descites, spondylodescites, septic face joint, and epidural abscesses. The incidence of the spinal infection is about 2.2 each 100,000 per year in the general population, and in the elderly can active about 3.4 each 100,000 of people. Most common type is primary pyogenic spondylocysts by the hematogenic route. It's more common in men twice than in women, and the lumbar it's followed by dorsal and cervical in this site of the dissemination. There are some peculiarities in the elderly. Comorbidities are frequent and may confuse the clinical complaint. Inflammatory pain or chronic neoplastic pain, osteoarticular degenerative disease and chronic pain, cognitive deficits, and institutionalization. This can take a delay in diagnosis. In the elderly, the presentation and diagnosis tend to take longer, with higher infectious markers, less presence of signs and symptoms of infection, which also contributes to worse evolution in this population. The mortality in 1 year is about 21% in the elderly and 3% in the general population. Cardiorespiratory events is about 10% in the elderly and 3.8% in the general population. But when the people survive, the quality of life is about similar between the two populations. The clinical findings. The pain is most common symptoms with or without irradiation. In the elderly, due to greater presence of degenerative alterations, pain can be confused and not taken as serious as it should. Fever present in 50% of the general population. It's less common in the elderly. Neurological deficit is present in 30% of the people, with higher rates in the elderly. This can be due to great bone fragility that leads to more fractures in the elderly, the higher prevalence of the canal stenosis that leads to higher compression rates, and the diagnosis can take weeks to confirm and even longer time in the elderly. The diagnosis made by a clinical history and physical examination together with laboratory tests. Among them are white blood cell count, C-reactive protein, erythrocyte sedimentation rate, and blood cultures. Blood cultures and biopsy positivity rates are approximately 50%. CRP in general are present with higher rates in the elderly. We have the images for the diagnosis. The magnetic resonance, computed tomography, X-ray, bone scan, and almost all the time we had to perform biopsies, percutaneous or open ones. The microorganisms, Staphylococcus aureus, are more prevalent, followed by Streptococcus and Enterococcus. And the Strepto and Enterococcus are more common in older than 75 years. Anaerobic organisms are less common, less than 4%. In general, we find a similar prevalence between young and elderly. The treatment is made by good analgesia and pain control, the agent identification and prolonged antibiotic therapy, immobilization or bracing, and sometimes the needs to perform surgery with fixation and drainage of the infection. We have a brief demonstration of a woman with 65 years old with no specific low back pain, no neurologic deficit, no fever, no trauma, with a past 1 month colonoscopy, with the magnetic resonance of the first day of the stay in hospital with little findings, but maintenance of the pain after 7 days, repeat MRI with significant alterations in the L2, L3 spaces, fever, blood culture positive by Enterococcus microorganism, and introduced empirical antibiotic therapies. Treatment with thoracolumbar orthos and antibiotic therapy with good evolution. Take home message: always watch out for back pain in the elderly. Its suspicion may lead to an early diagnosis of infection and great chance of a brief and better treatment for the elderly. Thank you very much.
Thank you very much. Next presentation: Management of scoliosis after high-grade spondylolisthesis surgery. Лечение сколиоза после хирургии спондилолистеза. Vinicius Tapia.
Hello, my name is Vinicius Tapia, and I will present you the management of scoliosis after high-grade spondylolisthesis surgery. I have no conflict of interest. We see in the introduction that the incidence of the scoliosis with spondylolisthesis varies between 15 and 43%. The curves are divided in 3 major groups: type 1 idiopathic scoliosis, type 2 allostatic scoliosis, and type 3 asiatica scoliosis or spondylotic caused by a neural compression and muscular spasms, like we see here in the table. Regarding the treatment of these associations, many authors suggest an individual protocol for each pathology, but others consider a single treatment as if it is one disease. The difference of opinion is even greater in the case of high spondylolisthesis. The study has the purpose of evaluating the behavior of scoliotic curvature in patients submitted of a high-grade spondylolisthesis surgery. We evaluate the behavior of scoliotic curves in patients submitted to a high-grade spondylolisthesis surgery. This study consists of case presentations of 10 patients submitted to surgical treatment of high-grade lumbosacral spondylolisthesis at a national reference hospital for spine pathologists during the period of January 2004, first digital report of this treatment in the hospital database, to December of 2016, the last patients of a 2 years follow-up period. We analyzed variables that consist of spondylolisthesis etiology, Myerding grade, SDSG classification, scoliosis etiology, length classification for idiopathic scoliosis, and others. Out of a total of 22 patients submitted to high-grade lumbar spondylolisthesis, 10 patients completed the sample after inclusion and exclusion criteria that we apply. The subjects were divided in 2 groups: those with associated idiopathic scoliosis and those with non-idiopathic scoliosis. a descriptive analysis was conducted to summarize patients' data and surgical procedures. We have 4 female patients in this group, in the group of non-idiopathic scoliosis. When we evaluated the group of patients with non-idiopathic scoliosis, 4 of them, 35% of the group, the majority of them, 3, presented a magnitude reduction of the scoliotic curve on the last follow-up comparing to pre-op. In this case, a 37-year-old female with chronic backache without neurological deficit. Here we can see the radiographs. A high spondylolisthesis associated with 14 degrees scoliosis. After a sacrum osteotomy and a reduction of the listhesis, plus a L3S1 posterior arthrodesis, we can see a reduction of the scoliotic curve of the patient. In this other case, a 39-year-old female with chronic backache without neurological deficit. Here we can see a listhesis myrodin 4 associated at 13 degrees scoliotic. After the L4, L5 decompression and reduction of listhesis and L4 iliac posterior arthrodesis, we can see the reduction of the scoliotic curve to 9 degrees. In the other group of idiopathic scoliosis, we have 6 patients. We have 3 myrodin 3 and 3 myrodin 5. When comparing Engel's value of pre- and post-surgery scoliotic curves, in most patients with associated idiopathic scoliosis submitted to high-grade listhesis, the primary curve remained stable or had a mild reduction, as we can see in the table. In this case that I present, it's a 14-year-old male with right lumbocytalgia. In clinical photographs, we can see a coronal imbalance of the patient. Here we can see the radiographs. The CT of the patient. And we did a L4S1 decompression plus a L5S1 reduction of the listhesis and a L4S1 posterior arthrodesis. The CT evidence a consolidation of the arthrodesis. In this other case, a 17-year-old female with left lumbocytalgia. The clinical photographs of the patient. We can see in the radiograph a link 1 associated with a myrodin 5 listhesis. We did a sacrum osteotomy plus L5S1 reduction and a L4 iliac posterior arthrodesis. Here is the post-operative. We observe in this case that the primary curve remained stable. In this article of Crostelli and Mazza, they defend in their review study that spondylolisthesis and scoliosis should be treated together, and they verified that spondylolisthesis has a little influence on this scoliosis etiology. We can see they studied 25 patients with symptomatic listhesis and only 6 patients have scoliosis, 4 of them under 25 degrees. Without resolution all these cases. In this other study, Zhu presented a case of a 12-year-old adolescent with high-grade spondylolisthesis associated to scoliosis with a primary thoracic curve of 50 degrees. The patient was treated only with a posterior decompression with segmental instrumentation in L4S1, and they accomplished complete resolution of the scoliosis after 2 years follow-up. This study found that there was a resolution of scoliosis in most of non-idiopathic patients submitted to treatment of high-grade spondylolisthesis, and most of these patients with idiopathic scoliosis presented a reduction or maintenance of the primary curve magnitude. This study need more. We have a few limitations. We must consider it because it's a case presentation, such as the small sample of 10 patients that hampers the association analysis and the presence of confounding variables, and we need for more multicentric studies due to low prevalence. And that's it. Thank you. Bye-bye.
Thank you very much. Next presentation, Discitis in neonatal children, дисцит у новорожденных детей, Andrea Anjura.
Hello, my name is Andrea Anjura. I'm from Brazil, and I talk about discitis in neonates and children. Discitis is not a very common disease. We usually see 1 to 2 cases a year, and the most common place is between L4 and L5, and the most common pathogenous disease is Staphylococcus aureus. The natural history of neonates is very different from childhood and adults. And in childhood, they usually present to us with few symptoms, usually with a prolonged history. If they are small children, they usually refuse to sit, or they may present with limping, with back or abdominal pain, and some lumbar lordosis certification, and stiffness of the back, like this boy, that he can't bend over because of his pain. They also may present with scoliosis, and which usually is very flexible, and rarely with radicular pain. The natural history in childhood is very benign. Resting after treatment, they may persist only with some end plate irregularity or disc space narrowing, without any functional limitations, and rarely they get ankylosis of the disc space. The treatment is usually a course of oral antibiotics for 4 to 6 weeks, and IV antibiotics is usually only if the patient has systemic symptoms. We may use brace for patients with a lot of pain in the acute phase, and surgery is reserved only for patients with intracanal abscess or residual mechanical instability, which is also very rare. This is a patient of 1 year and 10 months old. He got a discitis here, and when he was 3 years and 9 months old, he had only irregularity of the end plate and some narrowing of the disc space. This child, 8 years old, she had a 3 months history of back pain, and she had the discitis between L4 and L5, and she got 6 weeks of oral antibiotics, and after 6 months, she got only some narrowing of the disc space. This boy, he was 18 months old. She got a L1, L2 discitis, and he was treated with oral antibiotics. And after treatment, she got an ankylosis between L1 and L2. And this adolescent, she had scoliosis, which was very flexible and back pain because of L5S1 discitis. And she was treated with oral antibiotics. And a brace because of her scoliosis and back pain, and she got better without any restriction. The natural history in neonates is very different from childhood. The neonates have these vessels that reach the disc and fibrous annulus through the end plate, and reaching the bone of the body and causing osteomyelitis of the body, and absorbing usually 2 or 3 vertebral bodies, causing but preserving the posterior elements, causing an acute angled kyphosis, which usually is progressive, causing stenosis and spinal cord compression with neurologic deficits in the evolution. In the acute phase, they are usually neonates premature with low weight, under sepsis in the neonatal ICU, using IV antibiotics. Their labs are usually normal, and the symptoms are only irritability for bath or changing diapers, and some maybe also painful breastfeeding. The X-ray will show body destruction and kyphosis. But if they pass through the acute phase without diagnosis, they may present to us because of delayed neuromotor milestones, because of neurologic deficits, and only because of the deformity. The treatment in the acute phase is IV antibiotics, and we should prevent the kyphosis using casting or bracing. And surgery is done only if the patient presents with neurologic deficit, like this 3-month-old boy that had a progressive deformity and neurologic deficit, that was submitted to an anterior decompression with using an anterior ulnar strut graft and posterior site of fusion. He got complete recovery after 1 year of the surgery. In the chronic phase, we should monitor kyphosis and neurologic status, and we should follow them until around 3 to 4 years old, which in my mind is the best age to do the surgery before neurologic deficit happens. And we may use the Rajaz-Zakaran classification for tuberculosis to understand the prognosis of the progression of the deformity and neurologic risks. This patient had neonatal osteomyelitis. He presented to us only with 1 year old, and he had this kyphosis around in T3 and T4, and we followed him until 4 years old, and we did a posterior approach with a PVCR, and anterior decompression and posterior instrumentation. And he was, this is him after 6 months old. This is another patient that presented to us when he was 10 months old. He had osteomyelitis in neonatal during neonatal period, and his kyphosis was very, very flexible. We tried to do a casting, and he got better just with casting, evoluting with ankylosis between T12 and L1. So the cities in neonates and children are very different. In childhood, the natural history is very benign. So the oral antibiotics usually is enough to treat. And neonates evolve with body destruction, with acute kyphosis and neurologic deficit. And the surgery should be done before the neurologic deficit happens, usually around 3 to 4 years old. Thank you.
Thank you very much. Next presentation, cervical instability in Down syndrome, нестабильность шейного отдела при синдроме Дауна.
Hello, let's talk about cervical instability in Down syndrome patients. Down syndrome was first described by Sir John Langdon Down in 1866 and was the first chromosomal anomaly described in the history. It is the trisomy of 21st gene, and presents with a lot of physical features and a lot of medical conditions. And the musculoskeletal conditions are very common, including atlantoaxial instability and occipital C1 instability. The atlantoaxial instability was first described in 1961 and is very common among the Down patients. And the instability of C1, C2 articulation is made by transverse ligaments, alar ligaments, and the apical ligaments. And the instability is because of the laxity of the transverse ligaments, the flattened C1, C2 facets, and some abnormalities of the odontoid like hypoplasia, complete absence, and odontoideum. The instability in Down syndrome, atlantoaxial instability in Down syndrome patients is usually is asymptomatic, but less than 2% is symptomatic, usually because of neurologic symptoms like gait abnormalities, incoordination, spasticity, hyperreflexia, clonus Babinski, and weakness, fatigue, bowel or bladder incontinence. The evaluation of atlantoaxial instability is made by the atlas-dense interval, which in Down syndrome, the normal is considered less than 5 millimeters. The symptomatic patients usually have more than 7 to 10 millimeters in this measurement. The space available for spinal cord is also a measurement and should be at least 13 millimeters as the norm. The occipital C1 instability is present in up to 64% of Down syndrome patients and may coexist with the atlantoaxial instability. It's very difficult to make the diagnosis, and the measurements are the power ratio and the Weisel-Wotman technique, which is difficult to measure, but when we suspect, we should order an MRI, inflection, and extension to confirm the diagnosis. The radiological screening is very controversial if we should do or not. The first description of radiological screening becomes from 1983 from the Special Olympics in the United States that determines that patients with Down syndrome with atlantodense interval more than 4.5 millimeters should be excluded from sport with stress on the neck and head. In the next year, the Committee on Sports Medicine of the American Academy of Pediatricians confirmed this screening, but 10 years later they retired this statement because the neurologic signs and symptoms remain stable for months or year and rarely progress to paraplegia, quadriplegia, or death. And they suggested that all Down patients should be submitted to routine clinical evaluation, not radiological, and radiological screening only when positive signs, clinical signs were present. In 2004, the Special Olympics again reviewed and maintained the need for radiological screening for every Down patient before the practice of sports. And in 2011, again, the American Academy of Pediatricians stated that routine radiological screening was not recommended, only if the patient had symptoms and should be done a lateral X-ray, and if significant abnormalities is found, then further radiographics should be taken in these patients. So, currently, when we should screen the Down patients for atlantoaxial instability or occipital cervical stability? Before undergoing surgery, before sports that present with high risk of head and neck trauma, before school is controversial, around 4 to 5 years old, and all patients, symptomatic patients, should be screened, of course. So the radiological screening should be a lateral cervical X-ray in neutral, flexion extension, and we should look for occipital C1 and C1, C2 instability, measuring all the space for spinal cord, atlantodens, Weisel-Rotman, and all the measurements. If the measurements are normal, we should keep evaluating the patient clinically every 2 to 3 years, and instruct parents to understand the signs that may happen to these patients with instability and especially neurologic signs. And if they have instability, asymptomatic instability, they should be submitted to a flexor extension MRI and symptom surveillance with annual neurologic and radiologic examination, and avoid risky sports. If they have symptoms, they should be submitted to a surgical treatment. The surgical treatment is usually indicated when there are neurologic signs of compromising of spinal cord, with atlantodens interval more than 10 millimeters, with the space available for the spinal cord less than 13 millimeters, and with the power ratio more than 1. The surgical treatment presents with high complication rates. It's difficult to achieve fusion. Pseudoarthrosis is very common, and we should use autologous bone graft with instrumentation and post-op halo immobilization. If reducible, we should make a decompression and then fusion. This is a patient with Down syndrome. She presented to me with this huge instability, with neurologic signs, and the parents refused to do the surgery, and a few months later, she went to death. This is another patient with Down syndrome that was submitted to posterior fusion with fusion. Here we can see. This is another patient with 4 years old with instability and myelopathy signs here, and it was submitted to a posterior instrumentation, getting fusion. Also another patient with 2 years old submitted to fusion with screws, and also getting a good result. So in summary, there is no consensus regarding the need for radiological screening for Down patients. The parents and pediatricians should be aware about the clinical and neurological signs of occipital C1 and C1, C2 instability. If the ADI is more than 10 millimeters or symptomatic, they should be fused. And we should be aware of the high rates of pseudoarthrosis, and autologous bone graft and wrist immobilization on post-op is necessary. Thank you.
Thank you very much. And last presentation, update of growing rods of early onset scoliosis. Обновление в использовании метода растущего стержня в лечении сколиоза с ранним началом.
Hello, let's talk about updating growing rods for EOS. We all know that early onset scoliosis are the deformity of the spine with onset less than 10 years old, regardless of etiology. And the pulmonary growing is dependent of thoracic spine growing that should reach at least 18 centimeters to avoid thoracic insufficiency syndrome. So the treatment goals are to maximize the form correction of the spine and thoracic cage, maximizing the spinal growth, the thoracic volume and pulmonary function, and minimizing the number of complications, procedures, hospitalization, costs, improving quality of life. And in resume, we should control the deformity of the spine while the thoracic spine grows to reach at least 18 centimeters. There are a lot of treatment methods for EOS, and the conservative treatment and surgical treatment, and we're gonna talk about the growing systems, specifically the thoracic, the growing rods, and we have two kinds of growing rods: traditional growing rods and magnetic control growing rods. The growing rods is a technique of control deformity that we make a proximal and distal foundation and connect it to a system of rods that permit a periodic lengthening of the spine through a tandem connector or dominoes without touching the thoracic cage. And the problem is very beautiful, the idea, but the problem is the growing rods, traditional growing rods, they keep functioning until the seventh lengthening or 3 years after the index surgery, because after that there is a stiffness of the spine, avoiding further lengthenings. And there are also a lot of complications considering rod breakage, ankle pullout, migration, PJK, infection, and whatever. So the index of complications is very high. And we also have to consider the psychosocial effects of repetitive surgeries in children because of the psychological effects. And we know that general anesthesia repeated may cause problems in neurocognitive effects in these children. So to avoid complications, we know that we should delay as much as possible the index surgery, and we should use dual rods and submuscular rods, and we should also limit the number of lengthenings. The other type of growing rods is the magnetic controlled growing rod. This is a technique that uses external device to lengthen an internal device that it's possible to make it by lengthening without anesthesia, and we use fewer planned surgeries and causing less psychosocial stress. But it's very expensive. This is a patient using a magnetic control growing rod of Dr. Akbarnia. The magnetic control growing rod presents similar results to traditional growing rods, considering regarding spinal length, correction, and number of lengthening, parents' satisfaction, with less cost if we consider the whole treatment and fewer complications. But it also has complications related to the system, with which balance both techniques. The comparing traditional to magnetic control growing rod, they were equivalent regarding correction, growing, and unplanned surgeries. But traditional growing rod had increased risk of complications, 3 times more surgeries because of the planned lengthens. And the cost effectiveness, the magnetic control growing rod reached the cost of traditional growing rod in this paper at 3 years, and in this paper at 6 years after index surgery. The magnetic control growing rods, however, has some contraindications like stiffer curves, hyperkyphosis, short stature because of you need space to insert the device for lengthening, behavioral issues, children who need MRI monitoring like spinal cord tumors, and pacemakers, obese, and skinny patients. And we already know that definitive fusion after 8 to 10 years old is the best technique and avoid all the problems with the growing systems. So we don't know where we are in the Scott's parabola about the indications for growing rods, but we know that growing rods, the current indications for growing rods are when cast and bracing have failed or are not indicated for progressive curves that are more than 70 degrees. And the appropriate age is after 5 to 6 years old. And when the patient reaches 9 to 10 years old, we should consider the final fusion. And we should use dual submuscular rods. And the question is to choose between traditional or magnetic growing rod. And the goal is to reach the thoracic spine height at least 18 centimeters. Thank you.
Thank you very much. Ну, это была последняя презентация. Всех хотел поблагодарить. Всех стойких оловянных солдатиков, кто досидели до конца, без перерыва. Вот. Что? Ну, к сожалению, первая часть затянулась. Самое главное, что мы закончили вовремя. Renata, maybe you say some words for third BRICS meeting because you are only one from Brazilian Spine Society Association.
I'd like to thank those present for their participation through this day in this session of the BRICS Spine meeting. Even without time for a break, despite so many hours. This event has already reached maturity and is on the way to becoming permanent in our calendars. As far as Brazilians are concerned, we will spare no efforts to contribute for the success of this group. I hope to see you in Brazil in future. Thank you.
Он всех ждет в Бразилии, кто не понял. Спасибо. Хотел сказать, кто скажет, что в России в изоляции, честно, я как-то в это не верю. Спасибо всем.